Дорогие коллеги, может, зайдем в зал, да, и начнем, если это возможно. Уже время. Excuse me, I'd like to invite our speakers to sit there. Дорогие коллеги, пожалуйста.
Dear colleagues, please come inside the room. We're about to start.
Марко. Добрый день, уважаемые.
Good morning, dear colleagues, dear participants of the conference. We're happy to welcome you at our conference, Health Technology Assessment as a tool to determine priorities for healthcare development and funding. It is already our second conference. You know that the first one took place in 2022. We had a very fruitful conference. And this current conference will happen over 2 days. So we believe that it will also be as effective, as productive as the previous one. Now I would like to give the floor for the welcoming remarks to the first Vice Minister of Healthcare, Mr. Timur Sultangaziev. Good morning, dear colleagues, dear participants of the conference. Please allow me to welcome you here on behalf of the Ministry of Healthcare of Republic of Kazakhstan. And personally, I would like to welcome you here at this International Scientific Practical Conference on Assessment of Healthcare. The topic of today's conference is of great relevance, and I am sure it will also contribute to the increase in quality of healthcare services as well as access to the innovative technologies. In all the developed countries of the world, health technology assessment is recognized as an important tool to develop the policy of healthcare, which is first and foremost aimed at popularizing the individual targeted healthcare provision. Health technology assessment provides objective information to the decision-making people and allows to reach the optimal results within the available resources, following the principle of everyone being equal for the healthcare services provided. In Kazakhstan, health technology assessment was introduced in Kazakhstan within the World Bank project with the Republic of Kazakhstan, and since the introduction of this concept, over 500 different assessment of surgical interventions on diagnostic treatments were carried out based on the evidence-based medicine. In Kazakhstan, the Kazakhstani national medication formulary was developed, and over 110,000 clinical protocols of diagnostic and treatment were developed. These activities allowed us to standardize the medical care, increase the availability and quality of medical services, as well as rationally use budgetary funds. And as for the population can get evidence-based technology. As of today, Kazakhstan has a successful experience in the HTA area, and it is an institutional member of different organizations such as ISPOR, HCIA, INHTA. The goal of today's event is to widely introduce the HTA into the practice, which will increase the availability of effective ways of diagnostic and treatment of different diseases. It is also considered as an element to reduce the state expenses. HTA gives a possibility to make decisions based on objective information, on the results of the scientific research and study, and not only based on the opinion or preferences or interest of some experts. I would like to express my gratitude to all the participants, to all the speakers, those who traveled so far to come here to exchange the experience at this conference, to discuss the new vision on HTA. Dear friends, I wish you all fruitful work, a strengthening of scientific and practical ties, and development of new steps for the work for the benefit of all. Thank you. So, to continue on the HTA role, I would like to give the floor to Alexander Kostyuk. Please, the floor is yours. Dear participants of today's conference, who are gathered here today, this is the third international conference that is held in Kazakhstan, in Astana, on HTA. Here we have experts who are committed to this approach that is promoted by the HTA, mean well-balanced and weighted decision based on clinical and financial reasons. What we have right now in Kazakhstan, as far as the HTA is concerned, and we should say that it doesn't have that long of a history of development, just 15 years, we should say that the results are at least satisfactory, but the future development of HTA in our country is extremely important in order to increase effectiveness and efficiency of the medical services in general, because HTA is a tool that helps us reaching best results for health of our patients within the existing financial resources of healthcare system. HTA is an equally important tool for the countries with the high level of economy, with the middle-income countries, and other countries. We have our colleagues who join us here personally or online. We have people from Central Asia, from Caucasus, from Central Europe. I believe that the similarity of the economic development of these countries creates a great platform for the future cooperation and partnership in the area of HTA. Based on the resources of the healthcare system, we have similar approaches in different areas when it comes to different packages of the medical care provided to the population. And I believe we should do our best to exchange our experience and our opinion on HTA in different countries. It goes without saying that every countries are different stages of development. Some are just taking their first steps, some are maybe only thinking about HTA. But when we talk about HTA, it is something that the time dictates to us. And I believe that the successes that we see pertaining to HTA that are reached by those countries that introduced HTA the first are a great example to those countries that haven't introduced HTA yet. And all of that will make medical care more accessible and more qualitative. I believe that we will have a very interesting, very fruitful agenda today. And we hope that all the participants will be active in the discussions. And I would like to thank the Ministry of Healthcare and specifically Mr. Timur, Mr. Vice Minister, for consistent support of our work by the Ministry of Healthcare and specifically for the participation in this event. Without the support of Ministry of Healthcare, this conference wouldn't be possible. And I hope that our work will be productive and effective. Thank you for your attention. Thank you. We thank the Ministry of Healthcare and other participants, other stakeholders in HTA.
Welcome speech will for the giving the head of the country office of WHO, Sekundar Sila, please.
Good morning to everyone. Honorable Vice Minister Timur Sultangaziev, dear Alexander, respected participants, ladies and gentlemen. It's a great honor and privilege for me to address you today on this so important and very important event on behalf of World Health Organization. The event today underscores a critical reality facing health and care systems worldwide, a pressing need to optimize resource allocation to meet evolving healthcare needs in different countries. Healthcare systems across the world struggle with insufficiency of resources, either human resources for health, but also financial resources, because in today's complex and geopolitical world, the resources are allocated to different fields, not only to health. This is the case in OECD countries and member states, where the current health expenditure in averaging at almost 14% of GDP. And of course, this is the case of Kazakhstan as well, where the healthcare expenditure as share of GDP is much lower. Demographic and epidemiology shifts are posing strain on our healthcare resources and workforce as well. Medicines and other healthcare technologies place an overgrowing burden on healthcare budgets across many countries of the world that can affect sustainably but also essentially of health system financing. Moreover, the impact of new intervention and technologies on health and implications for health systems are not always clear, and not always the investments are based on the best scientific and evidence-based. This is a race to universal health coverage, which cannot be won without comprehensive measures ensuring care efficiency. In the world where we have scarce of the resources should be used in efficient, effective way and to optimize them in the best possible way. This is indeed the point when health technology assessment emerged as the vital tool offering a systematic approach to evaluate, but also to the value and impact of healthcare technologies and interventions. It can be applied in many areas, to medical devices, to medicines, vaccines, procedures, health services, but also public health interventions and even to digital health tools, which are today in the globalized world used more and more. Reaching a fair and efficient outcome requires a multidisciplinary process to evaluate the social, economic, organizational, and ethical aspects of health intervention, of health technology. Kazakhstan indeed has put significant efforts in establishing evidence-based approaches to ensure proper guidance and support for clinical and policy decision-making, which is crucial and of paramount importance. This also includes the introduction of HTA. From World Health Organization side, we have been working closely with Ministry of Health of Kazakhstan to support evidence-based practical from different angles. The first, from the quality and availability of health data to the design of the national knowledge translation platform, but also from implementing evidence-based infection prevention and control system to support in developing the refining clinical guidelines. Why I'm mentioning infection prevention and control? Because today, antimicrobial resistance is one of the major public health problems that the world is facing and maybe will be the future long-term pandemic that countries will be facing, and we don't want to come to the era in which antibiotics cannot treat even banal infections. That's why our focus will continue in future also in addressing this very important issue. In closing, once again, I urge each of you to actively engage in discussion, share your experiences, and forge collaboration. Together, let's harness the power of HTA to navigate the complexities of modern healthcare systems and build also a resilient and responsive system that prioritizes quality, equity, and sustainability. Once again, thank you, Alexander, for inviting me to this important event and wishing to all participants who are present today, but also those that are attending online, a very fruitful and successful event. Kop rahmet, spasiba большое. Thank you very much.
Rabia Suku, please.
Thank you. Ladies and gentlemen, esteemed colleagues, it's with great pleasure that I would like to introduce this critical event today. My name is Rabia Sucu, and I'm the president of Health Technology Assessment International, HTAI. As many of you already know, HTAI is the global scientific society that promotes the understanding and use of HTA worldwide. As HTAI, we are very happy to support today's conference in Astana today, and I have to say I'm very happy to be here for a third time in my life, and it's always a fun to be here. I would like to thank the organizers, especially Alexander Kostyuk and Ali Malmadi, to give us the opportunity to involve in, sorry about that, in agenda building, having discussions around topics to be covered, and speakers to be invited. Forgive my jet lag, by the way. Overall, the program, you will see that our leading members in HTAI will be contributing to the discussions throughout the conference. HTAI's mission is to foster communication, collaboration, and education in the field of HTA. We provide a platform for professionals from various disciplines to exchange knowledge, share best practices, and contribute to advancing HTA methodologies. The impact of what we do extends far beyond the realm of research. It has the power to shape healthcare policies, influence decision-making processes, and drive the adoption of evidence-based practices on a global scale. This transformative potential aimed at benefiting patients and healthcare systems is what inspires us in our work, and we hope we will inspire you as well. In HTAI, our largest event is the HTAI annual meeting, which brings together experts, policymakers, researchers, and all kinds of stakeholders every June to discuss cutting-edge developments in HTA, share research findings, and explore innovative approaches. In about 2 months from now, in June, our annual meeting will be held in Sevilla, Spain, focusing on sustainability, networks, and innovation, and I strongly invite all of you to attend. We have other initiatives in HTAI that privilege our international multidisciplinary, multi-stakeholder membership base. These are policy forums where we bring together very key stakeholders to discuss especially emerging issues in HTA area. And we have the global policy forum. We have one in Asia Pacific and another one in Latin America. And we have regional meetings which are convened in specific areas and co-designed together with the local hosts and their strong support and contribution. Previously, we had regional meetings in Accra City, Ghana, virtually in Ukraine, in person in Baku, Azerbaijan, and soon to be in Cartagena, Colombia. So we try to be present in different continents. And we are happy to support the regional meeting today that's realized in Astana. We have quite good presence in Eastern Europe and Central Asia. Since 2020, we had 2 regional meetings in this region, specifically in Ukraine and in Azerbaijan. And we focus on regions' emerging HTA landscape and aim to offer HTA education and training to bring expertise and increase capacity in the region. I want to add that we are very honored and proud to be here again in Kazakhstan. We also collaborate very closely with WHO and engaged in their activities in Balkans and Central Asia over several years. In HTAI, we firmly believe we can make a difference, and we do make the difference. We play a pivotal role in shaping healthcare decisions and policies. If HTA is your thing, HTAI is the place to be. So I encourage all of you to be our members, to further your contribution to the field together with us. And today, I wish you a very fruitful meeting with lots of rich discussions. And let's hope we will discuss together today what is the reality of today in the HTA field and what we can do together to improve HTA in this region. And now I have the privilege to chair the first session, and we have very distinguished speakers for today. So I will start introducing the panel. So we'll have 4 speakers, including myself. So I'll start my presentation on unmet needs, and then we will have Lou Garrison, Anne Single, and Marco Marchetti giving us different perspectives. And this session today, this first one, will be using HTA for funding decisions and universal health coverage. So I'll kindly ask my colleagues to reflect my presentation. So I will start with unmet needs. Okay, thank you. Can I move the slides myself, or? Okay, thank you. So let me see how this works. And this one, okay. Thank you. So I'll focus on unmet need today, because today's discussion, we will have a lot of different angles to be covered. But I'm sure from the start that we will hear a lot about unmet needs, and are we covering unmet needs while we are making our decisions, and how we can do that. But the issue I want to discuss today, rather than giving you methodological examples, when I was reviewing my presentation, I realized there's so much around the definition of unmet needs. And I want to start with the question, do we really understand the same thing when we say unmet need? Unmet need in itself in English, or even if you translate it to any language, it seems so straightforward and understandable, and I'll challenge that a little bit in my next slides. So by definition, if you look at the dictionaries, you will see that the need as a verb is requiring something because it is essential or very important. And as a noun, it defines it like circumstances in which something is necessary or that requires some course of action or necessity. So it seems easy to understand, and unmet means not satisfied. So if we collect it like unmet need, we can define it as non-satisfied circumstances in which something is necessary, or we can define it as an essential or very important requirement is not satisfied. The question here is, do we really understand everything here in the definition? Is it so clear? Or can we continue the discussion like what is essential, or who defines what is essential? Who defines what is very important? Is it clear enough? And how do we define necessity? And for whom? Because we talk about requiring something, it's very important, but can we say that it's equally important for every single person or every single population? So it means within the definition, we need to extend it towards the question for whom we are talking about the unmet needs and which circumstances. We say that we need a course of action, but what is the course of action? Who defines that and how it is defined? And finally, we talk about satisfaction of the needs. But can we really measure that satisfaction? There may be different research methods how we look into the needs in healthcare. One is the health needs assessment. It is a process of determining the health and healthcare needs of any given population or subgroup in an area. And why do we want to do this type of research? Because we want to make decisions around resource allocation or priority setting, or if we design in a program, how we define those programs and how we evaluate them. The examples we can give here, when we talk about unmet needs in HTA, we focus on specific interventions. That's what we understand immediately. But actually in the healthcare, we talk about population needs as well. And that could be simply an example like the shortage of healthcare providers, or needs of the communicable diseases, for example. They may be increased prevalence of communicable diseases. Or we could consider poor environmental health as one of the priorities and one of the needs in the population. But if we look at specific conditions, some examples could be like rare diseases or tropical diseases, or antibiotic resistance in itself can be considered as a priority situation. And the question here again comes, whose needs? Because when we look into needs assessment research, and this type of assessment, it includes in the definition in a given population, which means we need to focus on whose needs. And here, two important aspects we need to emphasize. The first one is context. It's very important because all of these change depending on where you are and who you're dealing with. And in order to define all of these, we definitely need to involve patients and citizens who are representing that specific population. We can also talk about different types of needs. When we look into literature, we can see 4 types of needs that can be considered in needs assessments. The first one is normative, so we can simply have a vision of health and we can define our needs with that, relating it to our vision. The second one could be comparative. We can simply compare ourselves with the determinants of health in other settings, like comparing OECD countries, for example. Or it could be expressed needs. Expressed needs are usually collected from like key informants through interviews or surveys or directly engaging with advocacy groups. And these ones put in front of us what actions actually you may need because they do express their needs very clearly. But there's also the felt need. Felt need is a little bit different because these are the ones or attitudes related to personal or the community's vision of health. So this can be very different. For example, a university student, young girl, after school going home, does she really feel safe walking alone at night? So this could be simply a need that she may prioritize, and we may not even think about it, but this is the felt need she has. And for all of these, as we mentioned, context matters. But there are also ethical aspects, because in the definition, we sometimes replace each other like medical need and health need, but is it really the same thing? According to Ben Davis in a recent article in Medical Ethics, Clinical Ethics, he actually differs them, like health needs are needs that relate directly to health condition, but medical needs, on the other hand, has relation to medical institutions or medical interventions or processes. So basically, when you have a health need, it doesn't necessarily mean you need a medical intervention. On the other hand, you may need a medical intervention or you interact with a medical facility, although you may not necessarily have a health need. So these are two different things, although there's significant overlap. For example, contraceptive methods. These are like healthy people. These are not directly health condition, but on the other hand, indirectly it has health implications. And these procedures such as vasectomy has to be done in a medical facility. The other example could be your teenager child who is shy and you want to take your child to a psychotherapy or a psychologist, or you have issues in your marriage or couple therapy. So these are not like health conditions, but these still require medical interventions. The question here is the ethical aspect, but also the political side of the decision-making, how we differ all of these things from each other, and how we prioritize them to be included in insurance or coverage decisions. So can we really do it straightforward? The main question raises here is, because the term is vague, there may be issues that these will be understood differently by patient groups or different individuals or different policymakers, and then there may be inconsistency or injustice in the final decision making. In healthcare, in general, the need in healthcare is defined as the capacity to benefit. It means if you have a health need, it's identified, then you expect there's an effective intervention should be available to meet these needs and improve health, but which is not always the case because there are not always available interventions for that. So when these are unmet, the only concern we do is not make this available or accessible, but actually go back to even the research and development process and to provide incentives to do that. Here, when we are looking into all of these, we need to see that there should be a balance in healthcare system between demand, need, and supply. Because normally we expect there's the demand and the supply of healthcare services or any equipment or intervention needs to be coordinated depending on the demand, but the demand may not necessarily reflect the needs. So the issue here is, in the healthcare system, we need to make sure that we keep a balance of all the three. So we do focus so much on the definition. Why? Because it is important. It's important to define what is the unmet need or the needs in the first place, because all of these are needed to make some decisions. So basically, we want to understand unmet need to determine health policy significance of anything in front of us. And the decisions that may be impacted are within the regulatory HTA pricing and reimbursement processes. We may simply go for early access schemes in the regulatory space if we feel a technology may be addressing an unmet needs, or we can go for a conditional marketing authorization, or we can simply accelerate HTA process for assessment, or if needed, we may play with our thresholds for cost-effectiveness thresholds for coverage decisions, or we may have innovative payment models for reimbursement. But in order to do that, we first may go to the definition and understand what is the unmet needs. Or we can simply go out of these processes and go back to research and development and create incentives to increase our guidance on development and incentivize manufacturers. Also, we may simply regulate or prioritize our research funds to the innovators who work in this area. FDA has a very general definition of unmet need, which is a condition or symptom whose treatment or diagnosis is not addressed adequately by available therapy. So this doesn't narrow us to a certain disease group. But on the other hand, EMEA has a different type of definition, and they do label unmet need when it treats a life-threatening or severely debilitating condition where there's either no treatment or there's treatment but it's considered unsatisfactory, and it produces meaningful reduction in morbidity and mortality. For the high unmet need, it is for rare diseases where no treatment exists or anything we talk about, it has exceptional therapeutic advancement. The issue with this definition is, again, it's a little bit loose because meaningful positive impact, what is the meaningful and how we quantify it, is still something to be addressed. And we know that when you have the label, you have certain benefits, like you are secure from competitiveness for between something like 6 months to 1 year if you have that label. The industry, of course, has some concerns. I'll not go into patient concerns because we have another colleague to speak on that. But for industry concerns, it's usually around the complexity, because this adds one more step to evaluation, so it may add up to the complexity. But also some concerns are we really, with this idea of unmet need and narrowing it to very strict conditions, are we incentivizing them only that produce this, or are we kind of disincentivize the ones that are targeting other parts of the treatment or diagnosis of different conditions, such as diabetes, for example? There may be unmet needs around diabetes as well, but are we simply disincentivizing that area? And the risk is, if we label the first comer, then what is going to happen to the rest of the industry who has been working on R&D for so many years, and they may not know when they are going to be in the market, and they may actually lose the market from the start because they are not labeled first. But let's say if everything is well defined, we understand what's unmet needs and we can define it. Still, there's the question, can we really quantify it? And how do we quantify? Well, some authors talk about three main elements, which are about the patient population, as we know, the disease severity, and alternative treatment. So for each one of these, they do talk about different ways of quantifying, such as number of available alternatives, number of accessible technologies or benefits over different alternatives, or we can go into severity of disease, the burden of disease, etc. So there can be different criteria to take into account, and some of them can easily be quantified. The issue here is, again, depending on the perspective of which stakeholder we are talking about, the need will differ, and the criteria you may look may be differ, and how you quantify them may differ. So it's extremely important which perspective we take in all of this. I'll give just one example to how this was done in one of the countries. In Belgium, Unmet Needs Commission, they used MCDA, multi-criteria decision analysis, to identify what are the needs and what criteria could be used, and they did quantify it through MCDA. And they did focus on two types of need, therapeutic need and societal needs. And for therapeutic needs, they used three criteria: impact of the condition on quality of life, on life expectancy, and inconvenience of current treatment. And for societal need, condition-related expenditures, because the patient population may be vulnerable due to out-of-pocket expenses, and the prevalence they used. And they did, they thought it was appropriate to use these both need types, and MCDA was useful according to their experience. I want to just conclude my presentation here to emphasize one more is there are still debates around how we define unmet need and what type of conditions we include into that. And as long as we use very narrow and loose definitions, there's a huge risk to lose attention to broader therapeutic areas. And there may be inconsistent and unfair approaches if the definition is not clear. The second issue, maybe more common for low and middle income countries, is there is the accessibility issue, not only about availability. So an intervention may be available elsewhere, but if it's not accessible for you, your need is about accessibility, not availability. And it's mostly common in low and middle income countries. And the methods to quantify, as I mentioned, is limited. There are good examples and there's so much work around it, but still it needs to be improved. Everything should be connected to value framework we work on. And sometimes when we define the value, we do include unmet needs in one of them, but we may include like disease severity separately. And this means that because severity is included in the unmet need definition, so you may simply double count some of the criteria you use, which we need to be very careful. But very important here is context matters and stakeholder engagement matters. So unmet need is not something you can import or export, which we do a lot. So unmet need that is communicated by different populations, different settings with different healthcare level development or different access in their setting, different coverage through insurance. If we import the list of unmet need from those settings, unfortunately, it may not necessarily address our needs. So we have to be very careful and we have to focus on our own context and understand what is the need here and what is the unmet needs here where we live and where we work. And for doing that, we definitely need patient engagement. Thank you so much for your patience. I'll stop here. We have another presenter who will talk about patient engagement, so I'll leave it here. Thank you. So now I would like to invite to the stage our next speaker, who will be Lou Garrison. Professor Lou Garrison, he is, let me see my notes. Well, everybody knows Lou, but just to give a proper introduction, he's from School of Pharmacy, University of Washington, but also representing global health economics from Seattle, USA, and he's one of the past presidents of his board. So Lou, please, the stage is yours.
Good morning. Thanks so much for the, let me thank the organizers and sponsors for the invitation, and to Alexander and Alima in particular. I started working 3 years ago with Alima when she was a postdoc in the US. Alexander contacted me, and and 2 years ago I did the virtual meeting. But my body clock is 12 hours different. So right now it's like 9 o'clock in the evening in Seattle, where I'm from. And I did it at midnight, I think. I was trying to zoom in. It was a challenge. So it's so nice to be here for the first time and to experience your hospitality that you're famous for here. So let me say a bit about my background. I've been doing this a long time. I was in an NGO from 1979 to 1992. And so I worked on hospitals and doctors and some of the broader things that Rabia was talking about. Then I transitioned to industry. I worked for Roche Pharmaceuticals for 12 years. So then I kind of switched from doctors and hospitals more to focus on medicines. And these days, when you're listening to me, I'm mostly thinking about access to medicines, innovative medicines, and prices for them. So I worked on that, and then I became an academic in 2004, and I've been doing this for 20 years from an academic point of view. So you will get the professor talking about academics. So Rabia has made us very clear how complicated unmet medical need is. But to the economists, we try to simplify things. Okay, so I will give you my simplified view. So I want to just give a general introduction to economics. All of you have probably had some of it. And then try to take you to what I see as some of the cutting edge issues. Okay, so first I'm going to say we need a broader concept of value. Rabia talked about value frameworks. I will talk about a particular value framework. We've also heard that I think the economist's favorite word is efficient. We want to do things efficiently. We want to minimize costs. We want to maximize outcomes. We don't know what is equitable and fair. That's a much broader question that Rabia was talking about. But we know that the information is a global public good. You know, how a drug works, who benefits from it, is something we all can benefit, everyone on Earth. So it's what we call a global public good. So we want to promote global information sharing. So I can talk about hospitals and doctors in the US, but Kazakhstan has to make their own decisions about how many doctors do they train, what facilities. But when we talk about medicines, we all can potentially benefit from medicines and vaccines and other technologies. And so then we think globally. So we're also moving away from a narrow definition of health, which I'll talk about, that we use, to, I think, a broader definition, what people call well-being or global health. So we're not maximizing just our health. We're not just we want to have happiness. We want to have happiness over our lives. So that's what we're talking about. This goes back to, I started doing I was a TA in a class in 1974, so I've been doing this almost 50 years, okay? And this is a book from my professor. In the economics there are three basic principles, right? We have resources are scarce, they have many uses, and human needs and wants are infinite, okay? So we have to make decisions. Now, the romantic person thinks we can solve the problem. But the fundamental problem is, no matter how many resources you have, we have limited time. You can't do three things at one time, and you only have one lifetime. So no matter how we distribute things, we always have scarcity to deal with. Now, this is my dissertation advisor, Victor Fuchs. He was, I can remember in 1975, there was a conference. Maybe there were 50 economists in the whole world, health economists. ISPOR has 20,000 members. HTA has thousands of members as well. And here we are in Kazakhstan talking about health economics. Now, so Victor died last year at age 99. He published an article in the New England Journal of Medicine at age 98. I think he will have the record for that. He shows this curve, and that curve is GDP, share of GDP in America. We're at 18%, when the rest of the world is 12%. So, and this is his famous book that he wrote, and he's revised before he died. Now, we have these jokes in economics that are, you might be an economist if, okay? Now, You might be an economist if you see a $10 bill on the street and you don't pick it up. Because if it were a real $10 bill, someone would have already picked it up. In other words, the market works, and we believe the market works. So that's kind of the basic thinking of the economists. Now, what is the basic rule of economics? And when we talk about cost-effectiveness analysis, this is the underlying rule. We compare the benefits of the intervention with the costs, marginal benefit and marginal costs. And if you've seen the basic demand and supply diagram, you see what does a perfect market do? Perfect market, you don't have any influential people, you have many suppliers, you end up with a price that's an efficient price, okay? And who decides the price? The marginal person. You know, it's not the whole demand curve, it's that person. So the person who will switch from the BMW to the Toyota, they decide the price. So that person is key in economics, the marginal person. And in theory, if we had perfect markets, things work well. But in reality, we don't have perfect markets. We have what we call market failures. One of the most important ones is public goods. Information is a public good, how a drug works, who benefits from it. We can all benefit from that. So that's a public good. So everybody has a stake in that. Externalities are like infectious diseases. So if I'm infected, I can infect you. So it's not just my own consumption. Sometimes there are natural monopolies. So you need to have academic hospitals. And then informational asymmetry can lead to market failure. And that's because, say, the doctor and the patient have different information. The doctor is the expert on the treatment. The patient is the expert on their own preferences. So they're trying to communicate. But the last one I'll talk a lot about is uncertainty. And I think of uncertainty as I have a model of the world with parameters, and I have distributions around those parameters. That's my uncertainty. I don't know exactly what those relationships are, and I'm trying to make investments to reduce that uncertainty. So, Talcott, please tell me when I have 2 minutes to go, because I'm losing track of time, okay? So, anyway, so this paper was written 60 years ago. It was the most famous paper in economics, probably. Kenneth Arrow wrote a paper. Actually, Victor Fuchs asked him to write the paper. He received the Nobel Prize in economics. And basically what he said, when you look at the healthcare sector, the way that the institutions we've developed, like regulation, certification of doctors, insurance, they're all dealing with uncertainty. So that's the key concept in this field, and you can think about these institutions for that reason. Okay, so we call market failures. How do we address market failures? What do? We bring government. So if we don't have enough investment in science, we finance it. But at least speaking from American perspective, we also need to think about government failures, okay? Don't just think that only the market fails. Government fails. America made an agreement with Iran, and what happened? We changed administrations, we changed the agreement. So those are government failures. So government's also a problem. Okay, so from an economic perspective, what is the value of something? The value is what someone's willing to pay. We observe that in markets, or what you have to give up to get something. We call that the opportunity cost. The challenge in estimating value is my value is different than your value. My value changes over time. There's not one unique value. And because of insurance, it's very difficult to measure in healthcare. We're not in markets. We're all buying with government with our own insurance dollars. Now, if the question ideally I would ask you, so when you're 20 years old, I might say to you, okay, suppose you might need a heart transplant in your life, in your lifetime, over the next 70 years. How much would you be willing to pay in taxes or premiums per month over the next 70 years? And that number is so tiny that you can't answer the question. So we can't really use that as a way to do it. So instead, we've developed a methodology around the life year, the quality-adjusted life year, and I'll talk about that. But economic value, there are three basic components. Number one is, do you save me money? You know, could you reduce my cost of care? Can you extend my life? Life years gain. So if I have two medicines and one extends my life more, I would pay more for that. I would say that's more valuable. And that's the fundamental principle of the quality-adjusted life year. But then we say, well, there's more to life than length of life. There's also quality of life. So what do? We combine that into a metric called the quality-adjusted life year. And then we can compare a diabetes drug with a vaccine and other things to prioritize our investments. So this is not showing up properly. It's supposed to be a build. But okay, so this is an example of the quality-adjusted life year. And if you look at the purple area, you can think of this is the lifespan, and this is the quality of life on a 0 to 1. And imagine that the base case is the purple area where a person is sick, and they get sick in A, B, and C, and they recover. And at the end of life, they need an intervention, and then they gain the area under that curve. Now, what we're trying to do, people call it rectangularization. What we'd like to do, the lifespan, suppose your lifespan was 90 years. We would like you to have perfect health every year over the 90 years. But we have a shortfall. We don't get that. And so you would say one definition of the unmet need, if you accept this framework, it's the area A plus B plus C plus D. That is the unmet need. It's the quality shortfall. So it's the years of life you've lost and the quality of life you've lost. So that's one way that economists try to measure unmet need. Now, basically, again, the value is, you say, well, what would I be willing to pay? Well, if I save money, cost savings is important, length of life and quality of life, and we combine that into a metric called the cost per quality adjusted life year gain. So how much does it cost me to gain 1 year of perfect health? So our metric is a healthy year. How much are we willing to pay for a healthy year? Okay, so this HTA and HTA had a very productive interaction to come up with this definition of health technology assessment. And I think that I was not on that group, but I think they did a great job bringing out equity, efficiency, and high quality, and also thinking about the value over the life cycle of the product. And again, I'm talking about pharmaceuticals, and I would say the cutting edge thinking is we're thinking about the product over the entire life cycle, not just at launch. We have to negotiate the price at launch, but at launch we have very limited information. And different countries have approached it differently. We have some that rely on the QALY, in particular the United Kingdom, and in the US we use the QALY to measure things. It's a measurement tool. Australia and France use some of the metrics, but they don't have a threshold. They don't say, like in the US, we say, we're willing to spend, say $100,000 for a healthy life year. So if you come to me with a medicine that gives me a life year, I will pay you $100,000. In the UK, they say 20,000 pounds or 30,000 pounds. Not every country works with an explicit threshold. The Germans do a different process. They focus on clinical data, and then they negotiate. We're all looking at the same clinical data. That's the underlying clinical data. The question is, how do we interpret it? Now, again, the other point I wanted to make, okay, it's okay to think about life years and the quality. That is the basis of what health economists have been using and for measuring shortfalls and disease burden and value. But it's not everything in life. There's also other dimensions, and I think we're really thinking about well-being. And I think this goes back to, and I think this is a recent development in our field. And I would just say, in the field, we kind of have two schools of thought. We have the role of society is utilitarianism. We're trying to maximize well-being of everybody. So each of us have a utility function, a happiness function. We're trying to maximize that. Another approach would be what's called the extra welfarist approach, which might be the British approach, we would say, where you have a fixed budget and you're just trying to maximize qualities, not necessarily happiness, just qualities. And so that's a big debate. And I think we're moving towards a thinking of value to reflect other things. So this is a result of an effort we had at ISPOR that led to what this is called the ISPOR value flower. And at 12 o'clock and 1 o'clock, that is conventional cost effectiveness analysis. You can see that you have the quality, the length of life, and quality of life. You go to 1 o'clock, that's net costs. Net costs and the quality gives you the cost effectiveness ratio. But then you say, wait, there's more to life than that. There's productivity. That's at 2 o'clock. Let's take account of societal effects. There's family spillovers. You know, if your grandmother has Alzheimer's disease, you're worse off. It's not just your grandmother. But as we start to go around that, I won't go into each of these petals of the flower, but they're dealing with uncertainty. And the first one there is called the value of knowing. What's the value of a diagnostic? It helps you to know that you're going to benefit. How do we value that? That's not in the quality. The other one is called insurance value, and that's the one that I would emphasize as the most important, but we also talk about real option value. So if you extend your life, if I extend your life through an intervention and new medicines come, you can benefit from that. That's real option value. Sometimes there's the value of hope. People are willing to take a gamble to get a longer life. So our field is working on quantifying all those different other dimensions that are not just the quality, and they have to do with value. So to me, the most important one is, let me just illustrate, with insurance value. So You know, in November of 2019, if you ask me, well, what was your quality of life? And I'm feeling pretty good in November of 2019. Pretty healthy. You know, maybe I'm a 98 on a scale of 0 to 100. Come February, I've been told that we have COVID. COVID's coming. Tens of millions of people are going to die, and we don't know who it is. And I might die in the next 4 months. I assure you that my quality of life fell, okay, dramatically. No, but not just me, but everybody on Earth. I mean, if they were rational, 8 billion people were worse off knowing that. So if we could, but once we had the vaccine, and we didn't have good prospects for a vaccine. But come September, you know, we had vaccines, we had concepts, so we all felt better off. That's insurance value. It's not just the quality, it's not just length of life and quality of life, it's the peace of mind you get from reducing uncertainty. So here's my last slide. What I've tried to do is take the WHO Universal Health Cube, and that's the below. Now, that's what we talk about universal coverage, and the value of universal coverage is you're protected financially and in your health, so you get peace of mind. The big problem in America is we have tens of millions of people who do not have universal health coverage. So they live in fear of losing all their money. Now, we have backup systems, but it's not a good thing. But I think what I'm trying to show here, well, there's more to life than just that cube. There's also this, I build this thing above it, which is the peace of mind that you get from knowing you're protected. It's not just receiving the service, it's knowing that you're protected. And that's the value of universal health coverage. And it's probably the most important, one of the important aspects of a new intervention is you now know that there's something that can protect you. So let me leave you with that thought. And I'm happy to look forward to discussion, and I'll be talking more about that this afternoon and tomorrow, if you want. So, thank you.
Thank you, Professor Lou Garrison. And we have our next speaker online. I hope our colleagues will be able to connect her. Just give me a sign, if you can. So our next speaker is Anne Single. She's joining from Australia. Yes, I see Anne on the screen. Do you hear us, Anne? Just to double check.
Yes, can you hear me all right?
Yes, we hear you very well. Welcome to our session. So I want to introduce Anne very shortly. Anne Single, she's current Vice President of Health Technology Assessment International, and she's the coordinator of Patient Voice Initiative in Australia, and also past chair of HTA Patient and Citizen Involvement Interest Group. So, Anne, I made a little bit of introduction, maybe a little bit confusing presentation on the definitions of unmet needs, but we'll be very happy to give you the floor to talk to us about your experience in patient engagement, especially when it comes to covering unmet needs. Floor is yours.
Thank you very much, Rabia, and thank you all for the invitation to join you today. I'm just going to move something on my screen so I can see a little better. That's better. Great, and hopefully you can see the slides all right. So the first thing I want to do before I begin is just declare my interests, which are listed here. And just please note that as part of my work, I do receive some money from biopharma companies. It's such an enormous pleasure to join you today. I only regret that I'm not with you in person in Astana. I join you from Brisbane, Australia, and this is the land of the Yagara and the Turrbal. So I'm going to begin by paying my respects to their elders, past, present, and emerging. And in Brisbane today, it is sunny and warm, and I hope your conference is set against spring sunshine too. But right now, I want to take you back more than 20 years to a time when I lived and worked in a place that was just not so sunny and warm. So in the early 2000s, I worked in Scotland, and it's a beautiful place. But sometimes with the heavy rain there, you can't always see the beauty. It can be hard to see. And so actually at that time, sight or people losing their vision was very much on our minds, because I was working under the leadership of Dr. Karen Facey on the very first health technology assessment for Scotland. And our topic was a national screening program for diabetic retinopathy. And at the time, Scotland had great variation in services and uptake of screening among people with diabetes. So we wanted to work out how could we have a national screening program that was clinically and cost effective and that people would use. And as part of that process, we asked the head of the Organisation for People with Diabetes to join our expert group. And we found out that there actually was some research going on in Scotland at the time, talking to people who had diabetes. And we asked our researchers if they could include a few of our questions about using diabetic retinopathy screening services. And so they did. And what we learned changed everything. We found out that people with diabetes often found the eye drops or mydriasis that was given during the screening uncomfortable and inconvenient. It blurred their vision, and sometimes for quite a few hours, meaning they couldn't drive home or go back to work. And because they had diabetes, they had so many appointments each year that took them away from work or other commitments. And so they didn't attend their screening appointments because they sort of figured that losing their vision seemed like a bit of a remote possibility, and their vision seemed fine to them. So we took this information back to our health scientists. And guess what? The statistician had seen some really interesting data that had him thinking, maybe not all patients need this mydriasis. So we had been doing our assessment on a presumption of a technology being used, and we were asking the wrong questions. We needed to start again, and we did. And we were able to go back, start again, answer the questions that we needed to answer, and then provide recommendations that not only gave us a cost-effective program, but rapidly increased the uptake of screening amongst the community with diabetes. So why am I telling you a 20-year-old story? Well, two reasons. One is because many of us get involved in health because we want to improve the outcomes for our communities, but not all the information is sitting in the scientific evidence. And health technology assessment has that capacity to bridge the evidence to policy. The knowledge of the patient community's needs and experiences and perspectives can help us build that bridge between science and our programs. And two, we can worry that patients always want the latest, most expensive healthcare. And in a way, that's true. They do want the best healthcare, but they also can help save our health systems money by making sure it's not wasted on care that's not wanted. As it turned out in the case of diabetic retinopathy screening in Scotland, it wasn't needed in most cases. So there are a lot of reasons that people involve patients and the community in health technology assessment. But for me, the critical one is relevance. Patients have knowledge, perspectives, and experiences that are unique and contribute essential evidence to our HTA. And this statement comes out of the HTAI's values and quality standards for patient involvement in HTA. It was developed through international research and experience. It's a decade old now, but it's still guiding a lot of practice. So for those of you who haven't encountered this before, I just thought I would touch on how do we access those patient experiences. And in HTAI, we have two particular ways we think of doing them. They complement each other. One is research and one is participation or engagement in health technology assessment. So research, and this is really work led by Sophie Stenevschuska and Sophie Verko with medicines with SBU in Sweden. So we do research to understand it, and it gives us evidence that can be appraised and critically assessed or peer reviewed, and it can answer some big health policy questions. And it's really clear about its limitations and any bias. So things like qualitative evidence synthesis or preference studies or patient-reported outcome measures. These give us better insights into our community's needs and experiences. And then we can also complement that by engaging our patient communities in our work. So this is a much more dynamic process. It can be more responsive to the sorts of questions that come up when you're looking at an assessment. And this might include insights from individuals or organisations. And it's really strong on local context, because in health technology assessment, we're always trying to think, what does that evidence mean for our local community? And local patients and community organisations can really help with this. We often use written submissions for this around the world, and sometimes individual committee members. And there's other ways too, but that's the most common. So just to take a pause there, what do I mean by patients? We tend to use that word to mean a wide variety of things. So sometimes when I say patients, we're talking about the people with the health condition, sometimes the people that care for them, and sometimes representatives from organisations that support or advocate for them. And who we involve tends to depend on our local community and what sort of questions we're asking. So around the world for more than 20 years, we've been gathering a lot of evidence about the sorts of things that these patients can add to health technology. Oops, sorry, I've just flipped forward. Go back again, thanks. And on this slide, I've just put a list there, which really brings together a huge amount of research done into what people doing health technology assessment learnt from patient communities. One of the key ones is it can focus discussion around outcomes that really matter or are meaningful to the patient populations. And so sometimes, that can include things like when the data might suggest that something isn't clinically significant. Occasionally, those can be things that actually in the real world can make a huge difference. And one of the areas this commonly comes up in is when a tool is measured, used to measure someone's quality of life, and it might indicate how far a person can walk. And sometimes patient communities might say to us, okay, well, walking 6 meters doesn't seem life-changing to you, but for us it is, because it means that I can take care of myself. I can go to the bathroom by myself. I can walk to a taxi and get in and travel to appointments. And so I gain independence, and those that care for me gain independence. They can help us with the comparators. There's usually a difference between what we think people are getting in terms of standard treatment in our communities, and then a variation of what people were having as standard care. And it's really useful to understand who's getting what and why before we bring new technologies in. A lot of information on quality of life doesn't come through the traditional evidence. What's the day-to-day reality of living with the condition or the burden of treatment? What are the side effects, and what benefits would communities trade for which side effects? Which are the side effects that people are willing to tolerate for benefit, and which are the ones they wouldn't? Patient communities give us a lot of knowledge there. Experience of treatments, unmet needs, how services vary and what that might mean to roll out. What are the consequences of starting and stopping with a treatment? And what are those wider non-health benefits of risk, like family members being able to return to work when a patient gains independence? And also, what does life look like in the future? What is the recovery process? How sustainable are the benefits? There's a really rich array of information we can find in our patient communities. And around the world, a lot of people doing health technology assessment use templates like this one to find out about their patient communities. The one on the screen is the one we have on the HTA website, and people adapt it to suit their language and country. But it highlights 4 key questions which are really useful for understanding need in different communities and guiding or illuminating the numbers that sit in scientific data. So what is your experience of the condition? What is your experience of existing treatment? Do you have experience of the proposed treatment, perhaps through compassionate access or a clinical trial? And if you don't, what is it that you really seek from a new treatment? And these questions have been asked in health technology assessment in different forms, really since it began. But when they're missed, there's a real risk. And so around the world, people do different things with these questions to address need. So for example, in the Philippines, they use a version of these questions to identify what sort of health technologies should they be looking at bringing in. So they identify patient communities' needs, and then they can decide if they want to do a health technology assessment on these health technologies. So patients are not just highlighting need, they're helping to prioritize by explaining what outcomes matter the most. And before I finish, I just wanted to flag that HTAI has an interest group working in this area. We have more than 300 members in 43 countries, and we publish resources to support this work, and they're on the HTAI website. And I also want to flag that our members love to share good practice in this area and particularly support places who are interested in developing these processes. And with that, I will wish you a productive and enjoyable conference, and thank you again for having me.
Thank you, Anne. Please stay with us. We may come back to you with some questions during the discussion session. So we thank Anne Singhul, and we'll move to our next speaker. I'll keep the questions at the end, so if you have questions, please keep in your mind, so we'll get back to that. So our next speaker is Marco Marchetti. He's also an HTAI board member. Marco is head of HTA unit at the Italian National Agency for Regional Healthcare Services, which is called AGENAS, and he's also co-chair of Member State Coordination Group on HTA at the European Commission. Thank you, Marco. The floor is yours.
Thanks for the invitation. It's an honor to be here. It's my first time in Kazakhstan, so it's I'm really glad to see how is the interest in HTA. And actually, I'm trying to present you a real-world my life experience that I think that probably is one of my best professional experience actually in my life, that is building a new system in Europe, trying to integrate this HTA framework in different 27 member states that have different level of maturity on HTA and also on capacity building. We have people, member state in the western part, in the eastern part of Europe, and we're trying to give an answer to some issue that has been raised this morning. The first one is how to transfer the value that is quite related to the context. And now we have this real experience, important experience, trying to make an HTA assessment at the European level, but in the meantime, not to enter in the value, the consideration that is very context related. And now, the other really, I think up to now, it's probably the unique experience all over the world is that we move from more research context activities in a legislative framework that is interesting 500 million person in Europe. And the perspectives, and the title of my speech is the integration. And actually what I bring you is the I mean, the strategic perspective of the integration starting from the European level to my national context. So I'm director of the HTA national program in Italy. So I'm trying to pass you what is the thought that we have behind the construction of this ecosystem. So actually, probably, I don't know how many of you is aware that we have a regulation in Europe that is related to HTA. Regulation is one of the primary law in Europe that is on top of the national law. So if the national law is not compliant with the regulation, national law must be adapted. And the national law, the regulation is applied both on pharma and on medical devices, on some specific category of medical devices, and with a stepwise approach on all the pharma product. And actually, in order to create an ecosystem, we trying to build a national HTA framework that is completely integrated and with the HTA regulation. HTA regulation have the objectives to create a real ecosystem in Europe with respect to the supporting the decision-making process. It's not entering into the value definition. This is quite a decision that has been taken by the legislator at the beginning, because as we discussed, and also my previous speech has pointed out the issue that value is quite related to the context is quite different. But what we would like to build in Europe and to have a common basis on which to evaluate the value. It means that we are working on mainly at the European level or the relative effectiveness and on the relative safety. This is quite different from the EMA approach, European Medicine Agency approach, that is more focused on the efficacy of the product and not in the comparison with the standard of care that is available. And all these systems have the objectives to be moved into the national context to support this national decision respect to the pricing and the reimbursement and the introduction into clinical practice. The innovation, if I can say, that we have is that member states are not obliged to adopt the what we call joint clinical assessment, but need to explain the reason because they are not adopting. This is, a first point that I would like to raise. And the second point is that member states are obliged to participate in the joint clinical assessment. So it means that they have to dedicate resources to do this assessment. We are working both on medicine and medical devices. Joint HTA work is focused on the clinical domains of the HTA, relative effectiveness, as I just mentioned, and relative safety. Now we are more than 400 people hardly working all over Europe in different HTA bodies, trying to set up the methods and procedure for the start in the operative way of the regulation. So starting from January 12 of the next year, all the ATMP, Advanced Therapy Medicine, and oncologic products that will apply to the European Medicine Agency are going under this joint clinical assessment. And with a stepwise approach, we have rare orphan drug in January 2028, and since 2030, all medicine that will go into the EMA regulatory process need to be applied also in the HTA regulation. For medical devices, we are working on the high-risk medical devices in the European level. We have a medical device regulation that distinguish high-risk medical devices in this different class risk. So we are regulation is affecting implantable medical devices, what we call class 3 of risk, and class 2B risk medical devices that are providing overlapping pharmaceutical product in the human body. So in a 6 year, in less than 5 years, the regulation is expected to be completely implemented all over Europe. And this is a huge change for, not just for Europe, but also for manufacturing industries that need to rethink how to plan their clinical study in order to be compliant with the regulation. Regulation is a quite different regulation with respect to the European standard because, as you know, regulation in Europe is managed and applied by the European Commission. In this specific case, member states have not given this delegate to the Commission, but it's the same member states that are managing the application of the regulation through a coordination group that is established by the regulation. And I have the honor to have a front seat row as a co-chair of the HTA member state coordination group to guide the implementation of this new regulation. We have the coordination group is organized in 4 different subgroups. One is on joint clinical assessment, joint scientific consultation, methodological procedure, and emerging technology. And the Commission is providing financial support, technical support, administrative issue support. Just before I've talked about the patient involvement, now regulation foresee a quite huge stakeholder involvement, not just patients, but all different stakeholders that are interested in this field. Stakeholder networks be set up by the regulation. 72 different organizations have applied to the call of the European Commission in December 2002. 42 organizations were selected, and we have had in the last year 2 different meetings. Stakeholder network is the place in which we discuss with the stakeholder the process and of the methods how to implement the regulation. Coordination group is the real strategic body of the regulation that have different responsibility to define the annual work program, the strategic direction for the work, adopt methodological guidance. We just published the last March 13, the first guidance on direct and indirect comparison, coordinate and approve the work of the subgroup, ensure the cooperation with the relevant union-level body, that is mean principally European Medicine Agency and for obviously European Commission, because what we would create in Europe is a really interconnected system among all different institutions, both at the European level and both at the member state level. And also to ensure appropriate involvement of stakeholder organization and expert during the work, joint work. I mean, just give you an example, we have this year, we passed the last year, and we will pass this year trying to prepare the implementation. We are guidance, methodological procedure that will be approved and adopted by the coordination group. As I just mentioned, the first one has been adopted in the last March, direct and indirect comparison. We have also activated a specific article of the regulation, that is Article 23, that foresee that member state, if there is their interest, would have the capability to work also on other technologies that are not mandatory by the regulation. We discuss to activate this voluntary cooperation on these different fields, digital medical devices, cost-effectiveness analysis, real-world data. And we are now in the phase to trying to plan how to implement, to start with this voluntary cooperation beyond obviously the mandatory work. So just to give a list of the guidance and guidelines that are under the preparation that need to be approved and adopted by the coordination group, to give you an idea how this will have an impact on the process in Europe, both for regulation and both for the technology assessment and pricing reimbursement system in different member states. Then we have on the road different implementing act. The implementing act has a tertiary legislation of the European Union that establish by law specific timing procedure for the joint work. We have an implementing act on joint clinical assessment of medicinal product that has been just published. Public consultation has been concluded. Now we have in plan to approve this implementing act at the end of this month, or maximum the beginning of May. And then we have other implementing acts that are also drafted: prevention of conflict of interest, cooperation and exchange of information with the EMA, and other implementing acts that will be drafted before the summer. Joint clinical assessment, procedural rules for joint scientific consultation on medicinal product, procedural rules for joint clinical medical devices and HTA2024KZ, procedural rules for joint scientific consultation on medical devices. All these implementing acts need to be approved before December of this year in order to go into the operation in the next January. So just to give you an idea of how the process is really interconnected, so we have the EMA process, scientific advice, CHMP process that is strictly connected with the process that has been set up by the regulation. And also for medical devices, that is quite more complex context environment because it's less regulated than pharma, but we are building a process that is try to connect the EMA process that have now the responsibility, just for the January 2022, to manage the expert panel process that is a specific process dedicated for high-risk medical devices, 2B and 3 class risk medical devices, and we are connecting, working quite hard with them, with the EMA, to connect with the HTA procedure, both joint scientific consultation and joint clinical assessment. We have also, just to give you how is the commitment, the willingness to do this joint work. We have, I'm coming from Brussels, not from Rome, in this conference, because we have had the meeting with the head of agency group that are 32 different HTA bodies all over Europe that are really push for a real implementation and integration of the HTA process in Europe. And then there is another consideration that I would like to bring from the beyond of the table, that we are now in Europe also looking to an evolvement of the concept of the European Union, in the sense that we are moving from what I call the European immigrants, to the European native. That is a completely new generation of person, real younger people that are involved in the group, in the subgroup, in the coordination group, that have a responsibility to implement this regulation. This is quite important element, because beyond the regulation, beyond the organization, beyond the process, there are the person. And this the person is committed to proceed to reach an objective, a specific objective. This is really successful. Just to give you an idea how is integrated and how will be integrated the process, we have just a family photo that we have had in the EMEA. In the middle you have the general director of the EMEA with also the member state and coordination group representative. Then just to give you another perspective, that is how there is the intention to provide this change. In Europe, after the COVID, we have a tool that is called technical support instrument that is financing the feasibility study for structural reform in the EU member state, and many of the European countries have applied to have this support to change the internal process and procedure to be adapted with the regulation. How we move this in the national context? We design and draft this national program in Italy in 2022, so exactly in the same time in which the regulation was going to be started. It's applied to all medical devices, software included, that are classified in Europe under the MDR as medical devices. Also, for the first time in Europe, we have, in Italy, we have a legislative framework. So we have a law, we have a decree that is completely harmonized and integrated with the HTA regulation. And the main objectives of this program is not just to provide the document, HTA report, but it's to create a governance system. So this is the reason, because the actions that are foreseen by this program are quite wide with respect to the production of the HTA report. And we have, the basis in which this program has been taught is firstly to use HTA in all different decision-making level process. So we have the national process, decision-making, we have the regional process, decision-making, we have the local process of decision-making in the healthcare organization. In trying to look into all different time of the life cycle of technology, both in the research and development stage, practical use, and in the disinvestment stage of the technology. Actually, I'm sorry, this is in Italian, but this is another, I think, an important goal that we reach, to give a real clear framework. What is the governance? So we are the Minister of Health that is guiding, that is giving priority, that taking political decision, and us as a national agency for regional care services are taking the responsibility of the operation of the national program. And here we have, and the agency is going to provide this operation using, a network, a research network, because that is going to build, to make the assessment. So we are an advice for, public advice for research center, for the university, where the competency is supposed to be, because we need to have a capacity building to provide this HTA. And also, on the other part, we have the regional authorities network that had the responsibility to transfer this result of the HTA result into the real policy decision maker. And then also, as in the regulation, we foresee an involvement of the stakeholder through a stakeholder network. Going to the one on my last slide, these are the key pillars on which is based the national program of HTA. The first one is to understand really what is the needs in terms of technology by the system, then to produce and prioritize these needs, then to produce HTA documents, but mainly final goals is to transfer the results of the HTA recommendation into the clinical practice. We are really convinced that this, as I mentioned for the regulation, is not able to happen just through process law. We need to have a cultural transformation. So we decide to invest part of the budget that we have available to support communication, education, or for all those people that are involved in the decision-making process. Then we need also to integrate this process of HTA into more the general framework of the decision-making in Italy. Also, I apologize for the Italian slide, but we need to, just to summarize, we need to connect the HTA to the reimbursement process. Actually, in Italy, we are planning to change the reimbursement model for medical devices. So actually, just giving you an example, because we need to connect the evaluation with the reimbursement, with the coding, that support us also to evaluate, to monitor what happens when the pharma and medical devices are introduced into the clinical practice. We have a quite strict timetable because we foresee that the national program need to be adapted every 3 years. So we are, quite strict timetable in terms of milestone and deadline. Thanks a lot for your attention.
Thank you, Marco Marchetti. Now we'll have a Q&A session, but before we go into the questions, I'll just give you 1 minute to think about your questions based on reflections of the speakers. And I think we will have a video now. There's a video prepared by the organizers. So when we are watching that 1 minute video, please take this time also to think about the presentations and your questions, and then we'll go into that. Well, thank you for sharing this little video. This reminded the past one I was here, but also it looks like this work is going way past in the years. So thank you for bringing all the stakeholders together. So I'll continue with the Q&A session. I think we have like seven minutes to go into that. So just to summarize what we discussed now, I started with the definition of unmet need, and in my presentation I emphasized that there's still need for clarification of what is unmet needs and do we understand the same thing. And I did emphasize how context is important and how stakeholder engagement is important. And then we had Lou Garrison is a health economist who gave us specific examples how this can be quantified. He did share elements of value, and he connected his presentation to universal health coverage when he concluded. We had Anne Single, who gave us a brief summary of how patients can be engaged and how they share their experiences with us so that we can benefit from patient experiences and inputs. And then we concluded the panel with Marco Marchetti, who gave us an idea about how the developments are in Europe with the recent EU regulation, how they collaborate, but he also gave us an example of Italian context, what they do in Italy. So now I want to give the floor to the audience for the questions. So please stand up. We have microphones around. Raise your hands. So we have one question, the gentleman. So microphone, my colleagues, if you can bring a microphone here. You can come, but I think microphone is coming. It will be easier. Yeah, okay. So if you can stay, maybe the guy, oh yeah. Okay.
Thank you very much for the invitation. The question is a simple one. since this is as HTA, different countries probably have different levels of requirements, including since different countries have different budgets. And different levels of investment, also maturity and level of education and training of researchers and scientists, the level of the standards applied in the specific sector. Well, I am the head of the SK Pharmaceuticals. I'm also an expert in transportation. I'm just extrapolating as it's done in other sectors. Well, just very simply, international standards are applied, but in medicine it is different due to different reasons. For example, our GDP is using local auditors with the stamping and sealing, and there is no expert in-house because European standard, a recent one, was received by our chemical pharmaceuticals. Well, initially, but why with a step-by-step or gradual approach, there are no details or graduality of the international standards implementation. As Pharmacia, we buy international drugs which comply with all these requirements. That's the first question. And the second question about the construction of new hospitals. And the question is, there is no methodology, and it's a little bit ad hoc. A very simple example with oil and gas plant. You know, like there is a design, detailed design with all the technological patents and processes, navigation. And then it is given to the design institute, and designers already do that. With hospitals, at least that's a personal experience. I looked at the Samsung hospital construction in Korea, but in our case, it's a little bit different. Designers come up with something, construct it, and then coordinate the list of all the devices and equipment, and the medical director has no idea why this equipment, and it's not also guaranteed that this equipment will be installed by commissioning. Well, looking at modernization, it's another thing. This is a problem of methodology and culture of works and operations in this case, I believe. Why there are no standards with the implementation of the proper approaches with the construction of new hospitals. Well, it is about an obligatory approval of the detailed design with the proper Pfizer or other consultants' involvement. Well, with broader engagement.
Thank you. I think we need to have also enough time to answer these two questions. I think it's very good question to emphasize the differences, different maturity levels of different countries. So maybe Lou, I don't know if you would be willing to answer the first question. It's about the differences in standards in different countries with different levels of maturity. So how do you have, based on your experience, an idea how this can be addressed in different contexts? It could be low-income countries, middle-income or high-income countries. And the methodologies we talk about, are they really applicable in all the contexts we are dealing with?
Okay. Yeah, I think the methodologies do move across borders. Information is a public good, and we all learn from each other. Now, obviously we have different resource constraints in different systems, and so they can't all do the same thing. It's not feasible. But at the same time, we see that medicines like HIV medicines, hepatitis C medicines can be used in hundreds of countries. So it's not as though, whereas a cancer medicine might require a diagnostic hospital or infrastructure, and so that's limiting. But I think we do want to approach this globally, and basically what we've seen, say, in Europe over the last 20 years is even though the system should be differential pricing, that's difficult to achieve because of external reference pricing and because of free movement of goods across borders, and I'll talk about that this afternoon. Economists believe we should have different prices for drugs in different countries. The information is, people can afford, we're all contributing to R&D, okay? And how much we contribute depends on our GDP, the inequality in our society. The big problem now is these medicines are not getting to Kazakhstan and other places, even though the drug lag is years, 5, 7, 8 years. So it takes a long time. And part of that is the ministry maybe doesn't want to have the burden given the resource constraints, but I think we need to work to try to overcome those, and that's the basic idea. Yeah.
Thank you. Thank you. Yeah, I do agree. The methods most of the time are applicable elsewhere. For the standards, definitely we need adaptation to the context all the time. The second question, I think it's quite related, although it's about hospitals. Maybe, I don't know if Marco, do you have any reflections from Italian context into this? Because at least in my experience in several different countries, I've observed a similar issue as our colleague asked, that in the hospitals, sometimes there are processes, WAG processes, how you actually adopt technologies at the hospital level. So we know Italy has also hospital-based HTA, and you are involved a lot at the national level as well. So can you give us maybe Italian context, how you handle hospital adoption of the technologies?
I try to give a quick answer. I spent 22 years in a huge university hospital in Italy. That's probably one of the huge university in Italy for sure, though not Europe. University. So it means that we have the needs to decide for all innovation that are arriving into the market, and we trying to formalize and to give into the operation an HTA approach, how to select the technology that need to enter into the hospital. This is my past experience. So what I learned in more than 20 years in the operation of this hospital, I'm trying to move into the national approach. So the lesson that I learned in hospital and trying to move into the national approach, and one of the main objectives of this national HTA program that we just started in the last year is to create an ecosystem that is going to integrate all different decision makers, also in hospital. One of the tools that we are developing is a workflow for the management of the request of acquisition of technology into the hospital. Not just to enter into the local decision-making process, but to trying to introduce methods in all hospital, but not just hospital, healthcare organization in Italy, to have an approach in which when you introduce a technology, you have to ask yourself some basic questions. The reason, because what are the patient population, what is the added value that would you like to have, and what is the technology that is going to substitute, and what are the costs, what I have to need in order to permit to the technology to express the value. So we are trying to improve this process in all hospitals, because there are different levels of maturity also on this issue in Italy. But the key element that we retain to be is the cultural change. This is the reason because we decide to invest an important part of the funds that we have in the next year to try to educate and train both general director, both general medical director of the organization, and also every year 2,000, 2,500 physician, administrative staff that is involved in the decision-making process to decide who buy, what buy, when, and because.
I will add a little local context to this question. Действительно,
It's true that if we talk about the best practices that exist in the world, the best clinical practice, the best production practice, the best distribution practice, globally, they are of the nature of recommendations. And I understand the question was a bit more about the changes that may happen at a local context. So usually what is a guidance or just a best practice in the West doesn't necessarily get applied in the same way here unless it's a law. So let's look at the airlines. So that IATA has guidelines, but in Kazakhstan, same guidelines are at the levels of laws and bylaws, because we have a different mentality. As for building of hospitals, I'm sure that we all remember we had the project of the World Bank in 2013-15, in which Kazakhstan adopted the rules and the regulations of the hospital construction. We don't need to build a hospital in Kazakhstan like in California, but certain standards are needed. There are certain practices and experience of Kazakhstan on introducing these standards.
We can get one more question, but then I need to close.
I have a question to Professor Garrison. I really liked your formula of the value in healthcare. Quite liked it. So you call it a value, but what do the economists who believe in added value theory, believe in this definition of value? I mean, from the economic point of view, what do your opponents say?
I don't have any opponents. What do you mean? Rabia and I are perfectly compatible. I said there were two general concepts, and the welfarism and extra welfarism. Welfarism is just saying, economists say we each have a happiness function. We call the utility function. And utilitarianism, we're trying to maximize the happiness of society. We add up everybody's happiness. The British people said, no, that's too simple, okay? Actually, we have a social contract. And we agreed to spend, 10% of our budget on health. And then we have a fixed budget. And then we tell the NHS, given the fixed budget, we want you to maximize the health of the population. But that's focused on like life years gained or morbidity reduced. And so that's the extra welfarist approach. So in a sense, equity, a kind of equity, overrides efficiency. And it's a redistribution. And those are two different concepts. But you would be surprised, we both come to estimating the cost per quality. And we come to the idea of a threshold. So we come to the idea of a threshold. And the threshold is, in the US, we're willing to pay, on average, say, $100,000 per quality. In the UK, they're willing to spend 20,000 to 30,000 pounds per quality. But the Germans would say, well, we don't want to do that. We're going to look at the clinical data, and then we're going to negotiate. So they don't explicitly do the measurement. I would argue implicitly the Germans think about length of life and quality of life when they negotiate. So we end up, but it's a different way to get at the same thing. But what I was trying to emphasize is there's more to life than length of life and quality of life. There's also the value you get from knowing you're protected, which is what universal health coverage gives you. It makes you better, even if you don't go to the hospital. If you know that if you get sick, you can go, that's valuable. And if we just measure life years gained, we don't capture that value. So that's what we're trying to broaden.
Thank you for the questions and open answers. I think we had a very good kickoff of the day, so now I need to close this session. We have a coffee break right now, and then we'll be back in this room in 15 minutes so that we can continue with the rest of the session. Thank you.
Раз. 3-4.
it's impossible. Let me check if it works. Just a bit more and it will work. A bit more, it will work. Yeah. People can see like this. Great.
Уважаемые гости, прошу всех в зал. Уважаемые спикеры,
Dear speakers and participants, please proceed to your seat in the room because we are going to start our session number 1.
ladies and gentlemen, уважаемые гости, прошу...
Dear guests, proceed to...
Our respectful speakers for this session, Dr. Igor Lipsa, we're waiting you. And all participants, please sitting on the place. Уважаемые участники нашей конференции,
Dear participants of the conference, we had a very good opening session, very good context was already set, and I believe it will set the tone for today's conference. We are a little bit late. Therefore, can you please proceed to your seat for us to start our first panel session? This panel session is dedicated to the issues related to the physical and economic accessibility and affordability of the HTA. Probably HTA is a tool which is has a direct impact on the accessibility and affordability of technology, and depending on the mastership of its use, it can be impacting both negatively and positively. We have experience with that. There are some European research and studies showing that where the HTA is not transparent enough, is not well designed, unfortunately, HTA will be the third barrier because there is registration and there are some other pricing issues which be serving as additional barriers. But if HTA is functioning as it is supposed to, well, then it is a very helpful tool to be really, it is supporting really innovative, good technology to come to the market to improve health outcomes. And this is a system actually which every country wants to have, which implements the HTA, and particularly countries of our region with specific focus on Kazakhstan. In this session, I will be moderator, Alexander Kostyuk. I am advisor to the Kazakhstani Association of HTA. And my partner will be our European guest from Italy, Mr. Marco Marchetti, who is the head of the department of the HTA in Italian agency. And Marco also is a co-chair of the European Coordination Group on HTA in European Union, EU. Marco?
Introduction. I would like to open quickly the session because we have just a little bit of delay. So I would like to introduce the Iñaki Gutierrez Barruzea that is supposed to be connected online, that is giving a speech on innovative technology and healthcare disparities. What are the challenges and solutions for HTA? Iñaki, are you connected? Can you ask? Is Iñaki connected?
Yeah, I'm connected.
Okay, now we can hear you and we can see also you. Thanks to be with us.
Thank you very much. I will. I'm very jealous not to be there, and I will try to minimize my echo because I'm nowadays with two translation. Yes, one moment. Yep. And I'm hearing twice. I will try to share my screen. So let me, if you can see it. And I will put that in. Can you see that now? This is the full screen.
Yeah, you have to invert the.
Yeah.
Okay, now we can see the full screen. Thanks.
Yeah, thank you very much, and thanks for inviting me today. First of all, I need to say it is that it is a challenge not to be there, as I was saying, and on the other side, it is important to note that well, it was a pity mainly due to local elections. So the things that I'm going to say today is around innovative technology and healthcare disparities, and which are the challenges and possible solutions from the side of health technology assessment. And at the end of my talk also, I will address a little bit why the background that I have, it is the one that I have. I don't know if it is not moving, I think, yeah. So when we talk about innovation in health, many words are coming to our mind, and among those we can hear new, and this is I took them from the internet, and when we were talking about innovation and in general, but also applied to health, we hear words like new, novel, improve, research, development, data, creativity, talent, and entrepreneurship. And although all those words can be related to innovation, I think it is important to note that in general, when we are talking about innovation, we are talking about different type of innovation. So we talk about open innovation, product innovation, process innovation, business model innovation, service innovation, incremental or disruptive innovation, computing, technology, digital, social, sustainable. All those words also come to mind, and when we are talking about health, and we hear many voices saying one of the challenges is how we can adopt innovation without creating more disparities in health and not improving the healthcare outcomes. It is true that many things need to be done, and on the other side, we need to be reminded what innovation in reality means. And although it is related to those words that I mentioned before, I will relate to something that was established almost 5 years ago by WHO Health Innovation Group. And when they were talking about innovation and health, they clearly stated that is innovation, it is to develop and provide new or improved health policies, systems, products, and technologies and services and delivery methods that improve people's health. So they stated something that is related to something that is also linked to the HTA world, that is improve people's health. So it is creating value. Furthermore, when WHO was talking about innovation and healthcare, they said that innovation needs to respond to unmet needs by employing new ways of thinking and working with focus on the needs of vulnerable population. So they tried also to address one of the things that is important, that is diminishing disparities when we are approaching to innovation and healthcare. And furthermore, they stated that health innovation adds value in the form of improved efficiency, effectiveness, quality, safety, and or affordability. And I think it is pretty much linked to one of the things that we are discussing today and in the following days. When we are talking about innovation, and I need to say that innovation has an ethical component. If we go, for example, to the things that are related to the 4 principles of bioethics, and we when we were at faculty, the bioethicians told us well, the four principles are non-maleficence, beneficence, justice, and autonomy. And the things that we are in principle evaluating in healthcare systems also are related to them. Non-maleficence, it is something that we are accustomed to evaluate, that is safety. Beneficence, it is also related to something that we are accustomed to balance with the safety, that is the effectiveness. And justice, it is an autonomy. It is related to other things that we also measure, that is efficiency, affordability, and quality. And those are things that the group of innovation of WHO also, they establish that ways in terms of defining innovation and determining the value into healthcare systems. If we go to the what it was said by the group of innovation or the group of innovation of WHO and the current definition of HTA, we can see that much. So they said response to unmet needs by employing new ways of thinking and working with a special focus on the needs of vulnerable populations. And health innovation adds value in the form of improved efficiency, effectiveness, quality, safety, and affordability. And on the other side, when we go to the current definition that was promoted by NATA, the Network of Agencies for Health Technology Assessment, in which we are members, and also Health Technology Assessment International, that is the international society around HTA. The definition says also HTA is a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. And the purpose, it is to inform decision making in order to promote an equitable, efficient, and high quality health system. And if we match the two definitions, they put the focus on efficiency, equitability, so it is making technologies being feasible in terms of being introduced also in vulnerable populations. So that is related also to justice and autonomy and high quality healthcare systems. But nowadays we are talking about innovations and the possible challenges, and we can say new or old challenges. Nowadays we are seeing that there are new areas that could impact our healthcare systems, such as nanotechnology, biophotonics, new molecules that are nowadays jumping, so molecular antibodies, immunomodulators, also the use of nano components in conjunction with new molecules. We are talking about artificial intelligence, digital technologies, and some others. But when we are talking about the challenges that we are, once again, they are related to safety. We are very conscious of what are the unintended consequences that we are created with those technologies. We are talking about the effectiveness, to which extent those technologies are creating intended consequences. Also, we are talking about affordability. So to which extent the new treatments, the new, I would say, technologies that are trying to impact our systems, so-called innovations, but I will refer to that. They are at a price that is affordable to anyone in the world. We are talking about quality, how we can ensure that the development and the things that are around those technologies, in reality, they are the same in all cases, and we are treating the same in all the cases and producing as far as we can, the same results. We are talking about autonomy. Nowadays, there are challenges that we have also around some of the technologies, especially digital technologies and artificial intelligence, to which extent they are going to put into doubt the autonomy of professionals and patients. And finally, we are talking about new kids on the block. So is there anything new under the sun, or yes or no? So we need to say that in all the cases, what we are seeing it is that the main challenge is the management of uncertainty. And one of the challenges, obviously, it is related that we have a diversity of values when we are judging value. We can see the values from the side of the citizens, the values from the side of the patients, the values from the side of the professionals, the values from the side of the managers, and the values from the side of the system as a whole. So one of the challenges is the management of uncertainty, but also the diversity of values, the diversity of perspectives around the value. So it is not the same, the perspective that a patient has around a value of a technology or a treatment and the perspective that a health professional has, or the perspective that the managers has around the managers have around those technologies. And also one of the things that it is that we have uncertainty around the intended and unintended consequences. Also, we have in the previous talk, it has been talked about also the value in context, and it was said that you are not going to build up a hospital in Kazakhstan as the same that is built up in California, but we need to establish kind of standards, and also that is related to how those technologies procure and generate value in context. Apart from that, it is one of the matters. It is also the uncertainty around the cost and the possible budget impact. Recently, I was discussing with some colleagues that are now implementing CAR-T technologies in hospitals, and they were saying that despite the many, I would say, thoughts and the many expectations that they had regarding the possibility of improving the health care and outcomes of some of the patients once they were treated with CAR-T, less than 30 to 40% of the patients respond to the treatment. So and they are very costly. They are very costly treatments. So one of the things that is challenging is also to which extent those costly treatments are generating outcomes that are generating also some value for systems and for patients. And the other thing is acceptability. And there are new kids on the block, it is true. So there is something new, despite that all those aspects that I've mentioned before. So it is that a diversity of values, diversity of perspectives around value in intended and in unintended consequences that were things that we already discussed and we have been discussing in the last 50 years. But there are new kids on the block. One of the concerns right now, and it is included under the new definition that was established in 2019, it is, first of all, environmental impact. So it is to which extent what we are creating, apart from generating intended or unintended consequences when we apply it on individual patients, one of the things it is to which extent those technologies are built up, are produced, managed, finally introduced into systems, are transported in the best way possible to generate the minimum environmental impact possible. And another thing that is important, it is from the side of disparities, it is also obviously the sustainability of systems as a whole. So why do we try to achieve and why we fail to achieve the desired results? In many occasions, because we are starting the houses from the roof. I will refer to that. Here we have a nice picture in which we start a house from the roof. And there are also possibilities to generate houses starting from the roof. I'm not against starting from the roof. And I'm going to refer why I'm saying that we are starting from the roof. Because in general, we start from the technology. And when we go to the definition of technology, and this is a nice definition that was produced by John Kenneth Galbraith, the definition of technology was saying technology is the systematic application of scientific and other knowledge to solve practical problems. And health technologies, when we are applying that to health, the health technologies are equipment, medical devices, medicines, and medical and surgical procedures used in diagnosis, prevention, treatment, and rehabilitation, together with the administrative systems required to implement them. So when we are referring to technology and health technologies in concrete, what we are referring, it is answers to questions that we have in the system and trying to produce the best value possible on the basis of those answers. And I will refer to something that is quite common when we go to, for example, the supermarket. If you go to the supermarket, and here it is a nice picture, you have the best deals quite close to the cashiers. So that means that when we are going to pay, they put the best deals in terms of capturing our interest and in many occasions, apart from the things that we are in need to buy when we go to a supermarket, also we buy other things that are, in principle, not under our mind. And that happens the same exactly the same with the healthcare systems, that we are bound by technologies. So the first is the technology. So it is the offer, the answer. It's theoretical value, because that is created around the system that we have introduced by guaranteeing that the things that are introduced in the systems comply with certain type of rules, and that is regulation. But it is also introduced at from the side of the health systems perspective, not from the side of the societal perspective. So it is the wills and the priorities of the health systems, but not society as a whole. Also, they are relying on the political cycle. So decisions are made on the basis of if I'm going to have an impact in 4 or 5 years' time, and also the establishment of priorities are from the side of the pathology point of view. So it is from the demand, but not thinking what is going to happen if we act earlier. So once again, sometimes what happens is that we go to supermarket when we are trying to prepare, for example, a recipe at home around spaghetti bolognese, and instead of buying pasta and bolognese sauce, we come back with some cereals, perhaps some small batteries, and other things that in principle they are not value in terms of creating spaghetti bolognese, and that happens. And it is important to say that happens also to the healthcare systems. Another thing, it is new ways of acknowledging value or values. It is one of the things that is stated in the definition of HTA, that the HTA creates or is based on explicit, robust, and transparent methods. And it is true, but one of the things that I think we fail, it is in scoping. So in defining and combining the value and the values, there is a clear example for those that are willing to know a little bit more about the combination of value and values in a European Union project that we were part of the consortium, and with other colleagues in Europe, that is the validated HTA. And we demonstrated that if values are not introduced from the very beginning, when we are doing the scoping, when we are making the questions that we are going to pose, we create tensions in the final definition of value. And if we are not able to differentiate on which is the interest in terms of value of the professionals, the patients, the managers, and the health system as a whole, and also the society. And if we are not able to demonstrate and put into place the diversity of things that are created around that, and the diversity of opinions and also perspectives, probably we are failing. Another thing it is that we need to explore new ways of demonstrating causality without compromising. Here it is a nice book that was written by a good friend, that is Miguel Hernan, that from Harvard University, around causal inference. And we can demonstrate that using real-world evidence and observational studies, we can demonstrate also causality. That is the link between the intervention and the desired effect. And on that basis, also we can be explicit, robust, and transparent. But also we need to be very conscious that we need to be strict in the way that we apply those new ways of acknowledging. So what can, and with this I'm concluding my talk and open also to questions from the audience, it is what can health systems and HTA do? First of all, it is know the needs. So know in reality the demand, and not starting from the bunch of technologies that we are offered from the innovators. So it is, first of all, it is analyzing what in reality it is the needs of our country, and what are the demand of our society. Not just from the side of health system. Obviously, we need to take care of the health system, but also we need to think about what our societies are demanding. Also prioritize the demand. So instead of prioritizing the technologies, it is prioritize the demand. So what are the most important things that we need when we go, for example, as I was describing, when we go to the supermarket? Make a list. One of the things that any economist is saying to you in terms of minimizing the impact on your budget when you are going to supermarket, it is make a list. And we are not doing list. We are not doing or making list of our wishes to the market. Also, confront the list against the stakeholders. Another thing that we are not doing, it is confronting the list that we have, the identified demand and the prioritized demand against the stakeholders, against professionals, against patients, against citizens, against managers. Also, assess the differences and the reasons behind that we have when we are confronting those lists against patients, citizens, professionals, and managers. One of the things that we don't do, it is also assess why there are differences in the approaches to that list by the different stakeholders. Also, confront against technology. Instead of technologies being confronted against the system, it is being much more proactive and confront the list against the technologies. And another thing that is important and that generates also other aspects, it is confront against the budget. So it is, well, I can go to the supermarket, I have a list, I decide which are my priorities to go when I go, and I need to say how much money I have in my pocket, and then I go to the supermarket and I say those are my priorities, those are the offers that I have, those are the deals that the supermarket offered to me, and on that basis, and on the budget that I have, so is that the money that I have on my pocket or perhaps in my credit card, then I buy. And what more? I think we need to be much more proactive. So it is one of the things that we are not doing, and especially when, well, in the definition of technology, it is by John Kenneth Galbraith. He was saying that is knowledge and skills applied to solve problems. And I think if we have done our exercises, our homeworks, we would know which the demand is, and that can be confronted with the innovators, with the companies, with those ones that are creating the technologies, and we need to be much more proactive in this sense. Also, that leads to another thing that is also important. So we can create public-private partnership. Nowadays, there are some people are saying, well, we can be confronted and corrupted by the companies because we are going to work close together with them. But one of the things that is important, it is that we need the best solutions possible, and that is based on a real description of what the needs are on the one side and what the technological possibilities are on the other side. So we need some kind of public-private partnership. Another thing that we can do, it is what is called public procurement of innovation. There has been a huge movement, especially in the European Union, in terms of improving the ways that we do when we approach to technologies in general, but especially in the healthcare sector.
Inaki, I'm so sorry to interrupt you. You have over 9 minutes, only 1 minute. Please keep time.
A more proactive way of thinking. Also, we need to promote also some kind of pre-commercial procurement. When we are saying pre-commercial procurement, it is a public-private partnership, and also innovative approaches to procurement. So based on outcome or based on cost. There is we can talk for hours around managed entry agreements that are based on outcomes of cost, and finally. I think we need to create, on the basis of that public-private partnership, it is early dialogue, early advice, and scientific advice, as it has been described in the literature on the one side, but also it is important in terms of creating that public-private partnership. And with this in mind, I thank you very much, and I'm sorry if I'm gone out of time.
Thank you, Inaki, for your very interesting presentation. We are missing you in Astana.
And I'm going to say also why the background it is what it is.
Maybe next time. And я сейчас хочу представить наш.
Now I would like to give the floor to our next speaker, co-chairperson of the special group of HTA on the development of the hospital level HTA, as well as the Chairman of the Institute of Management, Iga Lipska.
Hello, everyone. It's really an honor and pleasure to be here. So thank you for inviting me. So I've got dual roles here. So as Alex mentioned, I co-chair a hospital-based HTA group. I also try to chair Health Policy Institute, which is NGO in Poland. So I have come directly from Warsaw here, and it's my first time in Kazakhstan, so I'm really honored to be here. And I have also discovered there are a lot of direct flights between Poland and Kazakhstan. So I came directly from Warsaw to Astana, which is quite surprising, only 6 hours of the flight by Polish airlines. It's a kind of advertisement for you here, but it was a kind of surprise for me. Okay, so I will be talking about HTA and capacity building for resource allocation and evidence-based decision-making. Basically, I will share my story and my experience about Polish, a kind of success, I would say, in implementing HTA for decision-making processes. It's not so great. It could be better, I would say. As usual, you can do a lot of things better, but perhaps we can also discuss this. I will also mention about hospital-based HTA, also following up on the previous discussion and questions here. So I will also reflect on my second role, which is co-chairing hospital-based HTA group. So perhaps you will be also interested in joining our activities, as there are really a lot of things going on. Especially as we are planning also some training activities with India colleagues, perhaps also with Kazakhstan colleagues. So we can also discuss this. I'm very open to collaborate. So please take this into considerations. I think a lot of has already been mentioned, but just to kind of summarize. So what about decision-making in healthcare? So we have already mentioned, and I think it's very clear that resources are always limited. I think it's very, very important to take this into consideration. So we have to consider financial limitations, but not only financial limitations. We've got a lot, really, at least in Europe, and I think almost everywhere globally, we've got almost the crisis. I would like to use this strong word. So we've got the crisis with human resources within medical professionals. So it's not only about financial limitations. We have to consider a lot of other resources. So medical needs are huge. We can define them. Rabia has mentioned about medical needs, health needs, unmet medical needs, etc. We have to consider demographical changes globally and, of course, in Europe, so population aging. So the question is, and I really think it's the most important question, do we really need evidence-based decisions in healthcare? Some people, and it's also based on conversations I had with some colleagues here, some people prefer using evidence-informed decision-making in healthcare. So the question is, if we agree that we need evidence-based decision-making or evidence-informed decision-making, so do we need HTA, and what is HTA? I think the definition of HTA has been presented several times here, but it's good to remember what is HTA, so perhaps also to define why, if we need HTA, why do we really need this? So as I stated at the beginning, I will share my story with Polish experience, but I will start from, again, the same question. So why did we start implementing HTA back in 2005? Personally, I think it's an interesting story. Perhaps you will agree with me. But we also built capacity for HTA, and I think it's one of the key success factors for Polish story, that we also managed to build capacity and to build awareness for HTA in Poland, so for evidence-based decisions. So the most important question from my perspective is, do we need evidence-based decisions in healthcare? So as stated before, we've got a lot of limitations, financial limitations, human resources limitations. I would say, and I also think Iñaki reflected this in his presentation, I think we can say we've got tsunami of new innovative health technologies, but the question is, are they truly innovative technologies? What is the innovation? I think a lot of has been mentioned already. So we've got drugs, non-drug technologies. Of course, when a pharmaceutical company comes to Ministry of Health, neither in Kazakhstan nor in Poland or UK or somewhere else, they usually say they've got the best innovative drug. I usually say new wonder drug, but is it true always? So do we need all these innovative drugs? New doesn't mean it's really breakthrough or really innovative drug that we really need. So what we have to do, we need to define what drugs, what technologies we need based on our supply and demand knowledge, let's say. So definitely we've got drugs and non-drug technologies, but what about digital health technologies? So it's really, we can say it's really tsunami of digital health technologies. Not all of them are really innovative, but I'm really a believer that a lot of digital health technologies can really bring value. I think Lou mentioned value for healthcare systems. So I believe if we make really informed or evidence-based decisions for digital health technologies implementation in healthcare system, we can really use a lot of resources, even human resources, in much better way. So what we need to do, we definitely need to choose health technologies for implementation to healthcare system, and we need to choose them really wisely. So the question again is what criteria we need to use. So if we agree that we need evidence-based decisions in healthcare, the answer seems obvious, perhaps for all of us here, but, so from my perspective, but is that we need political will for positive response. But I would say, when I mention political will, and I'm really an expert, not a politician, but I'm trying to be honest here. So I think for each such decision, we need really political will. So what we did in Poland was really political will. So it was at national level, but also we need a kind of political will. At least in Poland, hospital managers are usually nominated not only based on their expertise, etc., but also politics impact these decisions. So we perhaps also need political will to implement hospital-based HTA. Definitely we need hospital managers' support to implement hospital-based HTA. So we need methods to assess health technologies reliably based on the evidence. If I mention evidence, I mean already existing evidence from clinical trials, but also evidence we can generate, or we can also use real-world evidence. That's also important, but we need methods for this. So we can assess clinical parts. So when we talk about clinical effectiveness, cost effectiveness, of course, budget impact analysis is very important. So all these HTA standard domains, I would say, but we also need to take into consideration other domains or other aspects, like ethical issues for HPV vaccination, for example. There was a huge discussion, at least in Poland, which is a Catholic country. Can we really implement HPV vaccination in the country? Because there was a kind of argument if 15-year-old teenagers already started their sexual life. So that's also important to consider other aspects. So not only clinical, cost effectiveness, budget impact, but also, for example, ethical, perhaps also religious issues. So HTA seems to provide the answer. So the definition has already been mentioned several times here. It has been published, it's quite recent, but it puts emphasis on several important aspects. So we really need methods to define the value of health technology for healthcare systems, also at different points of life cycle. I think it's really important when you mention digital health technologies, and we do this in order to promote equitable, efficient, but also high quality healthcare system, and that's exactly what we all need here. So if we agree that we need HTA, so we want to spend resources efficiently, so we need evidence-based decision-making, but please remember that we also need political will. So from my perspective, without political will, so political support, you will never implement HTA, at least at national level, but also at local hospital level. At least it's my experience. I'm saying this once again. So probably the issue is that if you really make evidence-based decisions, it takes a little bit power away from politicians. So the question is, have you got contacts as experts in HTA with politicians? So can politicians believe you, and can they rely on HTA expertise? In other words, perhaps they also need to understand HTA. And I will come back to that point later, how we also trained politicians. So why did Poland start implementing HTA? It was 2005, but I know it's a long story. But at that time, I had the opportunity to work for the agency. So I started in 2006 and spent really a great 5 years of my professional career there. So Poland accessed EU in 2004, but we had huge issue with EU Transparency Directive. And that was used, so it's on objective measures how to, let's say, implement innovative, not only innovative, but also innovative drugs into healthcare systems. But there were 3 areas like timelines, objective criteria, and also means of appeal. So I'm not going to into details, but there were like 3 areas of this directive. And Poland had issue with European Commission with that. So this is why, this was the main reason why it was such a strong commitment from politicians in Poland to implement HTA, because it gave us the chance to implement evidence-based processes. So criteria, the processes were much faster, so timelines, and also we implemented the whole legal framework for HTA, and I think it was a crucial success. So we implemented like new law on reimbursement on pharmaceuticals, etc. So this is exactly how Poland started. I've checked the map, so I already informed you, I've got a direct flight from Warsaw to Kazakhstan, but I think it's always really good to look at the map. So as compared with Kazakhstan, Poland is really a small country, you can easily see. I think Europe is really a small, European Union is small as compared to Kazakhstan as well. But I think we can learn from each other. So just a few words about Polish healthcare system. We've got 1 national payer with 16 branches. And we implemented HTA agency. So as I said before, we implemented this with strong commitment from politicians. We started in 2005, in operation from 2006, and then with full legal framework, we made the agency really much stronger. And now it is really an important organization in healthcare system. And everything was really supported by processes and HTA guidelines. So except for legal framework, all this was crucially important, but you all need to define HTA guidelines, so HTA expertise and processes. We still have access gap, and I usually try to explain this. So Polish patients have access to innovative medicines much later as compared to other countries, and there are many reasons for this, but one of those reasons, if you break these numbers down, you can see that the industry submissions for innovative drugs to Poland are much later in the timeline because we've got cheaper prices. I don't know if this is the issue for Kazakhstan, but that's definitely the issue for Poland. So what about capacity building? Because I think it has been a kind of key success factor here. So definitely political will was one of the factors, but we did, we really used international networks. But what's important, we organized a lot of awareness-raising seminars for decision makers, and that's important, and I want to say this publicly. We used international experts for this. I think it was important. So when you are like national expert, it seems to be obvious, but when you are a national expert, even a well-recognized expert, you meet your Minister of Health or Vice Minister of Health, but you can't convince them for some reasons, I don't know why. But when you invite international experts, like decision makers will say, wow, that's usually something we need to implement. So that's probably what this seminar is also about, but I think it's very important. We really used this. And we organized a lot of trainings for doers, so HTA doers, HTA users, but we also organized this awareness-raising seminars for our stakeholders. Not at that time, but now we are also organizing seminars, HTA seminars, for example, for patients, to help patients to understand the processes. So in conclusions, I think it's very clear that, at least from my perspective, and I think you all agree here, so evidence-based decision-making in healthcare is really crucial, but we need some political will, we need some scientific methods to support this. So we implemented this pragmatic model. We built capacity using international expertise. I think it was really important. And organized this awareness-raising seminars for decision makers, perhaps not only politicians, but for decision makers. But we also organized this training courses, not only internally for HTA agency staff, let's say, but also externally, so for a lot of other stakeholders. So I'm going to finalize with that. In sake of time, Alex, if you allow me like to say one thing about hospital-based HTA. I think it will be important here. So I chair this HTAI group, it's interest group. So if you want, you are really invited to join. The important thing is, I think we create a kind of HTA universe, and we try to go broader to hospital managers, for example. And we had this experience in Rome last year when we interacted with European Health Management Association. And a lot of hospital managers approached us and gave the feedback that, okay, that's the methods we really need. So we are planning to approach as this interest group, perhaps as the whole society, we are going to interact with real HTA users. So we target hospital managers, and we target biomedical engineers as well. So we try to implement this global approach. So if you're interested, just contact me. We were granted like the amount of money for this activity from HTI as the society. So I think we can do really a lot of things together. Thank you so much.
Thanks, Iga, for your interesting speech respect to the Poland experience. And now would you like to move the floor to Tanya Novaskovic, that is giving a speech in incorporated affordability and cost-effectiveness analysis for HTA. Tanya is an HTA and health economics expert, is the director of GME, is Solution Ltd in Serbia, and please, Tanya, she's connected online. Can you hear us? Can you?
Yes, I can hear you. Can you hear me?
Yeah, yes, we can.
Excellent. Can you see the screen?
Now we are able to see you. Yes, not your screen. Okay, now we can see your screen. Now we see.
The presentation is on, yes?
Yes.
Or no?
No, yes, we can see. We can see.
Thank you very much. I would like to thank the organizer for inviting me to such an important event as the second Scientific and Practical Kazakhstan HTA conference. I would like to regard all my friends and colleagues in Kazakhstan. And also I would like in advance to apologize for not being into details, into methods and concepts and calculations of incorporating affordability and cost effectiveness analysis for HTA, but rather go and explain more the importance of these concepts. So let's start with the definition of affordability. What is affordability? In a simple economic sense, it is making efficient use of healthcare resources. And what efficient means, also in economics and health economics, efficient use is defined with cost effectiveness. We will explain that later. Also, what I want to take from this presentation is important to say that affordability is not how much money it will cost us. It is not that problem. It is the part of the problem, but it's not the whole problem. What is affordable and what is not affordable? Affordable is a decision that changes the deployment of healthcare resources such that the population health improves. But what we cannot afford the decision that make a population health worse. And as Iga and probably other speakers said, we are in this constrained budget environment, and we are searching for the solutions that can improve population health. So we require a threshold. And what is the point of the threshold is that above that threshold, we can state that the change of the deployment of healthcare resources will get population health worse. So therefore, we need to define the threshold. And the threshold is actually simply defined by the incremental cost effectiveness ratio. And it is how much our decision change cost and how much our decision change benefits divided by each other. And here is the formula of the ICER. And on the graph on the right hand side, you can see the slope. You can see the slope, and that's actually the ICER. Everything below, and that's the threshold. And ICER itself actually determines this slope. And everything below this threshold is, let's say, cost effective. But we have two extremes. We have a extreme that, for example, we just want those decisions which reduce expenditure. So we have a threshold, zero threshold. But that's, of course, not in a real world. And we also have another extreme, which is when the threshold is infinitive. That means that only good decisions are those which improve health benefits regardless of expenditure, which is also not possible in the world. So we need something in between. Therefore, why we need that in between? Because already mentioned, budgets are fixed, and the budget impact is cost of a decision to a payer over the time. So we need to think for our budget over the time. And if we think about the consequences of saying yes, for example, to oncology treatment at the ICER of 50,000 euros per quality, and that will result in efficient use of resources for conducting cataract surgeries. So, which ICER is 2,000 euros per quality. So this was actually happened in United Kingdom in 2010. Decision makers said yes to some oncology treatment, and they stopped conducting cataract surgeries. So they gain less benefit for more cost. What we also need to differentiate for the threshold is the threshold is not willingness to pay. Should we pay for the healthcare technology? It's also not ability to pay. Does the healthcare system have resources to pay? What we also need to consider within the threshold is that we have options which are cost effective. So we can have threshold, for example, 30,000 euros per quality, and we have a treatment which can actually be below that threshold, but it can consume entire healthcare budget. Again, a real-world example is the hepatitis C treatment, which was reimbursed a few years ago in Slovenia. So they actually end up with consuming the entire healthcare budget because of that decision. So a lot of things were discussed today about health technology assessment and health economic evaluation. But I just want to emphasize those two aspects of the health economic evaluation. And this is the actually choice that we make between two interventions or more interventions, and comparison between two interventions in sense of costs and benefits. And this is this idea of the opportunity cost, when we can spend our resources just once and not twice. And now we will go a bit more into details of the elements of the cost effectiveness plane, which was previously presented. And we have these 4 quadrants. The top left red quadrant obviously is easy decision because we have here higher cost and less benefits. So we can say no to this new innovative treatment. Then we move a little bit on the left. So on the top left, this orange triangle, we have intervention, which is actually not cost effective because the threshold is this line here, and everything, as we said, above the threshold is not cost effective, so it's not affordable. We get we don't get enough benefits, and they're with the higher cost. And for the threshold is actually the line which determines is something affordable or it's not affordable. So everything below that line is affordable, and we can say yes to it. And therefore we have this green triangle, which we have actually, we did the intervention, although it is with higher cost, but we get enough benefits, and that benefits can justify that additional costs. And in the real world situation, we face mostly with this kind of problem. The green quadrant below actually is the ideal situation when we will have intervention with the lower cost and with the a lot of benefits, but usually it doesn't. It's not in the real world. And then we have this triangle, light green triangle, which actually is this investment. It's the opposite of this orange triangle, and resources can be actually used better elsewhere. We have intervention which are with a lower cost, but in the same time we get less benefit. And at the end, we have not cost effective and too great loss of benefits. And with the estimation, as I said, this is complex topic. With the estimation of cost effectiveness, we almost never get one single point. We actually get the point as cloud points. So this is how the cost effectiveness plane looks like. It's never like this, and we never get points in this quadrant. So usually we compare intervention with the best supportive care or to new intervention. And therefore, the ICER in the real world is not a single number, and the threshold is not a single number. In UK, NICE introduced threshold in a range from 20,000 euros to 30,000 euros. So that is because of this uncertainty, and that's how NICE is actually capturing our uncertainty. If they were certain about the outcomes, they would actually put the single number. What we said in the beginning, we search for the choices which improves population health. And today, unfortunately, we don't have time to go into details of the cost effectiveness. It's a huge topic. But first, what we need to do is to identify costs and to identify benefits. Costs are economic costs, but they can be understood as a financial cost. And this is a simple graph recently finished project when we have different types of costs, like treatment costs, diagnostic costs, healthcare resources costs, like visits to the doctors. And the benefits usually expressed in the measure as quality adjusted life years. This is the concept how it is calculated, but what we actually in the real life we are actually facing, and what is the most challenging are the health effects and costs are adequately captured, even in the systems where HTA is well established and well developed. This is the very big challenge and very big questions. Other types of the costs that we need to consider is the adverse events cost, and we will not go into details. And therefore, we come to the discussion and conclusion. When we think about solving the challenge of incorporating affordability into cost effectiveness and health technology assessment, we are coming to this constrained evidence environment. What it means? We actually need to make decision, and we still don't have enough information, enough evidence. To require this, we might invest in a further evidence, and we have to make decision one way or another. Another thing very important is that it is difference between countries with established HTA and not established HTA, and those who are using for a long time HTA. So those who are not having established HTA, they're facing a unique set of challenges for adaptive evidence for their healthcare decision making. And what is the most important actually, and where is the biggest value in this incorporating affordability into cost effectiveness is this transparent decision making, which paves the way for good decision making. This is something that is the best, this is the most important and has a very much importance in this challenge. Further, we come to the complex decision place when we have a high burden of evidence synthesis. For example, oncology treatments, which evidence can have to be tested in different healthcare systems, and in the same time, they are very expensive. And what we said before, and what I want to actually take away from this presentation, is that a good decision making, which Iga was also mentioning, is the one that improves the deployment of healthcare resources such that the population health improves. So all this mentioned fits into evidence-based decision making, into evidence-based decision medicine, and the process of explaining decision in ways that can be judged. I would like to thank you for attention. I was within the time, so I wanted to be, if you have some questions, I'm free to answer them.
Thank you, Tanya. Very perfect presentation. It was easy understanding and useful for us. Я бы хотел...
I would like to ask our participants. We have a lot of interesting presentations with these sessions, but unfortunately we are running a little bit late. Therefore, your questions can be passed over in written form. because we don't have time for Q&A. Speakers who are here offline, you can have discussions during the break. You can ask your questions. But those who were joining online, please submit your questions in written. We will be passing over all your questions. I would like to give the floor to our next speaker, Birol Tibet. He is the chairperson on the early career growth in HTA. He's a partner in the consulting firm Econics and vice president of the Association of the Evidence-Based Medicine in Turkey. Birol, please, the floor is yours.
Distinguished guests, dear esteemed colleagues, first I would like to thank the organizers because I feel really pleased and honored to be here. Not only we discuss HTA here, but also I'm in a country that I find it as a relative because I come from Turkey, as a public health physician and health economist. And my purpose is to get you back to the topic innovation again. So it will be somehow a complementary presentation to the presentation of Iñaki. So what we will discuss is how innovations can be identified, assessed, and recommended in HTA. Okay, it's difficult to present this in a nutshell, but we will try to understand what innovations are considered within the scope of HTA, how are potential innovations identified, what criteria are used to assess these innovations, and lastly, how are assessed innovations recommended for use. To achieve this goal, let's set a context for this and remember or emphasize what HTA is once more. It is a systematic, transparent, unbiased, and robust approach used to evaluate the properties, effects, and impacts of health technologies, inform decision-making in healthcare to promote an economically sustainable healthcare system, and examine the clinical, social, economic, and ethical issues related to the use of a health technology. But what is importance of innovation in health technology? Innovations are beyond mere invention. Incorporating the dissemination and application of new technologies into healthcare system, significantly improving available solutions or completely replacing them. So innovative healthcare technologies can lead to transformative changes like enhancing patient outcomes, increasing system efficiency, and promoting equitable access to care. So the strategic incorporation of innovation through HTA ensures that new technologies are not only scientifically advanced, but also economically and ethically sound. From that point, in the context of HTA, innovations must not only offer advancements, as I said, but also align with the broader health goals of improving quality, accessibility, and sustainability of care. So as Iñaki has already mentioned, there are different categories of innovations, including product innovations, process innovations, positioning innovations, and paradigm innovations. But why we focus on innovation? Why we need to do that? Because we have current gaps in healthcare globally. We have lack of accessibility and coverage due to geographic and economic barriers. We have variability in quality of care between regions and within healthcare institutions as well. Inefficiency of care delivery, such as high costs, lengthy wait times, etc. And health outcome disparities across populations due to socioeconomic conditions and demographic factors. So innovations carries potential impacts across the healthcare system in this term, like enhancing system-wide efficiency, improving efficacy of treatments, and promoting equity in healthcare. So I go back to the title. So we will identify, assess, and recommend how we will do this. For identifying innovations, we have, not ongoing, okay. We have methodologies that we use, like horizon scanning, which involves proactive and systematic search for emerging innovations that are likely to affect healthcare. Technology needs assessments, which are used to identify and prioritize technology needs within specific healthcare settings. Delphi method, often used for generating consensus among a panel of experts about the potential impact and feasibility of new technologies, and most recently, real-world data analysis, which leverages data from healthcare settings to identify gaps that can be addressed by new technologies. As a case study, which is well identified as innovation, I like these examples, like Google Health's AI system in diagnosing diabetic retinopathy. They interpret retinal scans with a level of accuracy comparable to human ophthalmologists. So it can significantly reduce the burden on specialists and expedites the screening process. The second example can be remote patient monitoring systems, which are identified as a key area of innovation as well, due to their potential to improve chronic disease management. They enhance patient engagement, reduce hospital readmissions, and allow better management of chronic diseases. So what tools or technologies we can use for identifications? Of course, the new trend, AI, artificial intelligence and machine learning, may have important roles on this, and, sorry, it's not working. Big data analytics, and also real-world evidence integration. To assess innovations as the next step, we assess clinical effectiveness. So it's essential for determining if the technology improves health outcomes. Safety, it's critical to ensure that the benefits outweigh risks. We assess also cost effectiveness for determining the value for money. And patient-centeredness, which ensures the health technologies align with patient preferences, needs, and values. For the assessment, we have different models, like comparative effectiveness research, which involves directly comparing existing healthcare interventions to determine which work best for which patients and which pose the greatest benefits and risks. Secondly, multi-criteria decision analysis, shortly MCDA, which uses systematic approach for ranking and prioritizing alternatives when multiple criteria exists. And lastly, predictive analytics in assessment uses statistical techniques and models to predict outcomes based on historical data. Okay, after assessment, of course, that's the, in real life, most important side, the regulatory considerations. In general, alignment with regulatory standards ensures safety, effectiveness, and high quality with compliance with regulatory frameworks, applied by the national authorities. But for this kind of innovative technologies, we need something further. For these breakthrough innovations, expedited pathways facilitate faster review and approval to let innovative health technologies reach the market in a shorter time. And encourage more investment and focus on developing groundbreaking innovations. So these kind of strategies are crucial to balance the need for rapid access for innovative treatments with the necessity to uphold safety and efficacy standards. For this purpose, we can take digital health implementation as a case example. first, we need to identify it, so needs assessment should be done to pinpoint gaps in current healthcare delivery, and stakeholder consultation is an important step here to have feedbacks of the relevant stakeholders. Then for the assessment, we assess efficacy, usability, and regulatory compliance of this specific technology. And lastly, integration into existing framework with systematic incorporation. So basically, you can think about like implementation of a telehealth program for chronic disease management. I'm just trying to be quick for the time limitation, but we will have time to discuss further at breaks maybe. Okay, for the stakeholder engagement, it's essential for the success of HTA. It enhances legitimacy, transparency, and utility of assessment process, brings vital perspectives, contributes to a holistic evaluation of health technologies, and drives more balanced and impactful healthcare decisions. So every stakeholder has unique roles in terms of contribution to these processes. So mainly patients, clinicians, policymakers, and industry representatives can be stakeholders on these processes. But even at this stage, we may have challenges in recommending these innovations after our assessments. Like what? For instance, we can have a problem in balancing cost, access, and innovation, because we have cost challenges like high cost of new technologies, budget impact. We have access challenges like equitable access and healthcare disparities. And we also have innovation challenges like incentivizing innovation and regulatory and market challenges. Another challenge, main challenge, can be dealing with high uncertainty in early stage innovations. We can have two examples for these evidence gaps, like limited clinical data and predicting long-term outcomes. And the second challenge can be methodological challenges like adapting HTA frameworks and dynamic evidence generation. So we need to overcome these barriers with enhanced collaboration between stakeholders, adaptive regulatory frameworks, financial strategies to support innovation, and promoting technology assessment literacy. So is it that much difficult? Of course, we have success stories as well for HTA recommendations. One is the HPV, human papillomavirus vaccine introduction in the UK is a good example because they involved this vaccine in their national vaccines programs, and it resulted in a significant reduction in cervical cancer cases among vaccinated population. Rapid integration of telehealth during COVID-19 is a good example because, I mean, the adoption of these kind of telehealth technologies is accelerated in this period. Due to lockdowns and beyond, it is utilized for the continuity of care. And lastly, more conventional approach, but I mean, compared to other ones, but approval and use of biologics for rheumatoid arthritis. It significantly improved treatment outcomes and transformation of the therapeutic landscape. So for the closing thoughts, I think it's better to repeat about stakeholder engagement. So we have different representatives here, so I believe it will be good to have a call to action to achieve using HTA and increasing access to innovative technologies. We need to engage proactively, invest in HTA literacy and capacity building, support innovative funding models, foster collaboration, and advocate for adaptive regulations. Thank you so much for listening to me. I'm looking forward to discuss more.
So, thanks a lot, Biror, for your presentation. And now I move quickly to Elena Peteros, that is supposed to be connected online. Elena, can you hear me? Can you hear me? No. Okay. We can go over. So please, would you like to give the speech to the next speaker? So Diana Lakinova, that is make a presentation on the topic on the international experience of orphan drug reimbursement. Diana is the head of health economics, market access reimbursement for emerging market, EMEA. Please, the floor is yours.
Good afternoon, colleagues. My speech will be in Russian. I'm very happy to be here today. I will report on the orphan diseases. Today I tried to count how many years I've been dealing with the orphan, rare or ultra-rare diseases. I realized I've been doing this for 15 years, so sort of anniversary for me. This topic is very near and dear to my heart, not only as patient access and HT, but also emotionally, because of course there is a patient behind every orphan disease. And I've been working for many years on getting access to certain type of drugs on the market. This is a short disclaimer. I work with Johnson & Johnson, emerging market, African countries, Middle East, Russia, Kazakhstan, and a number of other CIS countries, Moldova as well. And I would like to start my speech by drawing your attention to this number, 400 million, a little bit less than the population of the European Union and a little bit more than population of US and Canada put together. This is the number of people in the world who are believed to have orphan or rare diseases. So as you can see, the number is quite significant. And again, there is a patient behind every figure. Their stories are unique. They have their own fears, their own hopes. And this disease is not as easy as it might seem. 8 years is what you need in average in order to diagnose a patient with a rare orphan disease. 7 physicians in average see a patient before the patient reaches diagnosis. Most patients don't have the right diagnosis. At least once they're misdiagnosed and they get wrong treatment. I already said 400 million. These are not all the patients that have the treatment. Speaking about emotions, there is a movie from 2010. It is called Extraordinary Measures. The actors in this movie is Harrison Ford and Dana Fraser. And they demonstrate how a patient and the patient's family are faced with a disease, untreatable. It's a pompe disease. If you're interested in understanding how a family deals with the situation when there is no treatment and when they're trying to find this treatment, you will see their difficult journey that they have to have. 27% patients with rare diseases are visited by expert centers for their diagnosis, and they are not necessarily seen by the specialist who would properly diagnose these patients. Now you see data for 2021, and you see that the costs keep growing year to year. This is the costs of sales of prescription drugs in 2021 accounted for orphan and drugs. We see that the number of drugs for orphan disease keeps growing, and so is the cost. Of course, the burden is mainly with the state. If we look at the European countries, we will see that almost all the European countries reimburse the cost of orphan disease. Sometimes it's 100% reimbursement, like in Germany. Some other cases, it's partial reimbursement, but basically, in most cases, the government has the majority of the burden. Yes, we do have some restrictions of budget. We have some geopolitical anomalies, maybe climate anomalies. We heard the colleague from Turkey. They have floods, they have earthquakes, also in the nearby countries. Of course, all of this affects the budget and the way in which the government can reimburse these drugs. The experience of emerging markets shows that if the government doesn't reimburse these costs, no one will be able to provide an ongoing treatment of patients with orphan diseases. What about Kazakhstan? 76,000 patients live in Kazakhstan with rare diseases. Of those, 24,000 receive treatments from the state. So these are not only rare drugs. State budget is the main source to provide for the drugs for orphan disease. There is the public fund Kazakhstan Khalkana, which includes 8 orphan drugs, and 57.4 billion tenge was allocated to this fund. This is an additional source for financing, but mainly reimbursement comes from the state budget. Let's look at the neighboring countries. Many in Kazakhstan have probably heard about the public foundation, which is called Circle of Good. This is not a charity fund. It is a fund that was established by the president. It is funded by the additional tax at a rate of 2% on an annual income of individuals with the income of $54,000. So it is a part of the tax system. It includes 91 zoologies, 97 drugs included. If we look at the budget for this year, we will see $1.9 billion. The budget is quite significant. And this is spent just for the children with orphan diseases, the children up to 18 years old. But this is not the only source of financing. There is a federal budget of about 0.7 billion. These are the high-cost nosologists. And we also have regional budget that also covers orphan patients. You see that the burden is quite high. What can be done? The budgets don't grow, and we need to find new ways. We need to invest money into infrastructure. There might be some natural disasters that require the attention and the sources from the state. So what can be done? What is the best approach to this issue? We today at the HTA conference and in this region we discussed quite a lot the WHO on the threshold of readiness to pay. the Commission on Macroeconomics back in 2001 of the World Health Organization issued a report on macroeconomics and health, investing in health for economic development. So it's the readiness threshold, which is based on 3 GDPs. It can be used to assess different technologies, including innovative technologies that are introduced in different countries. We can look at this mechanism. It was introduced in the country in an isolated way. They tried it one way, they tried it the other way. Many articles were published whether there should be reimbursement or not. And the same authors who prepared this article in 2016 published another article. So again, they talk about the cost effectiveness. I can quote, above all, the indiscriminate use of a threshold of 3 times GDP per capita when making national funding decisions or to set the price of reimbursement cost of a new drug or other intervention must be avoided. WHO choice has never recommended this practice, which would be a misrepresentation of the purpose and meaning of the GDP-based threshold proposed by the Commission on Macroeconomics and Health. So what is the recommendation then? Multi-criteria analysis should be applied. We have discussed this analysis quite extensively today. We also discussed restrictions on cost effectiveness. My father is a mathematician, so I love mathematics. And I love knowing how much do we need to pay for an additional year of life. We know that one of the HTA agencies discuss what type of model should be used in order to forecast the curve of survival rate. So what can be done? There are no ready solutions. We always need multiple criteria. So we have to adapt the existing solutions on the market. So I would like to say hi to our Polish colleagues. I'm not an expert on the Polish market, but figures speak for themselves. We see that the market of drugs that are reimbursed by the state is increasing significantly. You can see on the bottom comparison to France and Spain in 2021-22, the number of orphan drugs has skyrocketed. And the precursors to that are the actions taken by the actions and preparation for HTA. And another important item is the increase in expenses of the overall financing of healthcare. Without that, it would be impossible to get these unbelievable results. Thank you. If there are any questions, I'll be ready to respond. Thank you, Diana. We are behind the schedule somewhat. I've been told that Yelena is ready to connect.
I'm here, I'm unmuted, the camera is on.
We can hear you.
Ah, finally, somebody can. Hi, Jackie.
Hi, Elena.
So, can you hear me in the room or not? Because before you could not, and I was connected.
I hear you well.
Lovely. So I'm going to try and share screen. First of all, I'm very, very sorry to be missing all of you. Instead of going from Barcelona to Kazakhstan, I had to go home because of a family bereavement. So let us see whether sharing screen will work. Okay. Hopefully you can see my screen with a lot of different things.
No. Yes.
You cannot see my screen?
Yes, currently we see.
Yes or no?
See. Yes.
Okay. So first of all, to say that I will be discussing a little bit about real-world data, real-world evidence, actually. There is a little bit of a contradiction in clinical data, and I will come to that. To say that the concepts are quite complex, so I'll try to keep things as high level as possible. But of course, we can send any material that's necessary, and we welcome questions, as I'm not going to be there in breaks and so on. So I wear different hats, and in the name of, yes, that's better. In the name of transparency, just to say that I do wear different hats, so the views here are my own and not representing someone else. So in terms of clinical research, traditionally, we have different terminology when it comes to discussing design. Over the past few years, we have had a lot of discussion about pragmatic trials, about real-world evidence, about routine data. Routine data is not heard so much in Europe, it's starting to be, but actually the utilization of these types of data and these types of evidence has been there for a very long time. Over the past few hours, the term efficacy was heard, the term effectiveness was heard. These terms are difficult to translate, and the nuance, the difference that they might contain, is very often lost. So when we discuss traditional clinical trial design before market entry and we refer to efficacy, we are utilizing and writing protocols and conducting trials that are optimized to demonstrate the best, in the best possible way, efficacy under ideal conditions. The question we ask then is whether an intervention works under ideal circumstances for a particular indication in a particular study population setting. And of course, when it comes to utilizing the said intervention in our real world, speaking all of us today from real world experience, this question changes because the question becomes whether a particular intervention works in real world practice. And this means in combination to other interventions, as it may be affected from a learning curve, for example, in surgery, or as it may be affected from access to it, timely access to it, as it may be affected from heterogeneity in the population characteristics, to speak but by one very basic and traditional difference we have in metabolism in R&D between Asian populations and European populations or Caucasians. So, and of course, critically, there is a need to discuss how our technology may be changing across its life cycle and across different types of disease progression. So in this respect, we have had a very urgent need to tackle uncertainty and to move towards what we call not evidence-based, but evidence-informed decision-making, evidence-based practice. And in this respect, identifying treatment effects of safety needs to be done in a manner which addresses these aspects. I think for most of you, this is now particularly because we've seen effects of interventions that may have worked in clinical setting, but not necessarily broadly or differential effects. To speak of one differential effect with evidence coming out, emerging and changing aspects of safety. We all have COVID vaccines very recently, but also because we have new treatment combinations. A game changer has been, of course, oncology. It's my background. Because of the different types of genetic testing and the advent of cellular and gene therapies, which we regulate as ATMPs, as advanced therapy products, and critically, the combination of these things, because of course also we may have a companion diagnostic, so a test, which may be differential intervention and potentially combined with a therapy. And last but not least, we also have digital transformation, and I think you'll hear about it a little bit more later on transformed sources of data. Now, there are some implications, including for LMICs for development, that HTA affects, but reimbursement and coverage effects too. And this has to do with how we invest in the pipeline and how many molecules or how many candidates. I mean, this is for pharmaceuticals from ABPI, but similar challenges are across all types of development because it usually takes a very, very long time, again, in particular populations to reach for one medicine, for one drug to reach all patients. And of course, what one should consider is when we say reach patients, which are these patients, under which market conditions we reach them, and whether there is potential for our WE to actually change that. There is some information there to see the actual change from FDA. It's fairly recent. It's extremely high, and very often the prices are determined largely by what is spent there. And of course, this also does not mean the molecule that makes it to the market, but many others that were tested before to cover the entire R&D cycles. Traditionally, when you have a clinical trial, you are able to be controlling very robustly whom you're including and to ensure sound reporting and even to some extent to ensure high quality data. The provenance of real world data and the quality that they have and very often the availability because of lack of infrastructure. And for many LMICs, this of course is a challenge, but it's also a challenge for high income countries, for remote areas, for countries without very good or well-developed infrastructure, or even when there is infrastructure because of the heterogeneity we may encountering in how we collect data. So lack of harmonization in requirements and lack of standardization in reporting. And this, of course, hits us very strongly when we reach the HTA level because we have, particularly when we have accelerated entry, because you don't want to compromise access to patients, or because we have rare disease, or because we have limitations in performing for ethical reasons, well-controlled trials, we reach the point where we have very few data to assess at HTA level, or we have interim data, surrogate endpoints are in place, or even if we have some real-world data emerging, this may not be comprehensive enough as we want. So there is sometimes, or more often than not, although this is rapidly changing as a paradigm in terms of determining a value, we have some concerns or some considerations in terms of how much we can trust the data sources. And here, it's important to mention why it's critical to look in these aspects and reporting. There is also a paradigm which is saying that evidence-based medicine is all about RCTs and solely RCTs, but really evidence-based medicine is all about putting the patient in the center. And if you have the tools to know, for example, thinking of disease-modifying diseases, prodrome markers and so on, genetic predisposition, who will benefit most, who will be harmed the least, it is both unscientific and even unethical not to utilize these tools to really address the needs of all patients. And again, in all countries, and for health resilience and even for global development. In this respect, we have seen traditionally, but with some delay, the guidance of 2021 from FDA, and the EMA published also a consultation paper, and I will speak a little bit about that later on. So we have started seeing taxonomies of real-world data, frameworks to inform their generation and quality assurance, and of course, a common language starting to be in place with links to costs for development and implications for what HTA and payer needs are. And it's important to know that they're when we say our WD, we're discussing very different types of data and very different type of data sources. And there's parallel guidance that we don't often discuss in HTA, but it's very critical, particularly in countries developing their infrastructure at the moment. They have to do with how electronic consent goes into place, because you want to be able to utilize for secondary use of data purposes your electronic health record, because we have new tools like AI. So artificial intelligence can actually look at narratives and tell you which population may be potentially more at risk, may even detect a safety signal. And we have seen this happening more strongly, more robustly across the Atlantic, but also Europe catching up quite strongly at the moment, including for medical devices. Now, it's important to mention yet claims data. There are some success stories from claims data, insurance data, payer data. It's the biggest, the highest breadth data sets that we have. but they're not necessarily the richest. The richest, of course, are the electronic health records. And we have new types of data emerging because of digital sensors, not only of applications, but think of glucose monitoring or think of cardiac rhythm. To have HTA in its current state and form utilize this type of data in the traditional manner that we were conducting it has become a little bit irrelevant. And we need to transform how we conduct it and via what frames. Now, there have been a few frames emerging. This is Peter Klimak's review of a couple of years ago, looking at ways to move from a taxonomy towards more quality assurance frameworks, including for HTA, from collaboration we have had from UNETA for HTA specific registries. But number one, phase 3 is transforming. So most companies, most manufacturers are looking to transform how they design their phase 3 trials so that they're continuous cohorts, continuous monitoring, both for safety reasons and to inform pipeline development. And HTA is also starting to sit in terms of life cycle approach much, much earlier. We need to start at horizon scanning. So what identifying potential RWD sources needs to start also much earlier in this respect. And in this effort, we do have at HTA, this was established in 2020, moving from regulatory coverage and interaction interest group. We have real world evidence and AI interest group, and we started looking at uncertainty more methodologically across HTA a couple of years ago. There is some information for the AI group, but I want to discuss a little bit more what we have done about RWE and uncertainty in the next 2 minutes with DIA. So the group was formed to explore, of course, uncertainty, but a large part of the uncertainty has to do with RWE. It's a published paper, and we looked at the taxonomy for sources of data, and we also looked at what happens across the life cycle and the payer questions we discussed. So you see, you heard a little bit, I think Lou spoke about access to information, access to data, utilization of data. Question is, of course, when it comes to HTA, which information is available and which one is unavailable, at what point, the accuracy, potential conflict, who's assessing it as well, whether it's readily understandable or whether it can be transferred, and many, many other aspects about mitigating it. And because we're discussing value judgments and value propositions, the concept that there enters is looking at how to create parameters that allows us to look at legislative aspects, societal aspects, but also potentially political and economical needs that may be there. And I think this is much stronger when it comes to LMICs, and it's becoming much stronger as we move forward also for high-income countries. Now, in terms of LMICs, and it's important to remember that the population in LMICs is also exponentially increasing from the 60s to today. There is an opportunity to streamline HTA and also do more straightforward RWD collection and RWE synthesis if infrastructure is put in place, because you don't have to tackle a lot of old material if you like. You can streamline and select prioritization questions. On the other hand, there are some need for global health partnerships and selecting, and we have mechanisms of regulatory reliance, but we also have a lot of challenges in terms of transferability and a lot of challenges because of legal, regulatory, and potentially technical interoperability. And I think the concept of reliance is not well known for most. It's a concept by which organizations like the European Medicines Agency are supporting market entry and assessment, including from a quality assurance perspective, without compromising sovereignty of countries that want to conduct regulatory assessment. I think for HTA, we also need to start looking in that direction. And I'm very, very happy that we are here discussing this. So I thought we should also mention it, and should also mention that we need a little bit stronger voice when it comes to HTA and RWE for these countries. And then trying to keep it very short, in terms of finding out a little bit more, we have done a series of 8 webinars with examples of how it's currently, RWE is currently utilized across HTA, and why we think it's important to move towards more continuous frameworks. And the RWE and AI group for DIA is now starting to look at 4 separate streams, including for medical devices, for personalized medicine, to check the guidelines against new clinical cases and for horizon scanning. I hope I was on time. Try to keep it to 10 minutes. Thank you.
Thanks, Helena, for your speech. Now we move quickly to the last speaker, and that is Zaid Zoldasov. Sorry for if I'm not pronouncing well. That is your surname. That is HTA manager for AstraZeneca in Kazakhstan. Please.
Thank you very much. I will try to be brief. I would like to thank the organizers for the conference. Talking about HTA in Kazakhstan and comparing it with other countries, I would like to point out that this process was introduced to Kazakhstan in 2008, so it's quite a recent area of the healthcare system in Kazakhstan in compared to other countries. Rating assessment of the cost effectiveness of Kazakhstan according to the international agency Bloomberg showed that Kazakhstan in 2012 was 111. In 2008 it raised a couple positions. And if we look at this data and at these rankings, if we look at the formulary commission and introduction of HTA in Kazakhstan, we can suppose that one of the factors that promoted the improvement of this indicator is the introduction of these processes. Talking about the key differences of the processes of carrying out HTA, we should mention that we saw this study of several European countries, and the main difference was as to who initiates the application as well as the cost. Talking about Kazakhstan, in our country, we don't have a published schedule of decision-making process pertaining to HTA, and there is no process of the cost discussion. Comparative analysis shows that basically, as far as all the indicators, these processes are quite similar. The difference is only whether or not a deterministic and other analysis of sensitivity are carried out. In Kazakhstan, across all indicators, the indicators are assessed during the HTA. We already talked about the threshold of the economic effectiveness, and now we see the data, which shows that not all the countries have the officially adopted threshold. In some countries, it's a range. In some other countries, it's a share of GDP. In Kazakhstan, we don't have the officially adopted threshold, but unofficially, when making the decisions, one of the criteria of decision-making process alongside the clinical data is the threshold GDP per capita, per quality. How does the HTA process affect the medication selections? Is that a barrier? There was a study in the 6 European countries that shows that when introducing the HTA, the timeline of the access to the medicine is reduced from 25 months to 14 months. We believe it would be interesting to show the results of this study. There was the reduction of time for the medicine for oncological diseases, and here we also see the timeline for the approval of new medicine for oncology. The shortest time was in Germany, the longest was in Belgium. The average indicator on the 7 analyzed countries was 477 days. We talk about the time of reimbursement and the processes of reimbursement in Kazakhstan. We should mention that we do not have official data on that. What is the timeline of the reimbursement of medication? We do show the process itself, and we should mention that in Kazakhstan we have the simplified financing system in which it is the industry that reimburses and the agency carries out the official expert opinion on that. According to Decree 215, the timeline is between 3 to 13 months, but this process depends on the agreement. All the other processes, which includes the expert opinion of that is carried out by the Ministry of Healthcare. Now this timeline, it is well defined, and it is 50 working days. As you can see in red are marked the processes that as of today are non-regulated. So we don't have a regulation for the decision-making process for the Formulary Commission, and we also have delays in the decrees that are based on the decision made. We already talked about patients' involvement in HTA. So I would like to mention that the best practices of patients' involvement are in countries such as Norway, England, Netherlands, and Australia, whereas 25 potential challenges are identified that need to be resolved, such as assessment of the patient's contribution, lack of patients' will to participate, needed time and cost, and in order to reach the consensus, recommendations need to be developed. Today we carry out this comparative analysis, so we wanted to look at the experience of some countries, and we would like to draw attention to the publication that talks about the medicine reimbursement in Poland. So the decision on the reimbursement is issued for 2 years. The first one, the second one for 3 years, the third one for 5 years. So this is the procedure with the revision. Another important issue is the fixed margin, which is 5%, as well as the restriction of the maximum price for the non-patent medicine, not more than 75%. Today we talked about the innovative medicine on the market, and here we see that the experience is such that there is an additional budget in the amount of 5% of the overall budget for the reimbursement of innovative ways of treatment. And next, I would like to share experience of France, which carries out HTR every 5 years after the first issuance of statement of the listing. If there are no negative data, the application is subject to a simplified procedure to carry on with reimbursement. I also did this comparative analysis of other countries that have a longer experience of HTA. Here we would like to outline a number of issues that need to be resolved. The short-term issues such as the regulation of issues of reimbursement by the Formulary Commission, meeting the deadline of decrees and decisions, definition of the range of prices for non-patent medication, midterm issues, identification of differentiated threshold of effectiveness, as well as orphan status and other factors, negotiations on price and additional budget for the innovative ways of treatment. Future issues in Kazakhstan, right now we don't have the experience of engagement the patients into the HTA process, so this is an open issue for now. Thank you for your attention. Thank you, Zaid. Dear colleagues, we're very much behind the schedule, so I have a number of suggestions. First of all, let us have 45 minutes for lunch instead of an hour. And let us continue at 2:20. All those speakers who will speak after lunch, please respect the timeline, because any additional 1 or 2 minutes will mean that we have a significant delay, which we already have right now. As for the last speech, that's an interesting issue that was raised by our Kazakhstani colleague, talking about the time in difference in getting access and for the refurbishment. Tomorrow at 9 o'clock, we're going to have a satellite session with the participation of Kazakhstan. We're going to have the results of this study. We can also discuss the barriers and ways to overcome those barriers. We will continue the discussion tomorrow. The lunch is downstairs, first floor.
В ресторане на первом этаже, в лобби ресторана.
Yeah. Please. Yeah, it's good. Yeah. After the 1 minute, we will start. We will not wait other participants because we don't have enough time. Yeah. I know his lunch is.
Maybe they can do an announcement.
Yeah.
While you're starting.
Yeah. Коллеги, мы начнем.
Colleagues, we will go ahead and start this session despite the fact that we are not in our full house. Not everybody's here yet, but still, let's go ahead and start this session. Colleagues, is everything on? Colleagues, we will start this session. Or do we have a photo to take? And there is a video.
Colleagues and the participants and the speakers, we are starting our second plenary session. Дорогие коллеги, мы начнем.
Dear colleagues, we are starting our second plenary session. Allow me to provide the floor to our first speaker in the panel session, Mr. Kostyuk Alexander, a scientific advisor to the Kazakhstani Association of HTA, evidence-based medicine, pharmacoeconomic research, the key barriers and factors enabling the use of HTA. Well, can you please put my slides on the screen? I hope the audience will be here while I am presenting. Well, I would like to thank all the people who are already here for your punctuality, for being with us. We will be improving our time management. Therefore, let me start. Well, actually, assessment of the technology as a tool to select the best technology, the most appropriate technology is currently functioning in 80 countries. It depends on the differences in estimates. But yeah, different countries have their own specific issues, problems, and challenges with the things which relate to the implementation of this process. And I will not be focusing too much on some basic definitions of the technology in healthcare, but what are the differences in the definitions, especially for the HTAI definitions, where it is said that this is a process with the use of specific criteria which allows to identify the value of the use. If we look at Kazakhstani realities, in line with the key legislation in healthcare, this is the healthcare code of the Republic of Kazakhstan and healthcare system. It's closer to the previous definition of HTA, which changed about 3 years ago. Comprehensive comparison of economic, social, healthcare outputs used for the decision making in healthcare system. Well, here already some of our esteemed experts during the first half of the day were speaking about value definition, and this is a key now for HTA because definitely we want to simplify the decision making processes sometimes, but yet the decision makers and policy makers of many countries face an inevitable problem when there are some groups of population who also need some efficient technology for diagnostic and treatment, but at the same time some classical criteria within the cost efficiency are not actually meeting all the criteria. Therefore, it's more complicated. If we look at the value, it has a lot of aspects. Professor Garrison was referring to the value. Ours is in terms of our realities in the Republic of Kazakhstan. You can see on this slide clinical efficiency, safety, economic impact, social, ethical issues, legal, organizational, and for patient outcomes for caregivers and for the families and for the overall population of the Republic of Kazakhstan, for general public. About the classic current definition of the HTA, you probably notice this is about at every level of the actual technology implementation, development, manufacturing, and you can see at which stages it is applicable. If it's about clinical trials, it's early dialogue. If it's clinical trials already, it is about the market approval and market access authorization. If it's about classical HTA, then it comes at the level of when the technology is about being implemented within the insurance packages or the guaranteed volume of free of charge medical services. And at the same time, there are different approaches to the analysis of proof of justification risks, of risk analysis, and other aspects. On this slide, you can actually see the key technology in healthcare because in Kazakhstan we had a very quite complicated journey with HTA before 2018 for 7-8 years. The HTA in Kazakhstan was not in use at all in the context of drugs. It was mostly only for surgeries and other interventions, even though more than 2/3 of the technologies to be assessed in healthcare are drugs and medicines. Well, for the past 6-7 years, we are trying to fix the situation. We were able to streamline the process for HTA to include broader aspects of categories, but there is still room for improvement. Here you can actually see the overall scheme of the types and approaches to the HTA in line with the international practices. What is the duration of such assessments, how long they take, and what are the methods and methodologies used. The two key methods are the clinical characteristics of the medicines and also economic assessment method. Probably this one is valid. It approaches economic modeling and simulations. Not all technology needs economic assessment. Here you see some ranking at which stage and who should be responsible in the models of healthcare for the specific stages of HTA. Well, when we refer to the implementation of HTA in different countries, the big impact was about economy and level of maturity of the healthcare system. On this slide, you can see how it is supposed to be evolving based on the resources available in different countries. For HTA, if we are speaking about immature systems, well, that's mostly about the most critical medical interventions, and for the low income it is about using these processes for the primary healthcare services. Middle income with limited coverage, I believe we should look at all the guaranteed financial packages of medical interventions and medicines. Kazakhstan is in this category, but currently we are not doing everything we are supposed to do in the system. So it's not a complete system yet. For developed countries, it's marginal analysis for the expansion of package. On this slide, you can actually see our studies. We engaged in to try to facilitate categorization and to put them into specific three levels: political, social, and individual levels, to group them into these three major categories. There are factors and success indicators which are promoting development of this process in our country. For individual, it is about very brief and very targeted reports, key areas, access for specific studies, and important interaction between policymakers and the manufacturers on the public level or societal level. The advantage of our system is the existence of the organizations to engage in HTA, adequate time between HTA and implementation or development specific policies. There is a specific structure for the decision-making processes based on HTA. Or on a political level, we have accessibility to specific HTA for policymakers, awareness among our policy makers, legal and legislative support for HTA. On my first slide, I said that HTA is actually stipulated in the healthcare code. Referring to barriers, well, we divided that into three groups as well. And in this terms of facilitation, individual level barriers, insufficient financing and human resources for the corresponding studies, not enough human resources for understanding and interpretation of the HTA. This is something which needs improvement, and a complicated format of HTA results presentation, very long reports on specific requirements which are not very clear to understand for policymakers. On a societal level, not engaged enough levels from the patient side, not sufficient data for specific prices of the medicines or the efficiency of such drugs. And in uncertainties for the HTA results. It means that recommendations of HTA don't always have specific implications for decision making. There might be an HTA, but decision might be an absolutely different in terms of how it is done. Political level barriers, no incentives. There should be incentives both in the healthcare system and also at the level of the specific hospitals. Insufficient context between manufacturers, policymakers, and HTA developers. And in Kazakhstan, we don't have specific instructions and guidelines for HTA in Kazakhstan. This is one of the most sensitive gaps because, yes, we have bylaws, we have an order and methodology criteria, but such guidelines are critical and necessary for our system to implement HTA full-fledgedly. Further empowerment and enforcement certification courses, master degrees, PhD, and other educational programs, improving technology approach to HTA, developing the professional level of HTA to increase its value and applicability of results. Next, for the legal basis for HTA, because with the key definitions, it is in the healthcare code already, but it's very in deep level. So it should be deepened and more detailed to make it more gradual for the specific understanding, as colleague already mentioned. So there is probably a need to look at the recommendations of having a threshold, not to have this unofficial status. But even though there are some concerns with our policymakers about the readiness to pay, so it concerns all the stakeholders of the process. But for us to enable the system and to make it balanced, we need to have some specific criteria. Particularly, we mentioned in one of the presentations, it was about affordability for the countries with low and middle income, including Kazakhstan. It's specifically about not only efficiency cost, but it's also about affordability, because we have a constrained budget compared to some OECD countries, and not already speaking about some leaders and the biggest economies globally. Therefore, affordability is a very relevant issue for us. Of course, we need to increase the volume of implementation of HTA. As we previously said, unfortunately, it does not cover packages for the mandated volume of free of charge services, and also the threshold for readiness and analysis for decision making. Of course, improving quality and implementation. Transparency. There should be checklists for decision makers. There should be guidelines for HTA to publish results, to discuss them with all stakeholders. Now the result discussions is almost non-existent. Unfortunately, this is one of the weaknesses we currently have. Thank you very much for your attention.
Alex, this was a very good overview of what's going on in Kazakhstan. So I guess now we will have the privilege to listen to Professor Garrison again. And we listened to him in the morning session already, the past president, Professor Emeritus School of University of Washington. And you will talk to us about value and impact of health technology assessment in the healthcare system. Thank you very much.
Thank you very much. And please tell me to stop. I mean, like 1 minute, 2 minutes, whatever, okay? I have trouble. I try to watch it, but I don't do a good job. Again, it's a real pleasure and an honor to get to talk to you again. I'm going to just keep my economics going. And actually, tomorrow morning, I'm going to have a session, a longer session if you want to hear more about my perspective, or maybe a U.S. perspective on economics of pharmaceuticals, okay? So economists we have a fancy word for generalizations called stylized facts. So when I think about the world, you think broadly, like qualitative facts. What are the facts when it comes to medicines? Okay, now, as I've said, I've worked on hospital care, I've worked on physician care, and I've been in the industry, so I've worked on pharmaceuticals. What I really want to talk about is access to pharmaceuticals, and I view them as globally, and they're different than doctors in hospitals. American doctors do not come to Kazakhstan. Medicines invented in America can come to Kazakhstan. They're global public goods. We can all benefit, and we have a different market design for that. And the market design is, it's really, it takes about, we have a patent system. The patent system is you get the invention, you get the patent, you have 20 years of patent life. It takes about 12 years to get to the market. So you only have about 8 years left. And during that period, we grant you a monopoly. That's our market design. That's the reward for the innovation. And then we we know that the industry has an incentive to extend their monopolies. We also, it's not all monopoly, there's oligopoly. We have competing organizations, right? So, but that's the market design that we have. And these are global public goods. Now, How many medicines do we invent in a year? Well, in the US at least, the FDA has approved over the last 10 years 46 medicines a year. It's not like devices where we have thousands of changes or hundreds of changes. We're only producing 46, and it's not going like this. It's pretty flat. And we're spending more money. We're spending over $100 billion a year in R&D for these 46 medicines. So what does that tell you? If I divide 100 billion by 46, I get 2 billion. So the cost of developing a medicine is roughly $2 billion. But once we invent them, the marginal cost can be very low. For example, the HIV medicines that we use, India can produce HIV triple combination therapy for $125. Now the price in the US is still $20,000 to $30,000 a year because we're financing the next generation of HIV medications. So but the costs are rising. And so if the industry, so we all complain about rising costs, but if the costs of developing are going up, the only way it's sustainable is for all of us to put more money in the pot to pay for these advances. And the important thing about these medicines is, for the most part, biology travels across borders. Economics are different. The prices are different here, the doctors are different here, and so on. So we got to keep that in mind. This information is a global public good, but I would want to say, we have at least two kinds of major kinds of information. We have the information in the product and what we know of in the clinical trials, and then we have the real world data, which is another kind of information. And as I said, we have incentives for companies. We require companies to do trials, so we have information at launch. But we don't require companies to collect data for 10 years, and it would be too expensive, so we don't do it. So we have a tremendous market failure there. Now, economic theory says the optimal financing of these goods that we all benefit from would be based on ability to pay, and so the richest people in the world would contribute more, and the poorest people might not contribute at all. But we contribute according to our ability to contribute, and that would be the optimal way to get the benefit that we all would get from having more science-based medicine. Now, I want to say a bit about HTA, then I'm going to talk about the drug lag. It means it's the delay in access to medicines, okay? And we've talked about this. We saw a slide already. I mean, we know that HTA is not just about medicines, it's about everything. It's about priority setting, scoping, topic selection, assessment, appraisal. Assessment is essentially doing the analysis. Appraisal is, do we agree to finance it? Do we bring it into the health benefit package? And that, so the biology travels across border, but the economics does not. So if we can afford it in America, it doesn't mean that it can be afforded that Kazakhstan can afford it. So so we decided it was good value for money for us, or Germany decided a product was good value for money for Germany. It doesn't necessarily mean it would be good value for money given your resource constraints in Kazakhstan. But I would say, but biologically, the FDA and EMA said they did a trial, and they said, forgetting the price, the product works for these people. This is the indication. The benefits outweigh the harms. Now, as a global citizen, I would say, well, ideally, if the benefits outweigh the harms, just biologically, clinically, I would like for everybody in the world to have access to that. Why wouldn't I? But we don't all have equal resources to finance that. So that's a different issue. Now, just some key things about we've been doing health technology assessment for probably 50 years now. I mean, we had the Office of Technology Assessment. It's been around at least 30, 50. It's a global thing. Now, look at this meeting. As I said, 40 years ago, maybe there were 20 health economists, and we know the whole history of HTA. There are multiple ways to do it, and we're all trying to learn what is the best way. But I think, as Iga emphasized, there's always politics. What economists call political economy. So as the theoretical economists, I sort of say, this is what would be ideal, but wait a second, there are interest groups. The industry, you call them stakeholders, but the patients want one thing, the industry wants one thing, the government wants so we're trying to work out a decision with all those different political groups. Now, when we talk about HTA, it's about everything, right? But in principle, what do we mostly think about? We're talking about pharmaceuticals, these innovative pharmaceuticals. To start, that's when we talk about it in a global. And in principle, it's about cost effectiveness, but people focus on budget impact and costs. And in principle, it's a scientific approach. In practice, it's very political. It's not just science that dominates, but I appreciate everybody being committed to science. Now, this is some work I did with some colleagues over 10 years ago, and we sort of said, and this is, I think someone talked about micro, meso, and macro, and it's just saying that micro HTA is looking at individual products. We can think of that. Should I bring this drug into my health benefit package under my universal health coverage? That's different than deciding how many doctors I need, what's the infrastructure I need for diagnostics, and prioritizing diabetes or the social determinants of disease are very important. So those are different levels of HTA. Again, I'm focusing more on the micro level. Now this is a slide from the European Federation of Pharmaceutical Manufacturers showing the drug lag, and I can't actually read it from here, but at the left you have Germany, and Europe more broadly. That's how many medicines were approved, and this is how many years later. So this, or I should read this, from 2017 to 2020, there were 160 medicines available in Europe, but only less than 20 of them were available in Kazakhstan in that period. And you can see that it really is more dramatic than you might think. I mean, there really is a drug lag problem. We know the biology works in all these countries, but people don't have access. And this was another slide showing the same thing. This is from the Pharmaceutical Research and Manufacturers, showing that in the Asia-Pacific region, they only get 20% of the launches. So that's to me, that's a tremendous system failure. As a global system, we invent these medicines, and people are not getting access in a reasonable time. Now, HIV was you'll recall, HIV was a cure. People were dying from AIDS. And for years, the medicines were not available in Africa. And millions of people died before the developed countries said, this is not a good thing. Okay, we've got to do something about it. And so we started to finance access to medicines in Africa. But, the same problem occurs in all disease areas. So we talk about, you hear the terms transferability and generalizability, and they're treated as synonyms, okay? I make a distinction. I think about transferability as that this information will move across borders. So Kazakhstan, I mean, you can look at what NICE did. You can look at what Sweden did. And they all do a similar dossier, even though they're moving to joint clinical assessment. They're trying to cut down on the duplication. But the biology travels. The trials are described the same. And so, you can read that. That's transferable. But again, the appraisal, and is it cost effective, would it be cost effective in Kazakhstan if it's cost effective in France? No, that wouldn't follow. You have to look at the other conditions. So that's generalizable. They aren't generalizable, but the biology is transferable. The other stylized fact, again, once we've spent the $2 billion per product, and every product you got to think, okay, for every 90% of the products failed during development. Most of the products that I worked on failed when I worked at Roche, okay? But there were a few of them, and our market design is the winners get big returns, billions of dollars. And they have to finance it. To make the system work, the winners have to be able to finance all their investments that didn't succeed. And so that's a complicated aspect of that. But anyway, I think that we know that, say, small molecules, like I mentioned HIV medicines, could be made for $125 a year. Then you say, well, now we have a lot more biologics and biosimilars. I don't actually know, and I'm sure it varies, what does it cost to actually make a biologic or a biosimilar? In the US, the prices can be $100,000 a year. I know oftentimes it doesn't cost $100,000 a year, but that's how we finance it. But, but when I say, if I want to transfer it to Kazakhstan, who doesn't have the ability to pay of the United States, I would say, okay, I would like there to be a lower price in Kazakhstan that they could afford, and if it's greater than what it costs to make it, then it's viable. Okay, now the question is, well, why doesn't this happen? Why do we have these drug lags? And I think you can think about, given that it's so low cost, on the supply side, you can say that the industry has limited incentive to go to small markets where they're not going to get a lot of money. Now, we know, so that's the supply side. At the same time, the Ministry of Health has a limited budget, and they've already done their analysis on what they can afford. So they don't necessarily want to bring the medicines in this year. There's this incentive there. So we don't actually know how much of the delay, how much of the lag is due to demand side versus supply side. And then we have parallel trade. So the industry is worried about low-income countries buying it and then selling it in high-income countries. That undermines the thing, or external reference pricing. So those are other factors that play. Now, this was a report from Zoltan Kalo, who was here 2 years ago to speak. And they basically said that owing to the lack of an efficient HTA system in low-income countries, it's difficult to implement price negotiations based on HTA results. Again, I'm trying to push the idea of efficient HTA. So what would be efficient for Kazakhstan? Do they need to train 200 health economists to do HTA? I'm saying no, you don't need that many, okay? You can actually look at what happened in other countries and use that information. You can see, what did Hungary say? What did Poland say? And the biology travels. Now, this is the theory. Okay, so you may recognize the demand curve if you took economics. So we've long argued that we should have global differential pricing, different prices across countries, going down the demand curve. It was named after a famous economist 97 years ago called Ramsey. It's Ramsey pricing, so the price varies across country, and it's fair. It's also the FPA would call that equity-based pricing. So the monopolists could gather all that what we call consumer surplus, the green area, during the patent period. And what that would do, it would get you to Q, which is the same quantity as you would have in a competitive market. So it would be efficient. Now, but it might not be fair because in the short term, you've given all of the monopoly profits as an incentive to the monopolists. But that's the basic underlying model. Now, this is a bit old, but it's still true. On the left, we have prices in the U.S. Eva, how many more minutes do I have? So, okay, okay, you can see this is the price in the U.S. is 2 to 3 times higher than the price in Europe. Those are the blue bars. And if you could read this, you would see the orange, there's no correlation between, outside the U.S., there's no correlation between the price level and the GDP per capita in the countries. So Luxembourg, Luxembourg has a high price, okay, but still, but anyway, the point is the U.S. price is higher, and we have a low correlation with GDP per capita. So the global financing system is not working well. Now, back in my Roche days, I remember working on Herceptin for breast cancer. And so we would, say 20 years ago, we would set the price. We'd have a price in France and Germany, but we didn't have a different price in Poland. And so we knew that Poland could not afford it. So how did they do it? And, I think what happened over time is Eastern European countries and even places like the UK said, we're not willing to pay the same prices as America, the Germans, or the French. We want a discount. So we started doing confidential discounting. And that's a way to do, that is probably the best tool we have to do differential pricing, is confidential discounting based on ability to pay. But it's not working as well as it should. Now this is a recent paper. So I can point you to a paper in 2003 which said we should do this. Here we are 3 years later, a paper by Calypso Chocolatado, famous person at the Global Fund, and they're saying we should have value-based tiered pricing. And they've written this paper. Okay, okay. And I just want to end with, so the European FPA has promoted a proposal, and I don't know a lot. I know that there's a current pharmaceutical legislation going on in Europe, and they're trying to incentivize companies to launch in many countries. Because again, naturally it hasn't happened. It's been very slow. They launch in the U.S. first, the most profitable market, then they go to the other profitable markets, and that's just the reality of it. And so what they're saying is, let's try to get them to launch within 2 years, but we need to break down the old system up here of having everybody reference everybody else's price, and everybody trying to get low price. So let's put them into 2 groups, the blue group and the orange group, and we'll only let them reference people within the same level. So maybe that's a first step towards, towards that. Now, I'm happy to send my slides to you. My email is at the end. Just write to me if you're interested later. So anyway, so they have tiering based on ability to pay. The assumption is each country negotiates based on their threshold, their ability to pay. But the interesting thing is you'll see over there verification by an independent party. That's an admission that this doesn't happen automatically. We need some sort of a third party to monitor who's making sure this is going on. Now, that has not been defined yet, but I think that's important. Now, this was a paper by some Italian economists. Now, some people say, we should have transparent prices. Well, if you have transparent prices, people get upset. They don't like the fact that Americans don't like the fact that Canadians have lower prices. So we're better off to have confidentiality. And what these guys showed was, if you start telling people they have to report what their net price is, everybody's going to want the same low price of, as everybody else, because the citizens don't understand. I mean, you can't explain to American, well, why should you pay more than Canadians? I mean, it costs the same to make the drug in both places. And you say, no, no, no. We have a market design that the rich people finance the R&D because they can. So that's why you're the richest country. You should contribute more. But we've never been able to educate the politicians and our citizens that this is a reasonable way to do it, and that's a big problem. So they basically say it would fail, it would undermine itself. So I call it efficient HTA. It's called adaptive HTA. You don't need to build a National Institute for Clinical Excellence in every country. You don't need 100 economists. The biology travels, the network meta-analysis travels. What doesn't travel is the cost analysis. So we want global differential pricing. Free riding, as it's called, is optimal. Not everybody should have to pay the same price. And the individual so what I would say is, what you do is you monitor what the FDA and EMA does, and they're going to do 46 medicines a year. I go down the list and say, well, if I look at my unmet medical need, my quality shortfall in Kazakhstan, of the 46 medicines that came last year, which ones would I want first? And then I call the company. Then I call the company and say, look, we want access to your medicines. I'm going to do what the Chinese do. I'm going to call you in and say, look, I've done an analysis. I have an idea what a price would be. You give me a price, and then we'll negotiate. So speed up that access. So let me stop there. Here's my email address. If you like the slides, please email me. And if you're interested in exploring this more, I'll have a session tomorrow morning. Thank you.
Thank you so much, Lou, and keeping the time. That was great. You did it. Now I have the pleasure, actually, we will be connected to Laura San Pietro Colom from Barcelona. She's the Innovation Deputy Director, Head of Evaluation of Innovation of New Technologies at Hospital Clinic Barcelona. And Laura will talk about assessing innovative technologies in a high-tech hospital, an overview of the last 15 years. So we heard a little bit about innovation before. So Laura, the floor is yours. We're delighted to have you. Thank you.
Thank you very much. Good morning. Can you listen to me correctly?
Yes, we hear you well.
Okay, wonderful. So thank you very much for inviting me. I'm very happy to be here with all of you. And I'm going to explain you what is my experience of working during the last, not 17 years now, in a high-tech hospital, and to see how this discipline, health technology assessment in a hospital, is changing over time, and it should be adapted to changing context that we all know very well. So let me please share my presentation now. So let me see.
Laura, while you are you please stick to 15 minutes.
Yes,
Thank
sure,
you.
Don't worry. I'll do my best. I think I will be able to. Thank you, Eva. So as I was saying, I'm going to show or to explain my experience. And now, let me just introduce my hospital so you have an idea of where I'm working. This is the hospital. This is Clinic Barcelona University Hospital. It's placed in the middle of Barcelona, in the center of Barcelona, so we don't have much chances to grow around. You can see here is the hospital and here is the university. And we have also areas of working in front, all this building here, and the research building is here. But we have another building in Barcelona, this is one that is devoted to maternal care and ophthalmology. And we recently have absorbed a small private hospital, this one that is also not in the center, but very close to our hospital. So our hospital, this one, is 100 years old. And we have two hats. We are a community hospital, so we are serving 500,000 population around our area, but also we are a high-tech hospital serving from 1 million to 8 million people of Catalonia, all the population of Catalonia, because our hospital is specialized in some pathology, some diseases that we are like the reference center for these diseases. We are the second Catalan hospital in number of discharge.
And we have, as you can see here, almost 8,000 employees and 107 research groups. Our budget currently is around 800 million euros, and we are placed in the second position of the best hospital or the best reputed hospital in Spain. Okay, so why HTA, health technology assessment, is really relevant for hospital, for any hospital, not just for my hospital? Well, first of all, because you all know that the main entrance door of technologies, especially the most sophisticated technology, are hospitals. And second, because hospital is an environment where innovation can flourish, because especially in high-tech hospitals, because we have prominent clinicians and nurses that have all these ideas, they try to look for solving solutions for problems they may encounter in their everyday practice. So innovation probably and usually is developed in this type of hospitals. So we have innovations that want to enter into the hospital and innovations that want to go out of the hospital to be sold or marketed in other places. But at the hospital, we need to know what is the value of these innovations, both the ones who want to enter and the ones who want to go out. And we need to take decisions on where to invest, which one to buy, because you know that you have many clinicians with competing technologies to enter in the hospital. And always, we do not always find HTA documents provided by national or regional HTA agencies, and we need to answer the requirements of information. And if we find documents in HTA agencies, national or regional, they are not adjusted at the context where the decision should be made. They are not adjusted to our hospital, to our cost, to our organization of care, to our type of clinicians. And also, most of the times, we need to prove the value of these technologies in real world, in our practice. So if you look at this graphic that I'm sure that all of you are very familiar with this graphic, that is the life cycle development of the technologies from idea to development and emergence to entering into the system and then established technology. So where are we working currently? We are working here since the beginning of the program when technologies want to enter into the hospital. So we are the what we call the early adopters of the technologies. Excuse me, because this is in Spanish, but here is the early adopters. But we also, as HTA professionals in the hospital, we are acting here when clinicians or nurses develop technologies. We are doing early health technology assessment. So let me start explaining all this evolution since we started in 2007 and what type of assessment we were doing. Well, we were doing assessment, as I said, of technologies that want to enter, and we were using what we call the mini HTA, mini health technology assessment. The mini health technology assessment is like a questionnaire, a template that has several domains. Some are specific and of more relevance for hospital decision makers than for national or regional HTA units. And what we do is to analyze looking at the evidence, published evidence, but also looking at our database cost, and also using sometimes evidence or clinical registers that clinicians have in the hospital. So we try to use in one side, as I say, the evidence published and clinical registers of whatever information we have in our hospital, plus cost data, plus information on organizational impact and so on. So what we call secondary use of, or secondary research we may use, using what is already there, published or available. And I'm showing this slide here because as you can see, the domains that we are using in hospital are quite similar to the domains that they are used in national regional HTA agencies, but we perform a European project a long time ago with 7 hospitals and other partners in Europe that show that there are 2 dimensions that are not considered in national regional agencies, but are very important for people making decisions at the hospital, that are these two ones, the political and strategic aspects. So we add these aspects to our assessment. Moreover, there are some domains that are relevant for national agencies, but are more relevant for hospital decision makers. So we stress this information in our reviews. And I'm not going to explain in this slide because I think that they are going to be shared, but there are some difference in the analysis of the evidence, for example, the type of information that are relevant. For example, just a brief example, national agencies usually use as measure of effectiveness, quality, adjusted life years. While this is an important measure for clinicians and the managers of my hospital, well, it's like, okay, it's okay that this technology brings that, but for me, I need a measure that help me to advance in my practice. For example, for them, it could be more relevant to use measures like number of readmissions avoid, or numbers of complications avoid, or patients correctly diagnosed with a diagnosis. Okay, so there are some differences. So when I started to work at the hospital, as I say, I used the mini HTA, doing a review of the literature and other information sources, but without producing any type of evidence. And here are some examples of technologies that we have been assessing during these years: big size medical devices, robot, Da Vinci, intraoperative radiation therapy, medium medical devices, like you can see here, like deep brain stimulation, extracorporeal shockwave therapy for non-union long bones. Also, small size medical devices like reusable electrosurgical device for bipolar vessel sealing, or procedures like amniotic membrane transplantation for ulcers that do not answer to conventional treatment. So you can use the methods of HTA for any type of technology. You need to know very well what is the question from the decision maker, and then you apply that. And this is the results from my first 5 years of working at the hospital, when I made a survey to all the people who collaborate with me, clinicians, economists, managing the institutes of my hospital, of all these specialty areas. And I made a satisfaction survey to know if they were happy. And summarizing, for me, it was really nice to see that all clinicians and almost everybody, they were very happy with the program in the hospital, with the way we were performing the HTA assessment, and they were willing to recommend our unit to other clinicians or nurses that were at that time were not working with us. And this is nice to see, because you may think, okay, you are working with clinicians very close to the bedside, and sometimes you are saying, no, your technology is not valuable. And still saying no, they are happy, because we are very transparent, very systematic, and very clear doing the assessment. And we perform like modelization to know the net present value of technologies that we recommended. And for these technologies, the hospital would have saved, not saved, because a hospital never saves money, but we can say a cost opportunity of 4 million euros, while if the hospital would have introduced the technologies that we say information from the European project, where we are producing all the information, including the mini HTA.
Recording stopped.
And an assessment toolkit for your hospital. But what happened? That in 2015, the crisis, the economical crisis, come to Spain and in most of the European Union member states, and we need to move. We didn't have money, a lot of money to buy innovations, but we need innovation, and we need to write innovation. So we start to make strategic alliances with companies, and where we were offering the services of health technology assessment and the production of evidence to analyze the value of the technology. So we just moved from reviewing what was produced in there to generate evidence for assessing the technologies from the clinical part and also from the economical part with the database of costs from our hospital. And we have published several papers that these are very nice for industry, no? To see if the technologies are valuable or not. Again, there were technologies that we found not work for our hospital, so we did not include those technologies in our hospital. And also another move from 2019 is that we have started to do early HTA with technologies, innovations produced at our own hospital, helping clinicians to know if their technology are valuable or not, and if they have to move ahead developing the technology or not. And also, the information we are providing to them is very important to look for venture capital outside, so to look for people that maybe would like to invest in this technology to advance and to develop more and to put these technologies into the market. And here, I just showed two examples. One, and both are we in the cardiology area, probably because cardiologists are the ones who, you know, they love gadgets and they develop a lot of things. So in both cases, we perform an early HTA showing not just the clinical advantages, also savings in money. And finally, more recently and up to now, we are helping clinicians to introduce innovations that are of value for them through a public procurement of innovation. The European Union just launched in 2014 a new directive on public procurement in general and for healthcare, because they wanted to push these innovations that have been shown to be valuable, but because of the scarcity of money cannot get into the market. So these are like programs that our payer, the Cat Salute, is launching, just asking clinicians to, first of all, present an innovation that they think that could be very good for the healthcare system and show their value through an assessment. Area that we have moved from buying a solution, an innovation, to buying a solution of a healthcare program that incorporates different types of innovations. And helping clinicians to do that, in this case, we have shown that this new way to manage, in this case, aortic valve stenosis patients, we improve quality of life, we decrease the number of complications in the perioperative moment, and regarding organizational aspects, we have improved a lot, decreasing waiting lists, waiting times, the satisfaction of patients and the satisfaction of clinicians. And we have shown that costs are less when we do this type of new organizational procedure, plus including these innovations that are valves and also apps to manage these patients. And also we have shown, the HTA professionals, we have shown through a specific methodology that this way to manage this type of patients can be scalable to other hospitals of Catalonia. So this is very valuable for the payer and for the health system at all. So my final thoughts are this one. So from my experience, 17 years of experience now in this hospital, I think that HTA professionals, we are working or acting as a partners of healthcare professionals and helping them to assess the value of the innovations they are producing or they want to enter into the hospital, and that HTA methods and procedures are there, but we need to adapt to a changing context. HTA, one of the main characteristics of HTA is its adaptation to each different context. And also at micro level, like in a hospital, we need to change how we work, what methods we use, and how we approach the different assessment to what we are asked to do or the changing needs in the system. And some teams, I think is the word tips. Some tips for those hospitals that want to introduce the HTA in their hospital. To be successful, you need two things. First of all, a strong support of key opinion leader in the hospital and also from the general director of the hospital, the CEO, the CMO. You cannot do anything if you don't have the support of these people, and then you have to have a good leadership of the professional who is doing HTA. You have to have credibility for doing that, otherwise clinicians or nurses don't trust you. And finally, I thought that if hospitals succeed in choosing wisely the innovation, the healthcare system will also succeed because hospitals are not in a vacuum, they are in a healthcare system, and they can make the system more efficient or more deficitary. And I think that HTA really can contribute, can help to make a healthcare system sustainable and successful. So this was my presentation. I hope and I think I fit the time, and I'm happy to answer any questions you might have. And invite you all to Seville, that the HTA meeting for next year is in Seville, in my country, in Spain, and it's going to be a very, very interesting meeting in a beautiful place. So all of you are invited. Thank you very much for your attention.
Thank you very much, Laura, for your invitation to Barcelona. We know Barcelona is a very beautiful city. Yeah. Please stay with us because we have to move after the two presentations for question and discussion. Right now, we ask to invite Professor of EDTP University, Güvenç Koçak. He's the partner Economics Research and MD in Health Economics. С докладом применения экономических
Use of the economic data for the HTA to make decision in the healthcare systems in terms of the allocation of the resources in healthcare. Please, 15 minutes.
Hi all. Yeah, thanks for inviting me, and it's my honor to be here in Kazakhstan with my sister and brothers, and it's good for me to be here. And when I was in the border today morning, it was the first time a police officer said my name correctly in a country which is not my home country. So my name, Güvenç Koçkaya, is a pure Turkish name in Anatolia as well. And in the Western Europe or US, people mostly say Güvenç or Kokaya or something, but the border police say 100% correct, Güvenç Koçkaya. So that's weird, but that's good. That feel like at home. So may my presentation come on board? Thank you. So I get a brief about talking how we can apply economics to the HTA process. Actually, I'm a medical doctor in professional, but not working as a medical doctor more than 20 years, I guess, and fully dedicated on health economics and HTA in Turkey and for the closer region. First question, do we need economic data? When I was in medical school, my lecturers say, if it is health, you don't need to think about the money. But nowadays, it is not like that, because we have limited resource. If we are not US, we have, all countries have limited resource, because US is a bit different than other countries, because they can print any amount of money they want, and nobody can say that why you are printing. But here, in my home country, Turkey, and I believe in Kazakhstan as well, you may have a limited resource of printing tenge as Turkish lira as well. So we all have limitations, amount of the resource. So do that, we need to implement somehow the economical data to the healthcare decision-making process. Okay, from the humanitarian perspective or equity perspective, it may not be right thing, but on the other side, we have limited resource. I believe in the first sessions, and it was mentioned somehow, how we can get economical data. when the countries like Kazakhstan or Turkey started these kinds of things to implement, it was another big question. Okay, we decide to implement because we have limited resources and we want to make better decisions than before because it's growing and we need innovation somehow. Okay, where we get the resource? I believe it is there. If you look, if you know how to look, it is there. It is there in clinical data. It is there in healthcare utilization database. I believe already it may be easy to implement, or it is already implemented, the digital health record. Also, there may be some expert opinions. For example, I put here expert opinion because at the end of the day, if there is no data from the relevant country, you may ask to the physicians, what's happening in your clinic? How many times you see the patients? Which kind of test are you asking for? Which kind of medicines are you prescribing? Or what is the medical device you are looking for in this treatment? Or how many of them? So if there is no data, there are still people in the field. These are physicians, these are healthcare professionals. So I believe if you want to get the economic data, it is there. Okay, then we decide to implement economic data. We decide, or we find the data somehow, and how we analyze. Actually, there are cost effectiveness and cost benefit analysis. I believe you already heard about these kind of things. But the debate is, can we assess a treatment with a cost and comparing with the effectiveness? Here, there are some questions. Okay, the developed countries use quality of life. Good. It's a thing that we can decide. But is it the right thing to discuss quality of life? Or which kind of effectiveness that I may choose for making a decision? For example, think about hypertension. You have a high blood pressure. And there is a new treatment on board, and you need to give decision. You may think about the cost of effectiveness ratio is depend on the lowering the blood pressure. Okay, this may be a good thing. But if the blood pressure is lowering, but your patients are going stroke or MI, or your blood pressure still remaining, but the patients go better stroke, less MI. So which effectiveness should we take for making a cost effectiveness? It is another debate. So in this case, maybe HTA perspective for making a clinical effectiveness perspective and compare the medicines out of the cost may be a better issue to make a decision. It's my opinion. As for example, I believe there is no one from Germany, is there? For example, cost effectiveness is a very hard thing to discuss in Germany because if you have no head-to-head study, IQWiC is not accepting any cost effectiveness study and say we cannot compare. So if there is no head-to-head study for comparing in the clinical data, how we can compare them in the cost setting? So it is another debate to discuss for cost effectiveness. But budget impact, I believe it is one of the most important things because the treatment may be cost effective, okay, but may be because of your all healthcare expense in this year. Because you will get a saving for 10 years' time, that's good. But if we paid the 10 years' time money today, it is cost effective. Yeah, it is very cost effective. But it is not cost effective for my budget because I have a limited budget again. So budget impact analysis come on board in developing countries like Turkey and Kazakhstan while we have limited resources. Okay, there's another debate. Which model we would like to use? In the decision process. Markov model, decision tree, simulation models. One of my lecturer, Mondor Taumi from France, maybe most of them maybe know him. Every time he say that, if things are getting sophisticated, believe that somebody is earning money. This means if someone put a new title to the table, then somebody need to learn that. And somebody need to learn that, somebody need to teach that. So these things going on. So if you want to put a new thing on board, this means things are not working, actually. So here, the list goes down, and you can put here time shared modeling or differentiated modeling, everything. There are different names. But the right thing is that you need to choose one of them, which is fit your needs and fit your capacity. Because using economic data on the other side, it is a good for making a decision for resource allocation. As coming back to the beginning, we have limited resource. So we need to count before we make a decision, because if you cannot count what is happening, you cannot make a decision, because the numbers are numbers. There is no lie on numbers. It is 1, 2, 3, 4. Nobody can say that it is not 4, it is not 2. It is numbers. So at the end of the day, you need to use the economic data somehow to make your resource allocation. And also policy making and planning, it is another thing for the government as well. Because you have a population, you have a country that you need to care about them. And not today, for the upcoming 100 years. So you are responsible for this population. So you need to make a policy how to move forward. For example, as Spain example that just we heard about a couple of minutes ago, they need innovation. So the policymakers say, we need innovation in the COVID time, in this time, how we can move forward. So these kind of settings is important for economical data. Transparency and accountability. Yeah, these are good buzzwords from English as well. Transparency is my best word, actually. Think about France. Do you know the France HTA committee name is Transparency Committee? So is it transparent? I don't think so. But transparency is one of the things that we every time discuss about, but nobody knows when it is happening. But at the end of the day, again, I'm back to numbers. I'm back to economical data. If you put the numbers on board, nobody can say that it is not that, because it is numbers. It is not a politician like me speaking here and manipulating the speak or manipulating the topic. It is numbers. Nobody can lie on numbers. And I would like to give some examples from Turkey and finalize my presentation, my last 4 minutes. Turkey has started this kind of things in the beginning of this century with the ruler party come on board and with the World Bank support and World Health Organization support, actually, and did a big story. But when we started the health transformation program in 2003, the economical data mandatory economical data submission from the pharma companies established in 2009. I believe Professor Sucu was there at the time in Ministry of Health in Turkey. So at the beginning, everybody resist on that. Academicians resist on that. Companies resist on that. They say that we cannot do this because there is no data. We cannot do this because nobody knows how to do this. At the end of the day, when we come today, everyone wants to do economic analysis because they understand that in the last coming 10 years, in the last decades, they understand that it is a must. Otherwise, how we can make a decision? How we can understand each other's, because only numbers are not lies. Only numbers doesn't lie. Only. The rest is politicians. So after that, and Turkey allow economic analysis. And first they started for the reimbursement decision, actually. Now it is in the regulatory process. And Turkish government, Minister of Health asked for that. If your product may have a value to Turkish economy, then your product may get faster regulatory approval than from the other products. So now in Turkey, we are using economical analysis in reimbursement part, but also in the regulatory part as well. So that may be, I believe, a good example. And when you look the history, there were big resistance from the academicians, from the pharma companies, and now all of the parties are looking for this kind of analysis because it is the only way that you can move forward for innovation and for making an equity and sustainable healthcare system. Thank you.
Thank you, Güvenç. Следующий speaker.
Our next speaker is Zafar Vahidov, partner of legal firm Vahidov and Partners. He will talk about the legal aspects of the medicine policy and HTA in Central Asian countries. Good day, dear colleagues. I welcome you at this conference. Please put my presentation on the screen. I will introduce myself. We represent the only law firm that specializes in healthcare and pharmaceuticals in Central Asia. We have offices in Kazakhstan and Uzbekistan. I don't think there are that many lawyers here in the room. Today we talked about different aspects of HTA through the economic prism. We had detailed political analysis. And we said that there are some challenges, there are barriers, individual, collective, political, and there are specifically medical issues. We come from the different side of the spectrum, and we want to look at the situation through a different prism. We would like to look at the regulation of HTA in Kazakhstan and briefly about Uzbekistan. This is just a general slide in order for you to tell what HTA within legislation of Kazakhstan is. I'm not going to read from the slide. The slides will be available and you can always look up this definition in legislation. And many colleagues before me talked about the definition of HTA, so I'm not going to cover that. Let me talk about the goals. And again, this is the slide with the aim to make us think why we need HTA at all. So this is the assessment of different technologies, of different medicine, of comparative analysis, clinical, economic, data effectiveness, and safety. We also developed this diagram of how it actually looks like in Kazakhstan and how it is regulated in Kazakhstan. There are different cases in which HTA is initiated by the state bodies, so specifically Ministry of Healthcare, or it may be the Fund of the Medical Insurance. There are other cases when other non-state bodies can become the initiators of HTA. So these can be, among others, pharmaceutical companies. The process will differ depending on the initiator. And it also depends on whether or not this technology is on priority list, which we have. So usually certain priority areas are initiated by the state, and then there is the assessment that is carried out in the competent body responsible for this assessment. There are comprehensive technologies of healthcare, and if this comprehensive healthcare technology is initiated by pharmaceuticals, it will also be assessed at the level of the national body. There are other organizations that can carry out this assessment in a private manner. Usually it concerns simple technologies and a number of other cases. Moving on in this process, so if this technology is on the list, and the list of priorities, then the decision is with the Joint Commission, and this decision is then sent to the Ministry of Healthcare. If it's just a simple technology and healthcare, then after the experts review by a competent organization, it goes to the formulary committee, and then the decision is made on whether or not to include this technology into the procurement list. I'm not going to go into the details. I think you know this process quite well. But nevertheless, we decided that this diagram would be useful. Let me talk more about the challenges and suggestions that we have as lawyers. So, besides the economic challenges that we mentioned today and the restrictions of the budget, of course, no country has enough resources for everything. It's a normal situation, even for developed countries, let alone developing countries. But there is another challenge that we experience, or our companies experience. There may be an expert review, right, but what comes next? What if this technology is not included into the list? So there should be a clearer explanation of when a certain technology is included into the list or not. And yes, again, we understand the restrictions of the budget, but in order for the process to be transparent in a legal state, there should be a clear set of criteria. Yes, we cannot stipulate everything, but we would like to see a clear process of decision making. Even if a certain technology is rejected, there should be an explanation. Formulary commission, for example, should say that we're not ready to include a certain drug into the list despite of the positive assessment, and give certain criteria, certain explanation why that happens. It may be objective or subjective, but if these criteria were available, that would be quite helpful. So I don't have that many slides, and understanding that everyone is getting tired and we're behind the schedule, I will briefly go over the slides. So that's as far as Kazakhstan, and just a number of slides on Uzbekistan, because, as I said, we're present in Uzbekistan as well. In Kazakhstan, the process is regulated. It might not be perfect, but still, in Uzbekistan, situation is a bit more difficult. There is no consolidated mechanism of HTA in Uzbekistan. There are rules that regulate inclusion of main drugs into the list. This list uses such terms as cost effectiveness and return on investment. These are the terms that our speakers mentioned earlier today. But the processes and mechanisms of HTA are not prescribed. So we hope to hear more about that. And we know that online we also have people joining from the Ministry of Healthcare as well, from the project office under the administration of the President of Republic of Uzbekistan. We hope that they will hear this message that the work needs to begin in this direction. We understand that it's not simple, but you have to start somewhere. And it should be either one of the existing bodies that would be responsible for that, or maybe a new one should be created. It could be the Center of Expert Opinion of the Drugs and New Technologies. And this body should be able to carry out assessment of healthcare technologies. And here is another diagram of how a drug is included into the list of the main drugs in Uzbekistan. This is the process as it is, and the way we see HTA could be integrated here. So the list is the list of main drugs, but we believe that it is not properly regulated. Surely these are the drugs that should be available in the pharmacies, and it should be provided by the state budget, but there are also certain gray areas there. Right now, in Uzbekistan, they're discussing the issue of medical insurance, which we hope will increase the expenditures in the healthcare that are covered for the population. If the expenditures are increased, there would be such questions as to which healthcare technologies should be included, which diagnostic tests should be included. So I believe it would be best to think about this mechanism at this stage already. And before the working group within the healthcare ministry could consider that, they need to receive this expert opinion. In the beginning of the year, there are 5 or 6 decrees by the president and the ministries in the area of pharmaceuticals. So there is quite a lot of work there. A lot of attention is paid by the head of the state and the government. And there are also issues of the pharmaceutical control and the issues of registration, certification. However, we believe that still right now is a good time to include HTA into this process. So these are all the main issues that we wanted to draw your attention to, and I understand that Q&A will be later on, closer to the end of the session, and we are ready to respond to the questions, share our presentation, and work together in this area. And we always support working groups from the legislative point of view, both business and the state. We understand that the HTA should be introduced and used in the right legal way. Thank you.
So much to all the panel. If we have any burning questions, like understanding questions, do let us know. If not, we will need to move on because we are running behind time. And we will not have a break between the 2 sessions. However, we all need a little bit of exercise, right? So let everybody get up. Yes? How many of you have a wearable device? Yes? How many steps did you do today? Very few. Yeah? So let's pick up some yeah? Let's do that. Let's do some steps. Let's dance around. Okay, another one, this. Okay, thank you so much. Yes? Photographer, we need a photo. Okay, so we move on. Alima?
Спасибо большое, благодарю.
Thank you very much. Thank you, dear participants. Can you please proceed to your seats? We are continuing our conference, and we are starting the third panel session, improving the healthcare system and the place and the role of the HTA. Let me introduce myself, Alima Alimadiyeva. I am one of the organizers of this activity. I would also like to introduce our second moderator, Antonio Migliora, manager of the scientific initiative in HTAI Sweden, apologies, and these are our partners.
Everyone, nice to be here. I would like to introduce our first speaker. Actually, she already had a presentation show, so this will make my job a little bit easier. She will talk about comparing regulatory and HTA reviews and convergence of regulation and HTA. Elena Petelos.
Let's see whether you can hear me, and indeed whether I can share screen. 1 second. Can somebody confirm, because I cannot see you? Can somebody confirm that you can indeed hear me well?
Yes, we can hear you.
Thank you, Antonio. Okay, let me try and share screen now. Again. Okay. So I have made, considering what was mentioned, because I was not quite sure how much you happen to know in terms of what's happening in Europe. The general pharmaceutical legislation was mentioned by a couple of people. So I've added a couple of slides because I think it may be useful to you. Hopefully, can you see my screen in its entirety? Because I'm only seeing part of it, Antonio, in this frame. So can you see the whole screen or not?
Yes.
Okay, so the disclaimer we've been through. So first question that arises, maybe also 1 second, my apologies. Okay, forgive me, this will be easier for me to change the view. Okay. Sorry, it's always difficult when somebody's far away. So desktop. There we go. Hopefully better now. So there are different reasons why at the moment we have divergence rather than convergence in terms of regulatory body decision-making and HTA decision-making. First of all, to say that there is a lot of differentiation across countries. In some countries, we do not necessarily have HTA per se. In some other countries, we do, but marketing authorization, generally speaking, does not mean patient access automatically. And approval by a regulatory body in order to obtain marketing authorization requires submission of a dossier. The assessment is to be based on benefit risk assessment. We discussed effectiveness a little bit before, in which we have an evaluation of quality and clinical and clinical data submitted by a sponsor or applicant, sponsor of trial or applicant, but usually excluding any economic considerations. For the HTA bodies, traditionally, of course, we need to support evidence-informed decision-making by payers, and not very often many other types of decisions locally. So the role and the needs of the payers are different. They need to ensure that there's going to be system-level resource sound allocation, and of course, to optimize the health outcomes for the population by considering all available treatment options. And these treatment options very often may not be belonging to the same specialty. They may not be belonging to the same category. There could be comparison of standard of care and medicine against a device. I'm thinking of small kidney stones. Traditionally, we excise them. Now we have diademy, for example, which is performed not by surgeons, but by interventional radiologists, and so on and so forth. And of course, it's very important to examine why do we really want it. And the amount of effects you get when you have regulatory divergence and decisions that do not reflect the same way of thinking or the same type of evaluation generate a type of various harmful effects, including in terms of access, of course, and because also clinical guidance and evidence practice, but also there are some other effects that are not always considered. The one that has been discussed a lot, but is not always considered at systems level, has to do with innovation reward and hurdles. It's well studied. But there is another aspect, and that has to do with potentially having mistrust from the population to the whole system of regulators. We saw a lot of things happening over the past few years in this effect, longer term effects that have to do with acceptability of evidence, and of course, within intra-country variation and intra-regional variation. Now, very dear friend Giovanni Tafuri, a few years back, he was at the EMA, looked back at the first effort for parallel scientific advice. So starting very early dialogue, saying to people, designing trials, what they should consider from an HTA perspective. So HTA bodies, HTABs, and the European Medicines Agency were coming together. And in parallel, there was another effort between EMA and FDA for assessing in parallel considerations to give information, give advice to the sponsor on how to design trials. And there was a retrospective analysis on all the medicinal products, in this case pharmaceuticals, that were considered in this 5-year period. And different aspects were examined, starting from population comparators and endpoints where they were available. Of course, at very early stages, you may not doing head-to-head comparison, which is quite difficult to consider. And looking at different type of agreements between regulators and HTA bodies. And at the time, it was already evident that there was concordance to a large extent, but not always. The difference could be surrogate outcome utilization, progression-free survival, for example, versus overall survival is one such case. For those of you that are familiar with these terms, there was often, though, and this is a little bit more concerning when you have to discuss situations like current development of harmonization in the European Union, where the HTA bodies were using different methods or potentially were assessing value and or innovation differently, and were making very different decisions between them. So not only dissonance between regulator and HTA body, but dissonance between HTA bodies. And then now there's another perspective which has to do with real-world evidence. And it's critical now that you also have this taken into considerations because of sound transferability and for context relevant decision making. And to be a little bit provocative, some things are transferable. To say that biological characteristics are, I would argue that they're not more often than they are not, at least not always. And of course, certainly the epidemiology characteristics of a region, of a country, are not transferable because we're moving towards a molecular mechanisms and molecular generation of therapeutics and diagnostics. And you need very high quality, very comprehensive coverage of an area to know your epidemiology, to know your causality. I'm thinking of hepatocellular carcinoma, very different causality in Asian populations, very different in Caucasian, with all that this implies. Genetic predisposition versus alcoholism and so on. And this requires, as mentioned, very sound infrastructure and also very sound mechanisms for generalizability and transferability. And then Laura before me mentioned how we deliver interventions. Very robotic, very important, very useful device, or in surgery may be very utilizable if you have it in a rich setting, in a very well-developed, complex, modern hospital, may not be equally relevant if you buy it and put it in the middle of the Sahara. So intervention delivery also has some other components. And then, of course, for safety, for innovative products, when you get early access, you have some very critical aspects when it comes to monitoring and safety. Now, the differences of you see in terms of population characteristics, which are causing a lot of dissonance between regulators for indication and HTA bodies, but also sometimes in terms of accepting transferred evidence. In the reliance mechanism have to do with different patient characteristics. And a lot of work has been done on this. This is from a paper which is already going back 15, almost 20 years, 2007. Disease characteristics, which may be also very different, healthcare system characteristics, and of course provide the characteristics, and this cannot be discounted. These are there, so you need to discuss these particularities. Nevertheless, this does not mean that you cannot build towards convergence by recognizing that these aspects are there and addressing them. And some of the information is transferable. We have a lot of tools for generating synthetic data and for matching, and this is something which is not just a challenge, it's also an opportunity. In terms of convergence, we have at least 4 or 5 modalities that are really transforming the current landscape of development. And I will spend a couple of minutes to give a quick example, although this is not the main part of this topic, because I think it may be useful, and the slides will be there. So we do have the artificial intelligence for creation of data and for looking where you had dissonance, what else you would need in terms of evidence. There's the aspect of cybersecurity and combination products. And of course, there's the aspect of omics and diagnostics. And to this effect, I will go a little bit deeper into my example. Some of you may be familiar with what a biomarker is. For biomarkers, you have an indication of how things will go. You may be very early or later in the disease. It could be molecular, it could be histologic or physiologic characterization, and more often than not now in oncology, but rare diseases, but also neurology and other emerging metabolomics are also playing a role. Many other diseases, we happen to have at least 2 very specific types of biomarkers, prognostic versus predictive. This is important for regulators, and it's starting to be also important for payers because we're starting to intervene earlier in diseases with the new diagnostic tools that we have. Traditionally, we had a paradigm of one test, one treatment, but now we're starting to need, of course, testing many versus treating very few with personalized medicine and precision medicine. And to this effect, you can see the concept of companion diagnostic, because you want to identify either before or during treatment who are most likely to benefit and who, of course, is likely to be at risk for serious adverse event reactions. Now, hopefully, yeah. So this means, however, something also very important, that the way we are actually doing development is getting transformed. We're moving towards side diagnostic development. This changes pretty much everything. You can see an example and some details there if you're interested in this, but you can also see that for these medicines, almost across every jurisdiction, we get very different subgroups in the populations, very different delivery of their care, very different difficulty in identifying the people most likely to benefit, delays in testing. So keep this please in mind, because when we discuss regulatory convergence, traditionally we're thinking of medicines or vaccines. We need to start thinking of diagnostics. One of the biggest challenges we have at the moment, if you want to do assay development in Europe, you better go to Asia and develop and come back, because it's extremely difficult to do, particularly for SMEs. So this is compromising also the molecules that are being developed. Not just the diagnostics. And then from a clinical and economic evaluation perspective, of course, the payer needs to see a better quantification and qualification of potential uncertainties. There's very nice work taking place across these themes from different colleagues. And there's also a couple more concerted efforts to factor them in and align to move towards more, let us say, harmonized approach. Now, for the payer perspective, it's an uphill struggle. I think not so for the HTA bodies, because the HTA bodies and the payers do not always sit in the same system. There may be different ecosystems of decision making. And also, you heard a lot about it. The evidence may be transferred, could also be translated texts, could also be information that does not tell you much about the patients you have in your country. And we have seen cases where this type of dissonance has led to a legal resolution. In some countries, it has been court cases for patient access. And of course, it's very true. And I think a couple of people mentioned it also. We have a policy versus political decisions with the latter very often also taking over. Now, convergence is urgently needed also to generate the evidence we need. If you don't have convergence, you cannot do it. There have been at least 2-3 recent efforts to map stakeholders and the views about it. And both pinpoint, they provide taxonomies and they provide examples. They both pinpoint for Europe the need to start discussing more and in a more concerted manner and a structured approach to deliberate, if you like, since we also work a lot with deliberative processes at HTA. And the current effort, there is FDA there looking at regulatory harmonization and convergence. There are a lot of efforts on standardization, and there we go into more medical informatics talk. So some links will also be on the slide footnotes shared for what's happening there. And there's also a lot of harmonization specifically for real-world evidence, because this is seen as an opportunity to potentially bridge the gaps in the decisions made between regulators and payers, whilst facilitating quick and safe access to the patients that are most in need. This, of course, does not solve most of the issues that are happening for LMICs. And it's also important to remember that in some cases, when we discuss preliminary positions or solutions, we don't just have an issue with the HTA only. We also have a very big issue on supplementation of data with trial design. We have single-arm designs. There may be reasons why we cannot generate the type of evidence traditionally required by payers. And this is a learning exercise because very often the people that are conducting exercises in decision-making, in policy, in payments, in reimbursement, and so on, also need continuous capacity building methodologies, synthetic data, digital twins, and so on are going extremely, extremely fast. Now, these are the slides I mentioned for Europe, so you can see what's happening. Indeed, there's an accelerator. There's also some implications that are not well known for LMICs via the EU Global Health Strategy. This is important because we're starting to look at cross-border trials in a different way with the inclusion of low and middle-income countries and supporting accelerator and pipeline development. And of course, there is a lot of discussion at the moment for the European health data space and how we handle data to also bridge the gaps that I discussed. I think you will also, in this slide, you will find in the notes, in the footnotes, a lot of links that could be interested to that to see what's happening. I think Mark also discussed it a lot, but we are going forward in a different way in Europe, and hopefully this will also help harmonize globally. And then, of course, finally, for the evidentiary requirements and synthesis, there are challenges, but at least there's starting to be some operational definitions in there and some discussions on how you can synthesize evidence and move towards much more adaptable frameworks. So making an HTA decision today, but being able to adapt it in a few months, go through an iterative process. Now, very important also to remember the changes that are happening in scientific guidelines. Many of you may have noticed that in FDA we always have draft guideline. So the draft guideline, it's a bit of a joke in the R&D that you will never see a fixed one. But actually, this is very important because there have to be living guidelines. You have to continuously revisit them. Such an example, which also is looking at the potential dissonance between NICE in the United Kingdom and England making a decision and the NHS taking this recommendation as the payer and agreeing or disagreeing to implement in different trusts, because it's not, of course, always compulsory. It's to some extent binding for some specific treatments. So this is also very important there because you're starting to see some considerations to this respect. And then finally, we have a regulatory player that is not well known. I think this is almost my last slide. And we're starting to discuss also trust of regulators and trust of payers to the evidence and to the data. So a concept that you will see a lot in the very recently published, there are 3 regulatory considerations for AI to harmonize also not generally traditional methods, but also AI tools for clinical development and assessment is coming out from the WHO. Potentially a new role for the WHO, but these are very recent developments, so it remains to be seen. Once again, HTA is comprehensive. Its linchpin, its underpinnings are being interprofessional and disciplinary and building trust and integrity. And therefore, we should all, I think, although I'm heavily biased, support it as much as possible in dialogue. And as a last note, we are focusing on this particular topic in a much more expanded manner and collaborating with the Get Real Institute in Utrecht. So I don't know how much of the event will be streamed, but I know that a lot of it will be released online. So the link and the details for that can be found on the footnotes of the slide. Thank you.
Thank you so much, Lena. Давайте поблагодарим.
Thank you, Elena. Let's thank all our speakers once again. Now I would like to highlight that we had very interesting presentation delivered by Elena as divergence, which is very often met in developing and emerging markets. In terms of the developing next steps for HTA in our strive to achieve efficient technology, who the speakers mentioned again. I would like to thank our speakers once again. Thank you for being here in Kazakhstan and for sharing your insights, professional backgrounds, and experience. Moreover, I would like to introduce a presentation of the President of Kazakhstani Association of HTA, Evidence-Based Medicine and Pharmacological Studies, KASPOR, of Kazakhstan, concept of the critically important pharmaceuticals and to identify priorities of the drugs for integration of the forms management. Well, again, Talgat, Professor Nurgozhin was one of the pioneers of the formulary system developed in Kazakhstan. We worked together in Kazakhstan national formulary, and to highlight that actually specifically this item mentioned by Elena for divergence, first of all, and the lack of the approaches in using evidence and the trustworthy evidence in assessing value to technology. Lack of such approaches was a barrier for our further development and improving of the formulary system in Kazakhstan.
Причине мы до сих пор стоим там, а должны были быть уже на 50 шагов вперед. Пожалуйста.
So please, the floor is yours, Talgat. We only have the strongest people who are still here in the room. Please put my presentation out. All the previous speeches were great, all the reports were great, we could discuss a lot, but let me go straight to the concept of the vitally important medicine. We had a lot of speeches already. The system is not the same as before. It's a living document. And right now we have changed the terminology of how we call the medication, and we now call them critically important medication. And the year is called equal access to the medication regardless of whether the person is born in a city or in rural areas. I'm sure that the strategy itself is quite clear to you. Therapeutical access, adequate financing, pricing, reliable system of supply, and effective regulation. All of that jointly gives access to quality medication. In the whole world, this concept of the critically important medications exists in many countries, and they use this concept quite successfully and effectively. As you know, with the development of technologies, no matter what the percent of GDP you allocate for healthcare, it will still not be enough. In the US, it's over almost 20%, but still, it's not enough. We have around 3, and of course, it's a huge deficit. I would like to talk about some milestones. I wasn't going to talk about it, but then Zaid showed that in his report. So I would like to go back to 1995, which is when the national list of the major medications was developed with the support of USAID. And after that, the formulary system was developed, guidelines were published. And I was personally involved into the development of all these documents. All our efforts were focused on the development of the Kazakhstani formulary, and we had a very strong working group with objective focus on the target audience. So it was then that we realized that some medication, 129 specifically, so the indications for this medications were not the same as the indications that were mentioned when registering these medications. We eliminated this problem immediately, but we saw that the problem was there. But there are also ethical issues, and we need to take all of that into account. So we've been talking about efficacy, effectiveness, and efficiency since this morning. So I'm not going to go too much into details over that, but basically the HTA should start at the very early stage of the technology development. And we understand that the clinical effect in different areas may vary, which is what is shown on the slide right now. I'm not the one who came up with this, but this is to say that without the assessment of technologies, it's impossible to get to success. If the technology is new, it doesn't mean yet that it should be introduced. And sometimes the technologies that are introduced too soon without the proper assessment are abandoned later on. Over 200 guidelines of standards and protocols were studied by the Nature journal, and it was identified that many of these guidelines contain certain mistakes. But mistakes do happen, we all know that. So here is the methodology that was developed. This is the foundation of HTA, comparison of two alternative technologies. So there is the cost on the y-axis and effect on the x-axis. HTA should be the red line across the whole life cycle, from the clinical protocols to the formulary. And that should be also reflected in the procurement process. We see that, we understand it, and we understand that there are also a lot of questions to the innovations. Whether the technology improves survival rate or reduces the cost of treatment, how the technology affects the expenses of healthcare system in general. Does the technology bring the patient back to normal life? Today I gave the example already. There was time when Kazakhstani cardiosurgery made a leap forward and it started placing LVADs, whereas legislation on the donor organs and transplantation did not exist. There was no regulatory norms at all. And imagine half a year later or a year later the patient dies, then how do you assess the effectiveness of the money spent? What about the patient's relatives? And they see that patients live for 6 months and without transplantation, they die. And we've always used these facts as arguments, but we were not always heard. We see that new technologies, starting from the registration and the marketing authorization, should be regulated, should be assessed. You see here these lines and arrows. You see the reference pricing, registration, etc. Our state bodies are sometimes afraid of talking to the applicants, but actually this is what they should do. I should talk about the price, negotiate the price, introduce different technologies. You know that we have the anti-corruption agency. And I guess the activity of this agency scares some people who work at the state bodies. And most importantly, the system should be transparent, which is what Zahir has mentioned in his presentation. In the formulary commission, here we have the chief clinical pharmacologist, and we have the members of the formulary commission. So when you say no, please do explain why. And why do you reject a certain technology? So we see this cascade. And explanation can be given. I liked the presentation by Alima on evidence-based medicine. I've been talking about that 8 years ago, and now we have some followers of this idea. Evidence-based medicine has some facts, but not all those facts are evidence-based, and we need to make sure that they are. And HTA will help us with that. So I don't want to take up more of your time. This is my last slide. I will just say what and how needs to be assessed. We should make sure that we use the results of the research, of the trial. We need to make sure we look at the economic factors, clinical factors, and we should involve all the stakeholders. Unfortunately, today we did not have representatives of the medical insurance fund. That's too bad, because everything that our experts said should have been heard by the insurance fund. What should be done? Well, that's an overarching question that dates back centuries. So here's the answer. The scheme of interaction of the formulary commission, starting with the collection of data all the way through the pricing, and you can look at the published prices by the MSH, UNICEF, MSF. These are wholesale prices, so there is something to compare to. There is information from US, from EU. If the country has pharmacopoeia, then it'll decide what type of medication will be available. If it's not flexible, if it's strict, then the medications will be of high quality. So pharmacopoeia plays an important role, and the British National Formulary is an example for us to follow. And coming to the end of my presentation, I would like to say that without HTA, no medication should be financed by the state. There are also some medications that have already proved their effectiveness and their financial, economic effects, but new technologies should be assessed. Thank you.
Nurgojin? Yeah, you pronounce it very well. Thank you. Now I would like to invite Birol Tibet again for another presentation on synergy of HTA and clinical guidelines development and revision for improved healthcare outcomes.
So I thank again. It's good to be here, and I thank Eva as well, because we need that refreshment before this start. And thank you very much for staying this much, for this much long time, you know. I know that it's tiring, but I hope it's going fruitful for you. So this time we will talk about HTA and clinical guidelines. So the synergy between them for improved healthcare outcomes. So I won't go back to HTA, but you know, when you start to explain about HTA and clinical guidelines first, if you're not familiar, you find it very different. But when you start to listen to them, then you see similarities and it's getting more confused somehow. That's why, let's skip the definition. I mean, we heard that so many times, but we know that, I mean, basically, HTA provides a structured framework for evidence-based decisions, optimizes outcomes, resources use, and integrates scientific, ethical, and economic dimensions, and it ensures equitable resource allocation and prevents wasteful spending. So on the healthcare quality, which will be our bridge for clinical guidelines, HTA promotes scientifically validated treatments that enhance patient outcomes, balances cost against benefits, supports effective health policy formulation, ensures sustainable innovations and prudent resource use. So it is essential to modern health systems. But what are clinical guidelines? As physicians, we know them, but from a broader perspective, it has, I mean, more meanings. Maybe we can call it like that. These are systematic statements that assist healthcare decisions based on rigorous evidence reviews, aiming to enhance care consistency, improve outcomes, and reduce costs. So in healthcare, it has some roles. These guidelines serve as pivotal tools in healthcare. They standardize treatment and optimize resource use, and assist clinicians, but not only clinicians, also policymakers, in making informed choices that enhance patient care. So it is applied in healthcare systems to aid in standardizing medical care, ensuring quality, and shaping policies, support HTA, and economic decisions. And eventually, it influences the economics of healthcare provision. So, after this background, in this presentation, we will aim to explore the integration of HTA with clinical guidelines to optimize healthcare outcomes by, hopefully, demonstrating how HTA and clinical guidelines enhance healthcare delivery, showcase the improvement in decision-making through their evidence-based integration, discuss how synergy improves patient outcomes and reduces costs, and illustrate how integration influences healthcare policy and practice, and lastly, promote the importance of multi-stakeholder collaboration again in healthcare. So basically, we will have an introduction in these topics. In healthcare outcomes, we have some challenges. Optimal healthcare outcomes are hindered by inefficiencies and inconsistencies. When I say inefficiencies, in delivery specifically, I mean resource waste, variability in treatment, and when I say inconsistencies in care, I mean geographical disparities or inequalities in access to care. So we can give examples for outcomes needing improvement. For instance, for chronic disease management, it requires coordinated and long-term planning to avoid suboptimal treatment outcomes and increased hospitalization. And for the example, surgical outcomes and safety, there are preventable complications which need addressing. If we have a closer look to HTA and clinical guidelines, we will have a summary now, HTA ensures the implementation of effective and viable medical technologies by assessing its components, as we talked about earlier, clinical effectiveness, cost effectiveness, ethical considerations, and organizational impact, with, of course, involvement of stakeholders. If we check how the process seems in general, basically, it starts with scoping, so defining the technology, technology use, target group, and evidences. Then we start evidence gathering. After that, to be quick, we synthesize the evidence. Then the appraisal step is coming, and the committees decide on that based on the extracted data and the evidence retrieved by these processes. To just compare the processes, for the revision or creation of the guidelines, first we identify the need. Sorry, I didn't realize that it didn't come. To recognize new evidence and priorities. Then we assemble a group by including multidisciplinary experts. Then we review evidence and assess research and data systematically. After that, we draft recommendations, but we need to be careful to create clear and actionable recommendations. Then public consultation and stakeholder input is done, and we incorporate feedbacks to refine our guidelines. And finally, we publish it and periodically update these guidelines. Of course, with the inclusion of our stakeholders. Let's talk about the need for synergy between these two terms. We need it because there are gaps in isolated application of HTA and clinical guidelines. If HTA is isolated, then we have gaps like limited implementation or inconsistent application. But if the clinical guidelines are isolated, then we face outdated practices and economic inefficiencies. There are some potential benefits. I will tell these to you, but just for a second. Actually, we need to know that the synergy between these two approaches facilitates a cohesive, evidence-based and cost-effective healthcare system. So, if you think about the benefits that I was talking about, integrating HTA with clinical guidelines enhances healthcare delivery. That's the short message. But how they do it? By comprehensive evidence incorporation, which informs decisions with efficacy, safety, and cost data, by reduction in practice variability, which standardizes care across various settings, by optimized clinical decisions, which balances effectiveness and cost efficiency, and by increased patient safety, which promotes interventions with proven benefits and minimal risks. And lastly, by equitable healthcare, of course, which ensures all patients benefit from high-quality evidence. So as a case study or successful example, again, we can take NICE as an example for this specific context. NICE integrates HTA into guideline development with comprehensive and evidence-based care, and they do in-depth assessment of treatments for clinical efficacy, safety, and cost effectiveness. So from this experience, we have some key takeaways like improved patient outcomes. In this specific example, better glycemic control and fewer complications can be an example. So economic benefits are other benefit that we get from here, and consistency in care and stakeholder engagements are the other following key takeaways. But how we integrate these methodologies? There are strategic approaches for integrating HTA with clinical guidelines. We can do parallel processing like they do in the UK and Canada, which means simultaneous HTA reviews are undertaken and guideline development is done after this. Also, stakeholder engagement involves all relevant parties early in the process, and this is applied by Australia. We can do iterative review like Scotland. It means continuous updates based on evidence. Also, we have frameworks and models. These are well known. I won't delve into details, but GRADE, it's called GRADE, the first option. It rates evidence quality and recommendation strength and applied by the WHO and various national health agencies. There is ADAPTE, which in my opinion, which should be known in low and middle income countries very well because it adapts guidelines to new contexts and HTA findings. So you don't start from scratch. And it is well applied in health systems in Europe and North America. And there is DECIDE, this is the third option. It improves guideline dissemination and evidence use, which is applied by healthcare institutions. So we have stakeholders, again, carrying important roles in this synergy. First, healthcare providers. They implement guidelines and provide feedback on practical applicability. Then policymakers develop supportive policies and ensure regulatory compliance. Patients and public engage in decision-making and advocate for effective technologies. Academic and research institutions ensure research effectiveness and educate on integration methods. And lastly, industry, and they align innovations with HTA findings and support economic assessments. So, what strategies can be implemented to ensure this environment, this stakeholder environment? Multi-stakeholder engagement is the first step. It is essential for diverse perspectives. Then transparency and communication, which is key for trust and informed engagement. And lastly, continuous improvement, which is vital for adapting to new evidence and challenges. Of course, eventually it has, this integration has an impact on policy making in terms of evidence-based policy formulation, standardization of care, regulatory and reimbursement decisions. Again, if we focus on the UK example, NICE integrates these guidelines, I have already said that, and they use it for NHS drug reimbursement, which means National Health Services. In Canada, CADES HTA informs national health policies and technology adoption, and in Australia, PBAC uses HTA for decisions on pharmaceutical benefits scheme coverage. But still we have some barriers to integration, like data evidence gaps, stakeholder resistance, lack of interdisciplinary collaboration, and resource limitation. So if we address with enhanced data collection and sharing, if we mitigate through structured engagement process and foster by creating diverse expert teams and overcome by securing increased funding and resources, we can overcome these barriers. It's not easy, but we need to work that. So these strategies have been creating a collaborative environment that enhances healthcare decision-making. My colleagues already told about their expectations for the future, but basically there are emerging trends in innovation, like increased use of real-world evidence, digital health and AI, global harmonization of HTA practices, or you can say that collaboration in HTA practices. And for the next decade, actually we look for the expansion of HTA in low middle income countries. Personalized and precision medicine will be a hard topic, and policy integration with sustainability goals will be met, especially in the already developed world. in these terms. My last slide, Alima. I'm just concluding. So what is the next step? We need to establish a clear integration framework and define integration methodologies. For timeliness and responsibilities, we need to do that. And we need to invest in technology and infrastructure. We need to strengthen HTA and guidelines, training programs. And lastly, we need to promote multidisciplinary collaboration. I continue to say about multidisciplinary collaboration and stakeholder engagement, because it's a key for the success here, stakeholder engagement. We need to involve patients and the public to ensure their perspectives shape HTA and guidelines, clinical guidelines. And engage healthcare providers, we need to do that, to include them early to leverage their insights. And lastly, collaborate with the industry, of course, to partner to align innovations with safety and efficacy standards. So that's it in a nutshell. But as I told before, I'll be glad to discuss on the breaks at the end of the session. Thank you for your listening.
Thank you so much, Birol. Я еще раз хочу отметить.
Well, once again, I would really like to appreciate all our speakers, all our distinguished presenters who are a part of the Health Technology Assessment International for their invaluable contribution, including here in Kazakhstan. Next, I would like to provide the floor to our next speaker, Eva Turk, who will be sharing her insights about harmonization of the HTA with the purpose of the Digital Medical Devices Assessment. She is the head of the HTAI Management Board. She is senior officer of the Center of Digital Healthcare from Austria and also from the Ministry of Healthcare of Slovenia. And, well, probably some people say that it's boring, it's theory, but let's not forget, when we are used to live with old standards in the years gone, don't forget that technologies are progressing, that we are lagging behind, that technologies are way ahead of us, and we need to catch up with new standards, new methods we need to use to maximally efficiently use all the available resources with healthcare. Eva, please, the floor is yours.
Thank you so much for the introduction. I didn't understand, but and I have the privilege to be between the break and you again. But I will keep it simple. And actually, there is so far harmonizing HTA to evaluate digital health products. Nothing is really going on. Yeah? So we could actually go. However, I do want to start with Annika. And I want you to meet Annika because she is the last user of digital health technologies. Annika lives in Helsinki in Finland. She's 9 year old, and she's the only child, and has been diagnosed with diabetes 1, and she has asthma. So her parents, and if you put yourself in the future scenario when digital health technologies come easy to the healthcare system, and many of them are reimbursed, her parents got her a social robot called Roboti. And this robot helps her basically, on one hand, that he's her friend, but on the other hand, the robot also generates data from her implanted insulin pump. He collects next generation internet enabled inhaler, so he collects data from that. And basically he also has the activity tracker that actually then sends also the alerts to both her parents and next of kin, but also to the healthcare providers. So these are some of the benefits that actually make life much easier for Annika and her parents. But there are also quite a few challenges when we speak about these things. So robots sometimes malfunction. For example, when we talk about real-world evidence and how data are collected, and the hospital that Annika is a patient in actually asked, let's say they asked their parents to share the data for a research for the research project. And how can we make sure that this data is then safe? Yeah, that it's not that it's used in an appropriate way. So these are all of the challenges that actually come also after the implementation of the technologies, and we need to, as HTA, think also of re-evaluating certain things later. So in digital health landscape, then, when we speak about the potential benefits, and these are amazing, on one hand, we also need to think about trust, and Elena talked about trust. Many people today also, when we speak about values, we also need to think about different perspective. So we must embrace these innovations responsibly, preserving the health system's reputation for safe and ethical care. We also then, when we integrate the different generation of patient-generated data, and when we integrate artificial intelligence and data-driven tools, we need to consider then the transparency that we heard of today already, accountability, safety, and fairness. So equity matters, and we must also be aware of unintended biases to ensure equitable benefits across all of the groups. And lastly, we also heard today about the technology literacy. So in a sense, we do need to empower the users, so people deserve clarity with regard to inform them about the data usage and their rights. So I asked before, you know, who of you wears a wearable tracker? These are just some of the devices that actually have a huge potential to change the way we perceive healthcare. Some of them are very much in use already. Some of them are really up and coming. So I will not. You see the slide here. I will not go into detail, but just to give you a little bit of a kind of like a broader view. However, then the digital health technology assessment, or the health technology assessment of digital technologies, is going on. NICE has been developing frameworks, but as Annika lives in Finland, I did my PhD in Finland, so the country is very close to me. I thought, like, okay, in Finland, at the University of Oulu, they developed a HTA method a couple of years ago, which was published in the Finnish Journal of e-health and e-welfare. And it's actually then looking into kind of like how can HTA methods specifically be tailored to novel digital health technologies, like what we mentioned before on the mHealth, artificial intelligence, and robotics. And they developed some kind of traffic light model. And what I find it interesting is that they offer then with the conclusions that can be reassessed within 3 years, because the technologies also develop very, very quickly. So this is how it's done in one of the countries. But the title of the topic you gave me was also recognized in a way by the European Commission. And last year there was a call for Horizon Europe projects. Horizon Europe, I guess most of you know, is one of the biggest funding mechanism for research in Europe, in addition to Innovative Health Initiative. And 2 projects were accepted. We have members, like Iga is in EDITA project, and Marco is also here from that project, so they can tell you more in detail what is going on. So it's the first, actually, then, when we talk about digital health technology assessment framework that will be co-created by all stakeholders in the European health ecosystem. And the second project is so-called ASSESS DHT, ASSESS Digital Health Technologies, which is on development and harmonization of methodologies for assessing digital health technologies in Europe. So I'll just go briefly into the project. Both of the projects put a lot of efforts on stakeholder engagement. Of course, you know, both of these projects or proposals were submitted to the same call. So you have the same buzzwords in there because the actually expectation is very similar. But in a sense, when we think about the EDITA project, now you cannot read it because of the heads of Birol and Alima, but the overall goal of EDITA is to deliver a fit-for-purpose HTA framework for digital health technologies that integrates existing assessment domains and methods with the new ones in order to inform decision-making. It is an innovative, first of its kind, the HTA framework platform that will be developed to follow HTA assessments and perform digitally in a standardized format that will be customized according to the type and life cycle stage. We heard about the life cycles today as well of the digital health technology. So these are the the stakeholders that will be involved. Both projects started in January this year. EDITA is a 4-year project with 16 partners from 10 European countries. I have the reference list and websites at the end of my presentation, so you can then go and Google if you want to know more. And then the ASSESS DHT, which is, you can see that the overarching objective is to consolidate and streamline existing methods and tools for approval of innovative digital health technologies and develop its new fit-for-purpose generic assessment framework, which will be then harmonized for Europe and aligned with the European health data space regulation proposal. This project it also started, as I said, in January, has 14 partners from 7 different European countries, and it has really 4 pillars. So the first pillar is then the consolidation and the preparation pillar, where we look into the existing assessment frameworks and tools. The second pillar is a toolkit development pillar, where the innovation powerhouse, this is the innovation powerhouse of the project, so this will be, the main work will go into this, and this will construct a new assessment framework with pathways for special case DHT and a fast-track pathway. The third pillar is then testing and validation pillar, and this is going to be in different countries where they will kind of like do the road testing of the initial framework. And the last pillar is the uptake and sustainability pillar that engages with external stakeholders. So this is really, really briefly about the 2 projects. There is nothing to show yet. The General Assembly of EDITA is on Monday in Rome. So Iga and Marco are flying straight from here to Rome. But I would suggest you that you subscribe to their newsletters, because a lot of exciting things are coming up our way. And I think with regard to the implementation of digital health technologies, this is going to be crucial. And just, I think it was probably last week or this month, published in the Value in Health, a new framework for defining digital health interventions. So the ISPOR Special Interest Group did a report where you see that it's a newly developed tool and aid in formulating specific and detailed definitions when we speak for patient digital health interventions and research questions. So these things will also then flow into the European projects when they do the status quo or the assessment of the where we stand today. So then, really, what's next? So the upcoming generation of HTAs for digital health technologies in general must really leverage the new sources of real-world data. We need to take into account also the methodological advances. It's all about stakeholder engagement. I think we spoke so much today of the importance of the stakeholder engagement, and also, when we develop the new digital health solutions, it's all about co-creation. It's all about user-centered design, and I think this is where kind of like the early HTA really comes in, because you already define the needs for these technologies. So going back to where Rabia started on the unmet need, I go back to the individual in a sense of how can we really co-create the digital health technologies together with the end users. And I'll just put it out there as a question mark. Yeah, do we need new financing models for digital health technologies? We speak a lot about conditional pricing and conditional reimbursements and so on. So we are still a little bit, kind of like up in the clouds when we discuss the digital health technologies. So in a way, this includes incorporating best practices in real-world data utilization while addressing the unique challenges associated with real-world evidence. So remember Annika from the start? So how could actually then HTA in a way help, or what could it address? We discussed a little bit on the data security and privacy measures. These are the topics that are very relevant. Data quality assurance. Who actually will be the one taking care of the patient's data? We spoke about the informed consent and the transparency. There's a lot going on also with regard to dynamic consents, and kind of like you can retrieve your consent when needed, ethical consideration, and regulatory compliance. So that would be really from my side for now. I said I would keep it short, and anyhow the slides didn't want to move. The references are there, so if you have any questions now, later, please do reach out. And thank you so much for your attention.
Thank you, Eva. I would like to thank you also the other speakers, and I think we can consider a couple of questions from the audience.
Уважаемые слушатели, если есть...
Distinguished experts, audience, if you have any questions, feel free to ask. But we only have 2 to 3 minutes for the discussion because we don't have that much time left.
Хочется отметить for the exceptional presentation, and actually I just it recalled me. I reminded one project we had in Kazakhstan. It was quite recently, and we did it like the name for this was MedTech, and it was exactly about the digital technologies, some applications. We have a lot of developers who created or create some kind of applications for people, and they would like to gather the data, the real-world evidence, like real-world data. But the problem was that they didn't use all of these methods and techniques you mentioned in your presentation, even if some people were involved, like me, and they recommended to use HTA approaches. But actually, all of these approaches, all of these methods were neglected. So maybe the main question now is for our speakers, what kind of recommendations you can advise, like, or you can give to emerging markets, which exactly the markets where people face some barriers, not like lack of resources, but exactly lack of capacity, lack of human resources, lack of some kind of maybe educational issues. Thank you.
I can start.
Yeah, sure.
So I work at the University of Applied Sciences at the Center for Digital Health and Social Innovation, and we work a lot with startups. And I think the thing here is also when we are developing, or when the startups are developing the technologies or their digital health solutions, they are not aware of HTA at all, right? It's too scientific for them. I think there are two worlds that on the innovation side, a lot with the startup scene, it's very difficult to penetrate their way of thinking, that it's more scientific in that sense. And what we are trying to do for example, we have a master's in digital health, and there we are trying to bring in the HTA already, so that how can we then tell them, because throughout the process you will need that, if you want to have it reimbursed by the system, of course. So that would be my recommendation. If you are working with developers, is often you need to start from the start, really telling them already about all of the needs that are there also from the system to be accepted in the system.
Thank you so much, Eva. The question was not only addressed for people who are sitting here, but also for those who are online, who are watching our live stream, for those who are in Zoom and waiting for some kind of discussion things. So if you have questions, please, уважаемые слушатели, если есть вопросы.
Dear participants, we have one more minute if you have any questions, and after that we're going to break for coffee. We don't have any questions, so let us thank our speakers and participants who are with us till the very end. Thank you very much.
"20 minutes break."
Уважаемые участники, 10 минут coffee break. 10 minutes for coffee break because we have the last closing plenary session.
I don't have Malta. Dear colleagues, welcome back and welcome to the last session of today. Today has been quite intensive, so thank you for your patience to stay here with us. And I think in this session, it will be kind of a reflection on the whole day, because we heard from many different speakers, their experiences at a global scale, but also experiences from their individual countries. So right now, we want to focus in this session mostly on the Central Asian countries and see whatever we talk today, does it relate to the setting, so to this setting in Central Asia. So we will hear from a few country examples, how the healthcare system and HTA is in their setting, and then we will keep it a little bit interactive to discuss the reflections. But I hope to finish this on time, so we will not delay you for going home. That's our hope. So for this session, we have two colleagues from Kyrgyzstan, we have a colleague from Azerbaijan, and we have Kazakhstan representation as the host country, and one of our colleagues has also experience in Uzbekistan, so we'll be able to cover some of the region. And we will have two short presentations about understanding, especially for Azerbaijan and Kyrgyzstan, understanding what the context is there. So I want to start with our Kyrgyz colleagues. So our first speakers will be Azamal, I hope I'm pronouncing correctly, Matamorova. She's the head of the Department of Evidence-Based Medicine and Medical Technologies, Center for Healthcare Development and Medical Technologies under the Ministry of Health of Kyrgyz Republic. So floor is yours.
Dear colleagues, good afternoon, or good evening rather. I'm very happy to be at this conference. It's such a great platform to discuss the topical issues. I would like to thank the organizers for this discussion for today that is so needed in our countries. This is the area that in our country exists partially, but it does not have a legislative foundation. So I would like to show you what we do have as far as HTA is concerned in the Kyrgyz Republic. So I'm going to skip some of the numbers I have prepared. I will just briefly say that the Kyrgyz Republic is a rather small country. We have 7 million people. 200,000 square kilometers is our area, and GDP is quite small too. So, of course, we don't have that much dedicated to healthcare either. The budget is rather small. And if other countries talk about restricted budget, well, in our case, it is even more so restricted, the resources and the budget. So the situation is quite complex. But nevertheless, we do have some elements of HTA. So I will briefly cover those elements. We use HTA when we are developing the list of the vitally important medications. And for example, this year we revised the national list, and we included 527 medications. When developing this list, we always use the well-known, well-established mechanism. We carried out the assessment, but there are some challenges, specifically in calculating cost effectiveness. And to our financial experts, it's rather difficult to calculate such indicators as the burden of disease, cost effectiveness, and some other indicators, the way, for example, it influences the budget, etc. And since our budget is not that big, it's not easy to do all that. And the country is not big either. That is why it is not really attractive to the pharmaceuticals, simply because our market is rather small. So HTA is used when we develop the list of the vital important medications. And currently, we also use HTA when developing the package of services. And right now, we have developed different packages of medical services. And we keep on working in this area. We will also work on the costing of the services. We will prioritize most important areas, and after that, we will develop the guaranteed package of medical services that are provided to the citizens free of charge. We'll have some additional programs, and this process is not yet finalized. Today, it's still in progress. We are also reforming the system of the fund of the mandatory medical insurance. It is being revised, which is another barrier for us. There are some changes and amendments to the price formation and price regulation. There are also some barriers which include the fact that the work on putting the packages of the medical services together is still on the way, and that we do not have any legislation in relation to HTA. This year, we plan on developing some documents, such as maybe rules or orders and some other regulating documents in the area of HTA. We also have the needs to define HTA for digital technologies. In the last couple of years, we realized that digital technology, as well as the telemedicine, are becoming more and more relevant, and we need to have a proper definition of HTA within the digital technologies. And it is a multidisciplinary team that works in this area. Usually it is the Ministry of Healthcare that initiates this work. The Fund of Mandatory Insurance Fund defines the amount of the budget. Central Development of Healthcare that I represent provides expert opinion. The Department of the Medicine provides its own contribution. And so you see that this multidisciplinary team works together, which is not a good factor. And quite often we have representatives of patient associations that are very active, and sometimes they lobby or they initiate some assessments. Sorry, I was told to be brief, so I tried to be as brief as possible when it comes to HTA. Thank you.
I hear myself. Thank you. Thanks for being brief. I know when it comes to a country's healthcare system, it's extremely hard to be very brief on that. But thank you for giving us some key information about the country. And I think I will have to come back to you for asking further questions to understand actually what is on the horizon in Kyrgyz system. I would like to move on to next speaker to hear more about Azerbaijan healthcare system. So our next speaker is Bilura Yusufova. She's the head of the Department of Medical Quality Standards, Public Health and Reform Center of Ministry of Health of Azerbaijan Republic. Floor is yours.
Can you please put my presentation on screen? Well, first and foremost, I would like to welcome all the participants of the conference. It's a great pleasure to represent Azerbaijan in this conference. It's the first time in Kazakhstan, and I would like to thank Kazakhstan and especially Ms. Rabia for the invitation to participate in this conference. Very briefly, I would like to mention some of the specifics of Azerbaijan's healthcare system. First of all, it is about the structure of healthcare. Healthcare in Azerbaijan is managed by the Ministry of Healthcare, Tabib, and the agency on mandatory medical insurance. Each organization has its own functions. We have institutes supervised by the healthcare agencies or second-level institutes, gynecology, pediatry, oncology, institute of oncology, and so on and so forth. Under the Tabib supervision, there are all ambulances, all for the primary health care system, inpatient care, emergency health care, emergency care. For the financing of the healthcare in Azerbaijan is responsible the agency on mandatory medical insurance. I would like to highlight that the medical insurance in the healthcare system shifted towards the insurance system right after COVID. Before COVID, we had three pioneering regions in Azerbaijan, but after COVID, we now have a full-fledged insurance system. How does this system operate? 10% from the income of the employee and 2% from the employer from the salary is being paid to the government. Children, disabled people, retired people, pregnant women, students, their medical insurances is paid from the government budget, is covered from the budget of the central government. Population of Azerbaijan is more than 10 million in terms of the territory, more than 86 square thousand kilometers, and cardiovascular are number one cause of death. Then number 3, respiratory chronic disease, and average life expectancy is on the screen, 76 for men and 77 for women. Here we have financing of the healthcare system from the budget. If you look here from 2011 till 2020, if in 2011 the healthcare system enjoyed 553 million of Azeri currency, by 2020 this figure increased 3 times. Threefold increase. We know that currently it is about the burden of non-communicable disease. In 1990, the key prevalence was with communicable disease. In 2020, major diseases for humankind, ischemic heart disease, diabetes, strokes, and for the healthcare system development, we need this following areas. Improved management in healthcare, improved public healthcare systems, investment in the human capital. Here it's a big role of the lifelong professional growth and medical education. This is access to key technology and pharmaceuticals, and of course medical services access. I would like to highlight that during the past years, the healthcare system in Azerbaijan is based on evidence. What is evidence-based medicine? This is a tool to close the gaps between the optimal medical practices and the existing one. The key task of which is to ensure high quality medical support for the population to improve the quality of life, life expectancy, and with efficient prevention purposes as well as a treatment. Now, very briefly, I would like to share some information about the state policy in pharmaceuticals from 1991 up to 2015. In our country, we did not have rigid government control and regulation of pharmaceutical. Prices were market regulated by distributors and drugstores. But in 2015, there was a decree of the president for the state regulation for the pharmaceuticals registered in Azerbaijan. Cabinet of Ministers identified the methodology for pricing. It's based on 5 benchmarking countries, and there was a limit of prices for the private pharmaceutical companies, and it was a limit set for the drugstores as well. Well, what kind of results it brought us? It has its own advantages and disadvantages. Advantages are that the generics market expanded and access for pharmaceuticals from Turkey, Egypt has expanded, but at the same time, for European countries and US products, the market has shrinked. Access to patented pharmaceuticals has also shrinked. In Azerbaijan, European companies are functioning less actively. Well, you probably know that the brands have higher costs, and it's not profitable to function in Azerbaijan for them anymore. They cannot compete with generics. Well, after the pandemics, from the state, there was a support for national pharmaceuticals, expansion of the procurement of pharmaceuticals, pharmaceutical supervision has expanded, rigid regulations for registration, and MA approved and FTA approved registration for such pharmaceuticals. There are no limitations for the import of such products. And of course, evidence-based medicine is the best approach for the decision making for specific patients' treatment. Public health care, based on the actual data, is an integration of the science-based approaches to improve the health of population. Well, in Azerbaijan, we have some elements of the evidence-based medicine. There are some tools, and some of them are the national clinical protocols. I would like to mention the national clinical protocols back in 2007. By the decree of the Ministry of Healthcare of Azerbaijan was mandated to our center of public health care and reforms from 2008 to 2015. For the kinesiologists, we drafted 91 clinical protocols, and after COVID, when our system moved towards the insurance-based system, the relevance of these clinical protocols has increased, and therefore, following the decree of our Minister of Healthcare, the existing protocols were updated, and at the same time, we started development of new protocols. And there is a basis of the science-based, evidence-based medicine in Azerbaijan, ENBGS, MD reference, and this basis and this database for data, again, based on the evidence. And very briefly about the programs of medical provisions in Azerbaijan. Currently, we have screening programs for newborns, and that is needed for early detection of metabological problems. If previously it used to be when diseases are identified, but now it's a broader list, and in the future we are planning to expand it further. Next, it's the program on diabetes, glucometers, pre-oral pharmaceuticals, insulin for patients with diabetes. I would like to highlight that these programs of medical insurance, all the costs are covered by the Agency for Obligatory Medical Insurance. We also have a national program to counteract chronic disease. We have hemodialysis system in the country, which serves 4,000 patients. There is a national program for the cancer therapy, and all the costs are covered from the government budget, because the Agency for Mandatory Medical Insurance yet cannot cover all these expenses, and the prevalence of oncology disease is more than 50,000 patients. And for the multiple sclerosis, we have a national program for the patients with multiple sclerosis, about 2,000 patients in the country. And again, using the insured medicine, we provide diagnostic tests and the first-line pharmaceutical products. We are also planning by May, as a pilot, for hypertonic for people with high blood pressure to organize free of charge drugs to manage hypertension. Those are the plans for the healthcare system of Azerbaijan. As for the HTA development in Azerbaijan, well, I want to say that we were planning for several years to take some steps in this area, but due to objective and subjective reasons, there were some difficulties associated with that. But right after the pandemic, in 2022, we had a conference on HTA. Rabbi Yahanam was also attending, and two international experts were also invited to Azerbaijan. We also had trainings on HTA, and later we are planning to within the public health faculty to train people for the economy of healthcare issues, and in the Azerbaijan Economic Institute to train human resources dedicated to this topic. Our center is currently being considered for restructurization. As the plan is that it will be restructured first as an institute, and probably we are planning to open a department on HTA in our institute or in the department for the standards of medical quality. But it's currently being discussed. That's all I had in a nutshell. Спасибо большое. И я должен отметить, что наблюдая за...
Because even during COVID time, this reform happened for introducing insurance and universal health coverage in a way. So I think that's something to be congratulated that it was done in such difficult, challenging times in Azerbaijan. So I want to move on to Uzbek and Kazakh experience, but before that I want to actually summarize something, something we all know actually about HTA institutionalization. So if you want to institutionalize HTA in a country, there are a few important things like the key elements, and without that it's impossible to be successful. And three of them, and during the day speakers mentioned several times, is political will, which is very important, the capacity, and legal framework. So there are many others, but if you don't have these three, usually even if you have other things, you just don't be successful institutionalizing. So for the rest of the session, we will keep it a little bit interactive, and please, from the audience, we can also take questions. Feel free to raise your hand and ask your questions. But I want to start with the legal framework, because some of our colleagues here mentioned, like Kyrgyzstan, they don't have the legal framework yet. Maybe in Azerbaijan, there's a little bit legal intro with the insurance system. And we know Kazakhstan has a legal ground for HTA. So I want to ask our next speaker, Zafar Vakidov. So actually, the audience knows you because you already spoke in the previous session, but Zafar is the partner at Vahidov and Partners law firm, and he can speak actually both Kazakh and Uzbek experience. But I want to ask you, mostly because we have limited share from Uzbekistan context, but can you tell a little bit about how the Uzbekistan context looks like with respect to HTA, and maybe a little bit reflect also on your legal experience, how important legal framework is, and how our life becomes more difficult without a legal framework on HTA.
Thank you very much. Sure, I'll be happy to, slightly more explore on this. Наверное, продолжу на русском, да? Основная...
I will switch to Russian. The key audience is Russian speaking. Well, in my report, previously I've already mentioned what is the situation in Uzbekistan like, but just to give a little bit of the context, what is happening in the healthcare system of Uzbekistan, probably some people might be interested to hear more about that. Well, overall, as I mentioned, regulation, it's not really detailed as in Kazakhstan in many areas. Sometimes it's an advantage, sometimes it is the disadvantage. Well, it's a gray zone wherever you look, but on the other hand, if it's not over-regulated, it gives some opportunities. Because very often we work with our clients in Kazakhstan and Uzbekistan, and we see that there are some ideas in terms of innovative procurement, very often about risk sharing, cost sharing, and the rules. For example, 2931 from SK Pharmacia, it is a huge publication, very detailed norms. That's great, actually. More regulations there is, less corruption there might be. So it's like a more clear playing ground. But on the other hand, sometimes in order to implement something, it turns out that there are a lot of things should be changed. This is one of the diversity factors. And in Uzbekistan, there are only the general legislation on procurement regulating the pharmaceutical sector as well. And probably it misses some aspects in relation to pharmaceuticals, medical equipment and devices. And in such rules, for example, to consider the aspects of HTA and even pharma economy is kind of difficult. And that's one of the aspects in the general context terms. Yes, there are some discussions on where to go, how to proceed, but it's not probably a secret. After many years of staying close with the previous president, now country is open, big speed of change and growth thanks to some reforms, in particular currency and tax reform. But the focus of the state is to develop economy, and issues related to healthcare, it's not a big focus yet, but we see that at least starting the end of the previous year, beginning of this year, there are a lot of regulations accepted, and it means that actually head of the government and the state are considering that, trying to develop it.
As previous speaker from Kyrgyzstan said, financing is not that big. And even though the country is not that big geographically speaking, nevertheless, the GDP is not too high. But nevertheless, we see that the population grows and GDP grows as well. It's an advantage on one hand. On the other hand, it is also a challenge. It is the task of the state to develop everything, to build economy, and then healthcare as well. And I would like to say that right now the structure of regulation of this sphere looks like that. There is a Ministry of Healthcare, and there is an independent agency of the development of pharmaceuticals. It used to belong to a different ministry, Ministry of Investment and Trade. Right now, it's not quite within the Ministry of Healthcare, but under the Ministry of Healthcare. The mandate is a little bit different, but it's a committee within the ministry. There is a different approach. It's not the regulator, but it's an important stakeholder to improve regulation. And of course, it's important to involve the investment in this area, and that improves the overall regulation regime. I also mentioned the Center of the State of Medical Industry and other processes. Right now, it is within the Ministry of Healthcare, but it used to be a separate agency. The Ministry of Investment and Trade is another stakeholder. And just like in Kazakhstan, we see an increasing role of the anti-corruption agency. And they participate in the price regulation, in the state procurement. They understand there might be some bottlenecks, but also room for improvement. And we know that an important role was played by an agency in Kazakhstan. So generally, we can say that anti-corruption agencies in our region are extremely important, and I'm sure their role will only become more and more important. We talk about healthcare, but when we talk about expert opinion of the medication or assessment, there will always be questions about the competition. Is the decision that's made by a commission enough within the area of competition? Whether certain privileges are justified? I'm not even saying about the intellectual property issues that are quite relevant in both our countries. So this is the overall context, but generally going back to HTA, there is no regulation as such, but cost effectiveness, return on investment, and other terms are mentioned. At the same time, there are no criteria how to assess these indicators when including the medication to the list of major indications. If we look at the protocol of treatment, then basically what we see is that the decision is made by the major experts of the medical institutions, medical facilities, and as far as we know, there is a reform in this area so that these decisions are made jointly. And I believe that if there is a mechanism that regulates different protocols, this would be a good time to consider HTA, or at least start with the pharmaceutical economy. This is the situation. And again, as I said, regulation may not be enough, but everything's changing rather quickly. We do study foreign experience, and Uzbekistan is quite open to that. We also study the experience of Kazakhstan and other countries. So we should expect that the regulation will change, it will improve, and hopefully it will lead to the fact that population will get access to these new technologies in healthcare, and that the market will become even more attracting, not only for retail, and retail is what we mainly have on the market of Uzbekistan. Yes, it is quite attractive, it's growing rapidly, but we see that the market share of the state procurements growing quite quickly as well. But if you look at the absolute numbers, it's not that big. So I believe that HTA will play an important role in this regard. Thank you.
Thank you, Zota. Thank you. It was a very, very good, for us, it helps understanding Uzbek context. And you mentioned a little bit about the leadership change and how it may affect also the landscape. I think it goes to the issue about political will as well, because political will also changes over time with leadership changes, and it has a huge impact on institutionalization of HTA and anything else. So I want to continue, Alima, with you, because Kazakhstan has a longer experience with HTA. As I will not ask you to summarize, because we have heard today from different speakers, so we have a better understanding of Kazakh situation. But I want to ask you especially about political will, because my personal experience is political will is important to introduce, but also equally important to sustain. So in all these years since you've been involved in HTA, what is your experience with the political will? So HTA being introduced, does it necessarily mean it will be sustained and equally be uptaken by all the decision makers? Or does it change over time depending on who makes the decisions? I hope I'm not challenging you, but maybe I will.
Oh, thank you, Rabia. I think this question is the hottest one, because a lot of factors are included and they influence on the situation in general. So allow me to complete my speech in Russian. So please, use your equipment.
Rabia, it's very nice to hear the high assessment of the fact that Kazakhstan is recognized as one of the leading countries in Central Asia as far as HTA is concerned. It's true that we've been doing that for a while now, and we try to develop a community of people who are committed to the principles and the pillars of HTA. Starting from 2009 or 2012, when I joined the project, HTA, and I'm talking about my personal experience, like you asked me, HTA is very near and dear to my heart. I felt that this is something that I've been striving for all my life. HTA is a set of principles, moral, ethical, when you try to be unbiased to any type of technologies or groups of patients. Moreover, HTA is a huge body of research and literature and techniques. So a person who works in HTA is a person who knows to work with information and who knows how to analyze the information and draw conclusions based on this information, again, without being biased. And you have to separate your own judgment and maybe change your patterns of behaviors or stereotypes or prejudices that we have acquired maybe from childhood or from parents or from society. It doesn't matter. So once I understood that HTA is not just a multidisciplinary work, it's also a philosophy of life. And if you can also use it in your own life and strive for this bar that is set so high, then I realized that it is a way of changing the mindset of society, starting from one person. So when a team of like-minded people, including the Kazakhstani Association of Kaspor, who is the organizer of today's event, we started putting together this team of like-minded people, carried trainings, different master classes, and articles, policymakers, stakeholders. We worked with clinicists, with the medical community. We started using different technologies to influence people's own marketing tools, neuromarketing, Facebook, social media. But unfortunately, it is still not enough. If we look at the country as a whole and its needs as a whole, even though Kazakhstan has a big territory and quite a low density of population, the country still has high standards of providing medical care. We buy 10 to 15 MRI per year. We also have different CT machines, but the question is, how do we use it? And the other thing I wanted to mention, colleagues from Kyrgyzstan, yes, we may be a small market, I don't know, it doesn't matter, 3 million, 720 is still quite small, but what about Scotland? Scotland has 5.4 million of people. It's a small country, yet they have elements of HTA. And sometimes they can even overthrow the decision of NICE. They say, no, it doesn't work like that. So maybe it doesn't depend on the size of the country or the size of the population. So I think I would like to outline another thing. Unfortunately, in Kazakhstan, the attitude towards the scientific research, especially when we talk about social research, multidisciplinary research, or marketing research, that can be part of the multidisciplinary research and economy, is not at the level that it should be. And this political will, and actually our policymakers understand this. When you explain everything to them, they understand it. And over these years, with our team of like-minded people, we introduced certain legislative norms into laws and bylaws, into the codes, but more often than not, it still has barriers in practice. So I hope that Alexander Kostyuk may add something to that. In his presentation, he has already mentioned it, and Talgat mentioned it, especially when he talked about the formulary system, which we have been developing since, well, I don't even know since which year, but still there is a lot to be developed. So all these issues remain. When I see this big society of medical experts, or health experts, it doesn't matter whether these are clinicists or not clinicists, I have a question: why don't we have convergence? And there was a question about convergence, which means that all approaches are the same. The whole world, the whole developed world, even those who use HTA, they have convergence, they get together, and unfortunately in our situation, we don't see the convergence, we see a divergence. Legislation works, everything works, but when you start putting it into practice, it turns out that the regulator of the medication works in one system and they don't understand what is being done in the other system. For example, the institute that is in charge of HTA. And then the market suffers, not only the industry that will lose the investment and they will not attract any more investment. It's also the patients who do not have access to this medication that we should have. So that is why I'm quite grateful to all the speakers for getting the feedback from many people. I also heard that we have very interesting keynote presentations that were quite informative. It was very useful, I hope, to all of us. And I hope that we could put together our insights and develop a joint position. We need to get together instead of going different ways, and we need to become leaders for that. Leadership is not when one person says, I am the leader. No, leadership means that you don't need to be seen and you're many, and all together you're working towards one goal. This is leadership. Thank you.
Excellent notes. Thank you for that. And actually, you covered many aspects beyond political will, legislation, but capacity as well. And as Alima mentioned, it may be the only element for this is not the size of the country, but other elements as well. So I want to go back to my Kyrgyz colleagues to ask further reflection on the landscape in Kyrgyzstan. So we have another representative of Kyrgyzstan, who is Mirbek Nishambayev. He's the head of Medicines Registration Unit, Department of Medicines and Medical Devices in Kyrgyzstan. So I want to ask you, maybe it's also about what Alima was referring about, perhaps collaboration in between different departments. So if we go back to these components with the political will, the legal framework, the capacity in the country, maybe engagement with universities and so on, but also international collaboration. So how do you see Kyrgyzstan has opportunity to increase political will to further institutionalize HTA? Because for the legal framework, I see, we say we need to have legal framework, but in order to push legal framework, also you need political will. But also, it's not just lawyers can sit down and write the legal framework, you still need capacity. And that capacity sometimes comes from universities, not within Ministry of Health. So how do you think you can collaborate with universities plus departments in the Ministry of Health and maybe use this as an opportunity to sensitize politicians? Do you have experience or any reflections on that?
Thank you, Rabia, for your question. It's true that HTA in Kyrgyzstan has some foundation. We're now trying to use some of the elements of HTA when choosing certain medications that may be on the list of some critical medication of the Kyrgyz Republic. We also try to use HTA or its elements when including medication into the list of the critically important medications. And if we look at the level of the regulator or regulation, so registration of the medications, we will see that HTA is a very important component that enables us to assess different aspects, as it has been mentioned in the presentation. Whether this medication is valuable, useful, to be included in different lists that are to be procured through the public procurement, for example, in order to cover the needs of orphan diseases or to cover other needs, maybe of patients with hemophilia, etc. So this is a very important aspect, and collaboration between different agencies, departments within the ministry and outside the ministry, and cooperation with academia, society, of course, plays a huge role for the development of HTA in our country and Kyrgyzstan in general. In Kyrgyzstan, we have a rather strong patient community and civil society in general, so the personnel, the capacity, all of that is there, I believe, and we can keep working in this direction.
And as for the shortage of some pharmaceuticals, of some medicines related to, for example, during the COVID times or post-COVID, due to the reasons that, yeah, that wasn't a problem, that the population was small, that some of the big players might be leaving the market or anything. Probably it's not related to that only. It's mostly due to the fact that big pharmaceuticals and producers might believe that if government can pay for such medicines, some like not genetics but actually branded products for the treatment of well, if even we look at some of the oncology treatments. Well, may I also add a little bit here? I would like to support my colleague and to say that actually Alima was right. This association it's a good momentum which helps us, and we initiated to develop and for the political decisions, it's in our hands, in this team, how they present their analysis, which will be helping in dealing with the HTA. Political perspective is quite good. Now it will be mostly depending on us, and it's a very strong team now. Now, if some additional developments are done, some points should be strengthened. And in terms of the clinical protocols and guidelines, it's a good already development. And new clinical aspects, it's already going on. And even to reiterate, some patients' community even initiate adding new technologies. Sometimes they give us such a task, like to include some of the pharmaceuticals, and we then look at the database, we look at the efficiency, and so on and so forth. Well, I believe that for potential, and it's a good initiative, but of course, we should be looking at the potential, look at some methodologies, instruments, and tools, and so on and so forth. Okay.
Thank you very much. It's interesting to see actually the political will in this area is also increasing. And I do remember I went to Kyrgyzstan for some trainings on guideline development. It was like 7, 8 years ago. And I did see the interest of experts and the dedication and already ongoing work. So I think that's a very big asset for the country to have that expertise already and the political will. And what is interesting, what I could capture from both of you, you referred to patients several times, and patients' voice is strong in Kyrgyzstan. So I think it's very unique, because I've seen many countries that patients' voice is not heard. So I think it makes it very unique, and with patient engagement, it's promising for the next steps. So I want to come back to Azerbaijan. And I want to ask you about the capacity, because we were, some of us actually as HTAI, we were in Azerbaijan 2 years ago, and we did deliver also trainings, and the university was very interested. The university actually hosted the trainings. So can you tell us a little bit about the need for capacity? How do you see Azerbaijan's capacity in HTA? But not only the existing capacity, but more about interest in improving the capacity, because you mentioned it very slightly in your presentation, but maybe we can hear more about the future of young HTA experts, let's say, in Azerbaijan.
In my presentation, I mentioned part of it, how we see development of the sector. Well, once again, let me reiterate that we don't have human capital yet in terms of the economists in healthcare. First and foremost, it is about healthcare economics, and especially for as public health students in Azerbaijan National University, and under the Economic Institute, and also for the healthcare management. And the issue about establishing a new department for the HTA is at the stage of discussions. We are currently negotiating. We will see, of course, but first of all, we are planning to establish this department and to attract leading experts to ensure activities of this department. It's about fulfillment, but again, I cannot share details on our vision for the future development of HTA. And time will show, but we need experience, of course. We need to learn from others. And unfortunately, it's not an evolved area yet. And we will base that on the experience of other countries. We will learn from the lessons of the others.
It's a very interesting discussion. So we heard experiences from Kazakhstan, Uzbekistan, Azerbaijan, and Kyrgyzstan. So what is common? Everything is in transition. It's always improving. Never something is like, okay, I'm here, achieved, everything is done. No, it never happens. So it's always recognition of the need for improvement. So that's what we see in all the countries. We also see that in all the countries, even if it's developed in HTA, there's still need for further improvement of the capacity. Legal frameworks are always in transition. That's what we understand from Zafar as well. It's never complete. You always work on the legislations and updating it. But legal frameworks in these countries also need to be improved. But what I want to conclude, as all the speakers mentioned, Alima very nicely put it, I can't say it as nicely as her, but collaboration is key, international collaboration, learning from each other, sharing the experiences of ours, not always about the success stories, but also failure stories. They're very helpful. And always to be open to this kind of collaboration in between countries, whether it is regional collaboration or beyond the region, learning and inspiring from other parts of the world as well. So I want to thank each of you. You stayed all the way until here and heard our stories that comes from many different countries, so I can speak for all today's meeting. So I think it was inspiring, it was fruitful meeting, and thanks for staying all the way until here. And I want to thank all the speakers in this panel, very openly sharing how the landscape is in their countries, and saying clearly that they're open for collaboration and they're open for learning and improving systems and be a part of those reforms in their settings. So I want to give the floor, before I close, I want to invite Alex to say the final words. I think we deserve a closing remark from you. When he's coming, I also want to have some applause for our speakers. So Alex, on behalf of HTAI, I also want to thank you, Alima, and others involved in this meeting, organization. So you are the host, we are just guests here. But for HTAI, it was a pleasure to collaborate with you, to support the event, and to have a little bit of our contribution as speakers and agenda building. It was really, I think, other speakers can also confirm who are here on behalf of HTAI that it is also a very good experience for us, and we learned so much from each other, and we learned so much from the representatives of the region, and thank you for giving us this opportunity to be here with you.
Rabia, thank you for your warm words.
Thank you very much for these warm words. So actually today's conference, which will be continued tomorrow for half a day, and we will have more detailed and more interesting discussions. And this was thanks to the huge support from HTAI. For Kazakhstani counterparts, I would also like to say that we appreciate all your contribution. It's a teamwork. And this is the top of the iceberg, Ragia, Talgat. For the ERI also, we would like to thank them. And I believe that it is about the technology, and Kazakhstan is already working on the HTA from 2009 and in more active perspective from 2011. More than 2,000 people were trained in clinical protocols and regulations. Unfortunately, as a minimum, I'm sorry, we can say that now it is about not only quantity, but also about quality. And we feel proud about that, because any system is supposed to bring. And today, some things are already considered, others needs further improvement, but it was really great session we had today, where we discussed the regional perspective in the context of Central Asia and Caucasus. Well, actually, what the countries can be proud about, first of all, this is the resources, human resources and financial resources. And of course, here we need to find the model for HTA to meet the interest of the country, and it is about starting this process and then, you know, like having the twins and some of the challenges. For the final session, of course, many people say that they have a shortage of human resources, but human resources appear when the country is trying to develop something, where there is political will, political support, and that's number one. And Kazakhstan trained some people already, for example, and unfortunately, it's also about turnover, with many people coming and going. And this is about it's about internal training programs, analytical cooperation. It's about collaboration, and that allows us to learn, to get better, especially for newcomers, to learn from more experienced counterparts, because it's the best experience. And I believe it's a very good thing, and so on and so forth, to be part of this whole system. Well, because it's this regional level. It's about providing support and evolving, because it's a joint problems we are trying to tackle. For the clinical part, of course, we can work together, and I believe that everybody in this audience understands that it's not about avoiding all the economic mishaps, but of course many countries actually feel that for all post-Soviet Union countries it is about lack of some professionals and specialties, economists in healthcare, and professions which exist, the medical ones, for the measures. In our countries, we actually have also historically, unfortunately, that is how it is going on. In post-Soviet Union, healthcare is evolving, but economists are not really interested. But there are experiences abroad as well. We can use as a role model some competences that should be evolving. I hope our today's conference, thanks to the support from HTA, will be a basis for further development. Well, I would like to thank again our colleagues from HTA for such a great support, methodological, in our region. We feel that you are paying all your attention to us, and I would like to wish all of us a productive sessions tomorrow.
Уважаемые
Dear participants, that is the end of our conference, day one. Thank you very much. We really appreciate all our speakers. I would also like to thank all the speakers who participated, who came from on behalf of the HTA. Would like to thank Professor Garrison, who came from United States, Mark Marchetti, who came and joined this Eva Turperol Egalipsk, Rabia, first and foremost, as a chairperson who had this idea. Let's give a round of applause to each other. Thank you very much.
Самое главное, вы приехали.
Да.
I propose in our session.
Like all the